Bronze skin pigmentation is seen in Addison disease, Marfan syndrome, scleroderma, polymyositis. Congratulations, it's a correct answer. Team D. Swan neck deformity is seen in psoriatic arthritis, osteoarthritis, rheumatoid arthritis, or gouty arthritis. Very good. It's a correct answer. Team E. Dance sign is a characteristic of gastroesophageal reflux disease, intussusception, volvulus, or diverticulosis.
No negative marking.
It's a wrong answer. I'm sorry. Anyone from the audience? Yes.
Right answer.
Very good. It's a right answer. Can we have a applause for the audience? Anyone else? Okay.
Now question for the audience.
Chagrin patch is characteristic of psoriasis, pemphigus, mycosis, or tuberous sclerosis. Very good. किसने बोला?
ग्रुप में मत बोलो, अमन 5-6 रख लो, वही दे देना.
Can we have a chocolates? Now we move on to the second round.
Now we move on for the second round. It would start from the team E. First question would go to team E. Okay. The rules are this round is transferable. Okay. There is no negative marking, but you have to answer within the first 30 seconds. If it transfers to the next, they have to answer within the next 15 seconds. Okay. If they can't answer also, the first answer would be considered final. Okay. Transfer. The full direct answer would fetch 10 marks, and the passable answer would fetch 5 marks for the correct answer. Clear? Okay.
Okay, I would request the audience, please don't prompt or anything. And we'll start with Team E first.
Team E ready?
Okay, the rules are it has got 10 marks. It is a transferable round. And when the question is transferred, you will get half marks of the 10 marks. And you will get 30 seconds, the parent team. And when it is passed on, you will only get 15 seconds. Okay, so let's begin. Question 1. So what is this logo stands for? Team E. Very good. Team D. Next question. It transfers to the next team, Team C. Wrong. Water availability, wrong. It goes to the next team.
Specific
Anything?
or specific?
I think we should pass it to next team. Next team. I don't.
So 5 marks to team A. This is the eyes on diabetes, which was
This logo is Eyes on Diabetes.
okay, not exactly diabetic retinopathy. It is for diabetes awareness. It is a logo for the World Diabetes Day. Next question to team C.
Can you again?
Sorry, wrong. Pass to the next team B.
Team B. Wrong. Team A.
You have to be specific. Any further answer?
Half.
Next,
Next.
team A. Team B. So 5 marks to team A. It is the
National Organ and Tissue Transplantation Organization.
logo of the
NOTO.
NOTO. Okay. 5 marks to team A. डायबिटीज नहीं है, वो पूरा आयन डायबिटीज बोलना था. You have to don't argue first question. First, I am saying please don't argue.
Okay. So we move on to the next question.
Full form. 10 marks to team B.
Team B. 10 marks. It's a correct answer. We move on to the fifth question.
Fifth question for team A.
Team A. Very good. Correct answer.
आयुष्मान भारत और प्रधानमंत्री जन आरोग्य योजना. ठीक है. Now question for the audience. Please say the marks at the end of.
Can we have a big round of applause for the teams? Yes, now we go for the question for the audience.
ठीक है.
Meanwhile, they are calculating their scores. We can have the audience question.
Audience question. Identify the logo. Correct. Well, बाद में जाएगा चॉकलेट. अच्छा है. Next question. What does logo signify?
Anyone? Please raise your hand.
Anyone? So this is the logo of the primary healthcare first, which was first adopted during the Alma-Ata conference. So this is the during the 1978. This is the first logo, primary healthcare.
So we are ready for the scores after round 2.
The team A is got the maximum marks, 30 marks. And rest all other teams have the total marks is 10. सर इनको 5 नंबर दे दीजिए इनका ओ अच्छा ये सर सॉरी ये वो पेन okay after the round 2 the team A is on top position. After that is team B who have the 20 marks and rest other have the 10 marks.
Please be seated faster. No prompting from the audience, okay? So moving on to the next question for team B. Identify this famous doctor public health couple. Both are doctors. Q, okay. They are the pioneers of maternal and child health among the tribal communities in Gadchiroli, Maharashtra. They run an NGO in the name of Search and awarded Padma Shri in the year 2018. Even if you give the surname, you will get only one name also you will be getting marks. No negative marking, you can attempt. Anyone from the teams?
Or audience.
Audience? Very good.
Chocolate for
Bhai, ye chocolate. Achha, ye. Now direct question to team C. Ready? Identify this famous personality. Q. Okay. Doctor whose name is synonymous with oral rehydration therapy due to his immense contribution in developing this life-saving solution. ORT or ORS, whatever you say. Saurabh, time. Ramakant Mishra, no, he is a cardiologist. Raman Panda, at least. Any other teams can answer? Audience? Mobile se nahi dekh raha na? So he is Dr. Dilip Mahalamaris, who has worked extensively in the West Bengal and Bangladesh region, saving millions, saving most of the lives due to the ORS. Yeah, 2 years back. So now question to team D. Ready? Identify this personality. Q. Okay. Eminent Indian pediatrician and worked as the WHO chief scientist till recently, known for her immense contribution in TB and HIV in India. She is Dr. Soumya Swaminathan, now working as in the think tank of the Indian Health Services. So 0 marks to team D. So now direct question to team E. Ready? Identify this famous personality. Q. He is a famous Indian doctor and politician in whose memory we celebrate the National Doctors' Day. Anyone from audience? Right, sir. Dr. B.C. Roy or Dr. Bidhan Chandra Roy. He was also the Chief Minister of West Bengal. So, please, Prakash, please, scores at the end of round 3.
At the end of round 3, Team A is leading with the score of 30 marks. Team B has 20 marks. And Team C, D, and E all have 10 marks.
So now the audience question. Identify this famous Indian woman personality. Huh? Yeah. जोर से. Dr. Anandi Gopal Joshi. She is the first female doctor of India trained in Western medicine. 2 doctors, Dr. Anandi Gopal Joshi and Dr. Kadambini Bose Ganguly, are the 2 first female pioneer doctors in Western medicine from India. Now, next audience question. Identify these personalities. They are the winners of Nobel Prize in 2023 for discoveries concerning nucleoside-based modifications and their implementation in mRNA COVID vaccines. हाँ? क्या जोर से? Anyone from the audience? नहीं क्या बोल रहे थे वैसे? नहीं ये लास्ट नोबेल प्राइज है 24 का नहीं आया अभी तक. So they are Kathleen Carrico and Drew Weissman, both from USA. Okay, awarded Nobel Prize in 2023. So next audience question. Identify this famous personality. He has worked.
This is given in books, sir.
Wrong. The correct answer is already been given by sir. He is Dr. Ronald Ross, a British doctor who carried most of his work in India and was awarded Nobel Prize for his work on transmission of malaria and isolation of Plasmodium vivax, and he got the Nobel Prize in 1902. Okay. Now we move to the round 4, which is a basically current affairs round. Now I hand over the mic to Dr. Raman.
Good morning, everyone. So I will be taking you through the next 2 rounds. I think numbers so baras rahe, so we need some breaks and more gears to decide our winner for today. So taking to you next round. So our next round is
We want to start from
Team E.
Team E.
So next we have rules for the. So this is a current affairs round, non-transferable, and 10 marks for the right answer. No negative marking. So Team E, your question is, the recent outbreak of acute encephalitis syndrome in children in Gujarat was caused by which virus? A. Hantavirus, B. Chandipura virus, C. Ebola virus, D. Nipah virus. Your time starts now. Answer is? No negative marking. Answer is? Kindly name the answer. That is the right answer. Big applause for them. So it is named after the place where the cases were first found. Chandipura is a place, is a village name from Maharashtra. 10 marks for Team E. So the question for Team D is, this virus causes a disease that is endemic in Africa, and the World Health Organization has declared a public health emergency of international concern recently for this. So your options to name the virus are A. Nipah virus, B. Mpox virus, C. Ebola virus, D. Hantavirus. That is the right answer. 10 marks to Team D. Team C, your question is, what is the name of the toxin that is found in unripe lychees that was linked to acute hypoglycemic encephalitis in malnourished children of Muzaffarpur, Bihar? A. Toxicodendron radicans glucosidase, B. Methylene cyclopropylglycine, C. Lycic acid, D. Cyanogenic glycosides. Your time starts now. Kindly name it. That is not the right answer. Anyone from the audience? Sir? That is the right answer. Applause for sir. So, direct question to Team B. In 2023-24, Kerala reported an outbreak of which viral disease that raised concerns due to its potentiality for severe complications? A. Crimean Congo hemorrhagic fever virus, B. Nipah virus, C. Ebola virus, D. H1N1 influenza virus. That is the right answer. 10 marks to Team B. So coming to Team A, your direct question is, the expansion of Ayushman Bharat Pradhan Mantri Jan Arogya Yojana for elderly of all strata is using what age cutoff? A. 60 years, B. 65 years, C. 70 years, D. 75 years. That is not the right answer. So some newspaper readers from the audience. 65 तो उन्होंने दे दिया and we have told that it's not right. Huh? Answer is 70 years. That is the right answer. So 0 marks for Team A. So we have come to the end of 4th round now, and the scores are.
At the end of round 4, Team A and B are leading with the score of 30, followed by Team D and E with the score of 20, followed by Team C with the score of 10 marks.
Big applause for all the teams. We have neck-to-neck competition here. And we also have an audience question for this round. So, which COVID-19 variant has recently been a focus of concern due to its increased transmissibility and the potential to resistance to vaccines? A, alpha variant, B, delta variant, C, omicron variant, D, epsilon variant. So, oh, whole audience deserves a chocolate this time. So that is the right answer, omicron variant. Huge applause for the learned audience here. So moving to the next round, and to trying to spice up the things, we have make it a movie round. So medical movies for all the movie lovers. So all the movie lovers, here is a round in which they can score and come ahead. So still a lot of scope in this quiz to change the scores. So this time, this is round 5. So 1, 2, 3, 4, 5. Team A will be starting. Team A से start करेंगे. So to start with Team A, your question is, no negative marking, not transferable. No change of answers is accepted. The theory of everything, Stephen Hawking, is diagnosed with which neurological condition? A, amyotrophic lateral sclerosis, B, multiple sclerosis, C, muscular dystrophy, D, cerebral palsy. Your time starts now. Please, no prompting.
From the audience, be quiet.
That is not the right answer. So we have some movie lovers in the audience. That is the right answer, A, amyotrophic lateral sclerosis. Theory of everything. So, movie to watch for Team A. So, coming to Team B, your question is, a beautiful mind, which mental health is portrayed through the life of mathematician John Nash? A, depression, B, bipolar disorder, C, schizophrenia, D, anxiety disorder. That is the right answer. 10 marks for Team B. So coming to question for Team C. In Pa, Oro suffers from which rare genetic condition? A, Alzheimer's disease, B, progeria, C, Down syndrome, D, cystic fibrosis. That is the right answer. 10 marks for Team C. Coming to Team D, your question is, in My Name is Khan movie, the main character Rizwan Khan has which condition that affects his social interactions? A, schizophrenia, B, autism spectrum disorder, C, bipolar, D, post-traumatic stress disorder. That is the right answer. 10 marks for Team D. Coming to question for Team E. In the movie The Fault in Our Stars, which medical condition does the main character Hazel Grace Leicester struggle with? A, diabetes, B, cystic fibrosis, C, cancer, D, asthma. That is not the right answer. Computer ji give 0 marks to Team E. So we have some answers from audience. Cystic fibrosis, that's the right answer. So we have come to the end of 5 rounds and the score is, computer ji, score final करके round 5 के end पे बताइए where the teams stand.
At the end of round 5, Team B is leading with 40 marks, followed by Team A and Team D with 30 marks, followed by Team C and E with 20 marks.
So there is neck-to-neck competition still going on, though there is some change in positions. So still there is lot of scope as the last round is rapid fire, where there are lot of numbers to score. So before going there, We have audience question for this also. In the film Tare Zameen Par, dyslexia. So that's why we kept this as the audience question. So what type of cancer Irfan Khan was diagnosed with in 2018, to which he succumbed later? Answer is neuroendocrine tumor. That is the right answer. So now handing over mic to Soumya sir for rapid fire round. Sir, here.
अच्छा ठीक आप उसको ये कर राइट रॉन्ग ना बोलो ना It can be either right or wrong, but if you say pass, you can come over to the next question if you are within the stipulated 1 minute time. Okay? No negative marking. Each question carries 5 marks. So here you have a 40 mark window to play with. Okay? So let's start. Team E. So coming to the rapid fire round, Team E. So these are the rules. Each set carries 8 questions. Each question carries 5 marks. Total time 60 seconds, 1 minute. First response is considered final. If you have to pass, you have to say that instantaneously so that we can move to the next question. Unless and until you give an answer or pass, I won't be moving. Okay. The options are either you have to say the answer or say pass. If you say pass, I will be moving to the next question. Okay. So ready, team E. Expand RBSK. Right. When is World Patient Safety Day celebrated? What was the theme of World Mental Health for 2024? Where is National Institute of Immunology located? A patient has unilateral facial drop, difficulty closing one eye, and loss of taste in the anterior 2/3 of tongue. Which cranial nerve is most likely affected? Correct. Macrolides target ribosomal 50S subunit. True or false? Correct. The cobblestone appearance of the intestine. Please come again. Crohn's disease. Correct. Please let me answer ask the question. Then, what is the antidote for iron toxicity? Disperance. So, wrong. World Patient Safety Day. So, good performance by Team E.
5 right answers.
They gave 5 right answers to 25 marks to Team E. So this is a great level around. Try to do your best in this, okay? So Team D, ready? Team D, here are your questions. Expand MAMA. Correct. When is National Nutrition Week celebrated? Correct. What is the theme of World Cancer Day 2024? जोर से बोलना, ठीक है? हाँ. A 35-year-old man presents with weakness of wrist extension and wrist drop. Which nerve is the most likely injured? Correct. Aminoglycosides are primarily concentrated dependent or time dependent antibiotics interaction. Where is National Institute of Virology located? Correct. The stipple sign on a lateral neck X-ray is indicative of which condition? Right. Which antidote used for acetaminophen or correct. You missed the questions. Theme of World Cancer Day 2024. Wrong. One question. Time's up.
6 right answers, 30 marks.
Very good performance by Team D. Team C, ready? So here are the questions for Team C. Expand ABDM. When is breastfeeding week observed? What is the theme of World Rabies Day 2024? Where is National Institute of Occupational Health located? A patient with carpal tunnel syndrome presents with weakness in the thenar muscles. Which nerve is most affected? Correct. Domperidone is a D1 receptor agonist. True or false? Correct. Great Anna sign is seen in which medical condition? What is the antidote of lead poisoning? Incorrect. Wrong. 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 So ABDM is Ayushman Bharat Digital Mission, August 1st week, breaking rabies boundaries, which is incidentally today, September 28, the World Rabies Day. Ahmedabad, NIOH, median nerve, false, acute pancreatitis, great Anna sign, and the antidote is DMSA. Okay. Now moving on to
2 right answers, 10 marks for Team C.
we can have more claps. So now direct the question is for Team B. Ready? Expand INP. When is World TB Day celebrated? What was the theme of World Health Day 2024? Where is National Institute of Epidemiology located? Wrong. A 50-year-old woman reports difficulty in elevating her shoulder. On examination, she has weakness in the trapezius muscle. Which nerve is likely involved? Wrong. Quinolones act by inhibiting RNA synthesis. True or false? Right answer. Homan sign is a feature of which medical condition? Correct. What is the antidote of benzodiazepine overdose? Correct. I will imagine. Your answer, expand INP, World TB Day, theme of Wrong. Wrong.
Time's up.
So INEP is Intensified National Iron Plus Initiative. March 24 is TB Day. The theme of World Health Day 2024 is My Health, My Right. National Institute of Epidemiology, Chennai. The nerve is accessory. Quinolones act by inhibiting RNA synthesis. Falls by DNA synthesis. Homocysteine DVT. Benzodiazepine overdose. IV flumazenil. So, बता दिया आपने?
15 marks.
So now direct questions to team A. Ready? Expand, Suman. World Hepatitis Day is observed on. What is the theme of Patient Safety Week 2024? Where is National Institute of Nutrition? Correct. Which nerve is primarily responsible for the sensory innervation of the posterior one-third of the lung? Correct. Carbapenem's mechanism of action is inhibiting cell wall synthesis. True or false? Correct. Auspicine is seen in antidote for opioid overdose. Correct. Correct. ऊपर 3 का we give it to you. And next, fast and 2 questions.
Now it's time for a score. The team A and team D is on first position. Then team B will have got the 55 marks, followed by the team E who have the 45 marks, and at last the team C who have the 30 marks. So now this is a tie for team A and B. टीम ए और डी सामने आ जाओ. हाँ बस. This one is working.
Hello, yes. So we have 4 questions for tiebreaker. tiebreaker will be conducted in 2 plus 1 plus 1. So 2 questions in first go. If we have tie at that end, we will have add on 1 question. Again tie, we will have 1 add on question. This is how we have made this tiebreaker. So rules are simple. To begin with, we have team A and D here for this tiebreaker round for the winner position. So we will start with team A for the first question. If they answer rightly within the 30-second frame, they will get 10 marks. If it is passed to the next team, they correctly answer it within the next 15 seconds, they will get 5 marks. And the second question will be started with team D, and similarly 30 seconds, 10 marks, and not answered well, going to you. In next 15 seconds, you are getting 5 marks. So best of luck for this tiebreaker. So, आगे चलिए आप
नहीं नहीं आप
Team A. So your question for the tiebreaker, Team A, is identify this logo. No negative marking. Wrong. Team D. That is the right answer. 5 marks for Team D. Team D. Your question is, a child presents with failure to thrive, eczema and recurrent infections. What condition should be primarily suspected? Options are A. Cystic fibrosis, B. Severe combined immunodeficiency, that is SCID, C. Digeorge syndrome, D. Celiac disease. That is not the right answer. That is the right answer. 5 marks for Team A. Again, we have a tie here. So, going to the next question. So, now these are non-transferable. And the one who answers will be declared the winner. तो दोनों क्वेश्चन करते हैं but non-transferable. So both teams can answer. They can raise their hand. So whoever answers will get the winner position here. हाँ. So we have a tough tie here, requiring third tiebreaker question. So the question is, what is the main characteristic of borderline personality disorder? Options are A. Excessive need for approval, B. Emotional instability, C. Grandiosity, D. Fear of abandonment. That is not the right answer. Team D, if you answer it correctly, you will be the winner today. Your time starts now, 15 seconds. No, even that is not the right answer. So, answer is emotional instability. That is the main characteristic. So, moving to the last tiebreaker question. So, the one who answers wrongly will get -5, hence will make our job easier, I think. So, now they will have to decide even more firmly about their capacity to answer even. So, दोनों answer नहीं देते. Oh, please don't give them more options, sir. It's already a tough condition for us. So, coming to the fourth tiebreaker question. In Something the Lord Made, groundbreaking surgical procedure was developed by Alfred Belloc and Vivian Thomas together for which condition? A. Tetralogy of Fallot, B. Atrial septal defect, C. Ventriculoseptal defect. D. Patent ductus arteriosus. That is not the right answer. That is the right answer. So we have our winner for today. Congratulations. It was a tough tie. And I want to congratulate Team A also because they did a wonderful job and gave a tough competition to Team D. And I also congratulate the other participants who make it through to this final round. We know we had 16 teams participating for the, actually 18 teams participating for the preliminary rounds. So these were the final 5 teams who had us here today for the last 1 hour. Mind-boggling questions and their answers who even made us our job difficult to judge the final round. And I'm so proud to have you people here in our final 5. Thank you.
So winner नाम winner declare कर दीजिए first, second, third.
पेपर है ना?
हाँ.
नेम्स के साथ लिस्टिंग उस पे बोलो उनको स्कोर बोलने दीजिए
एक बार स्कोर बोल लीजिए.
First, second, third बता देना.
Okay, the team D is the winner with 70 marks. And the runner-up is team A, who got the 60 marks. And the third position is with team B. Thank you to all the participants.
First is team
D. D, A, and B.
Call them on stage. We have prizes ready here. What is the sir? आप declare कर दीजिए with the names. उधर बुलाना है.
बुलाना है क्या करना है?
उनके
हाँ बुला दीजिए.
जब कैश प्राइजेस आएंगे
फर्स्ट
तो
थर्ड को बुला लेते हैं. थर्ड कौन है मैम?
सर ये लिख दिया मैंने. ये थर्ड है. ये मैंने लिखा हुआ है.
थैंक्स कर देते हैं बाकी.
हाँ जी.
हाँ.
So everyone has enjoyed. I think the rounds were very exciting, very interesting, and tiebreaker में भी हमें तीसरे चौथे राउंड में जाके हुआ. So you can see the competition was very tough and rounds were very interesting. So I would like to take this opportunity to thank our quiz masters. So and other team members. So Dr. Anupinder, आप इनके लिए तालियां बजाइए थोड़े से. Dr. Anupinder, Dr. Ramandeep from pediatrics, Dr. Soumya Sahu from community medicine, and our 2 SRs, Dr. Saurabh and Dr. Prakash. So please give a big round of applause for them also. And now we will announce the winners. And I'm thankful to the organizer.
Thank you, Dr. Kakkad and his team. I think this is first time in history of Bathinda that Dr. Kakkad and his team has organized such a beautiful and intelligent, academically oriented quiz. And most importantly, there was a tie break. So finals का मजा तभी आता है जब ऐसे ही आसानी से नहीं जीतता कोई. So I must congratulate every one of you, and we will, from the organizing committee, we will request you to be present tomorrow for felicitation program from 11:30 onwards to receive your appreciation certificates. So it is great to have a faculty, such faculty to promote academics, because we have encountered a few faculty who are against academics, but we really appreciate your presence. And now I'll request Dr. Vinder Singh, who is amongst us, to come on stage, and no better person than him to give away the prizes. Dr. Sonia Arora, please. And my friend, Dr. K.K. Goyal, to please come on stage to give prizes, because he was supposed to be the genius of our batch. And I am really thankful that he has come all the way from Sarsa to attend the conference. And that shows कि अभी इसका एकेडमिक कम नहीं हुआ है, इवन एट द एज ऑफ कितने साल का हो गया. सो प्लीज आप टीम के साथ ही आ जाइए जी, आके आओ. टीम के नाल आ जाओ जी सारे. कक्कड़ साहब आप साथ में, आपके बिना कुछ नहीं होने वाला. So Dr. Vinder Singh is a great scientist from ICMR, and this year he have got appreciation from the government as well as scientific community for research purposes. So I think Dr. Ashu nahi aaye ji. So Dr. Ashu is also here. She is also from ICMR, and I'll request all the students who can spare their time. एक attendance absent लग जाएगी तो कुछ नहीं होना. But you will not find opportunity to listen to the galaxy of speakers whom we have invited, and they have taken their time out of their busy schedule to address all of you. So those who can spare time, जिनका एग्जाम है वो चले जाओ, बाकी को मैं रिक्वेस्ट करूंगा कि बैठो, एक दिन की अटेंडेंस से कुछ नहीं होने वाला, राइट. एंड पीपल हेयर विल थ्रेटन यू ऑल्सो कि एब्सेंट लग जाएगी, ये हो जाएगा, वो हो जाएगा. प्लीज रजिस्ट, because this is a lifetime opportunity to shake hands with scientists. मैं भी इनसे हाथ मिलाता हूँ कि यार कुछ ना कुछ अकल इनसे ले लूँगा, वो कंडक्शन होती है ना. So that is how these things should go. Now I'll invite the winners of first prize. थर्ड को पहले बुलाना है तो आप बुलाइए. थर्ड प्राइज.
Please, Marita and Ansika, please come on the stage.
पीछे पीछे हो जाइए थोड़ा. हाँ, सीटियां भी मारो यार. So you should encourage academics, not discourage academics. नहीं नहीं आप करवाओ जी. Great.
Now, second prize, Ishan and Urvi, please come on the stage.
आओ जी के जी. ना ना एक लिफाफा तुम भी देना यार. नहीं 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 इसको दवाना लिफाफा, एक एक लिफाफा दवाना. So thank you very much. Great performance. Now the first prize.
Now the winners, please come on the stage. Hargul.
Congratulations. वो यार ताड़ियां मारी चलो यार. सवेरे सवेरे हजे तो ब्रेकफास्ट किया होना है, एनर्जी पूरी होगी. Great going. And now I invite all the second and third prize also. Please come on stage to have a group photograph. पांचों को बुला लो जी, आ जाओ. Everybody comes over stage. So definitely that shows the attitude of Dr. Kakkad कि इन्होंने बुला के दूसरों को भी इनकरेज करने का काम किया है. प्लीज कम. आगे बैठ जाओ आप बेशक.
बल्कि हम लोग चाहते हैं कि बाकी जो 17 टीम्स ने पार्टिसिपेट किया था उनके लोगों के लिए भी तालियां हैं.
So we will give them appreciation certificates to all the members of the preliminary teams also who have participated in quiz. थैंक यू वेरी मच. ग्रेट गोइंग. आप बोलना चाहते हो कुछ? नहीं नहीं आपने तो सारा कुछ किया यार. आप फिनिश करो ना यार.
Yes. सर वो है नहीं, कुछ पार्टिसिपेंट्स है, बाकी है नहीं. A sincere thank you for all those who participated in the quiz, not only the finalists, but also the preliminary round. A total of 18 teams participated, and it was very encouraging to see participation from the 2023 batch also. Okay, and I am glad to say that the only team which participated in the from the 2023 batch, they didn't come last. Okay, the best thing is participation. You will get your, I would say, appreciation with time. So I would encourage everyone to further participate in quizzes in large numbers. There would be 1, 2, or 3 winners, but participation is best. Okay, thank you.
I hope everyone enjoyed this process. That is the most important thing about quizzes. We learn and we love the procedure, the way it is done. And I also want to tell that quizzes are not the highest level of examination which assesses your academic learning. But here we mix things up the way, and the questions are different caliber. You may think that it was easier or difficult for the other one, but it's a little bit of luck and definitely a lot of academic learning which is judged here. So don't be disheartened, anyone who thinks that they know others' questions at the end of quizzes, it happened. So I want to say that all of you did well, and the numbers show there are so many scores. Score sheet is so high scoring match it was, and that tells that you people were doing really well. And we were the quiz masters, but you were the masters of 17 subjects we study in MBBS. So that's a lot of big deal to appear in a quiz that is catering to all the subjects of the field. And I want to congratulate all the participants and the winners of today. And also to the teams who take this stage to the tiebreaker. So we had no questions spared. We had to show all our cards to decide today's winner. And it was really great to go to that extent. Thank you all.
मेरे लिए कुछ बचा नहीं है बोलने के लिए, but I would like to applaud all my students. So let's say hip hip, louder, hip hip, hip hip. ए खाना खिलाओ यार, एक बारी और. Hip hip, great.
Thank you all.
Now we will start our routine scientific program of third day with the first lecture. So formally, I'll request again the students who can sit, they should attend a few lectures, then they can go. Otherwise, no, it is okay.
Without further ado, let's start with the first presentation for the today. Our first presenter is Dr. Sambhu Datta, HOD Medicine, Intensive Care and RCU at St. Anne's JM Hospital, Visakhapatnam. His topic is Management of Acute Febrile Illness in ICU ER. Please, sir.
Hello, thank you. Slide is changing. My heartfelt thanks to Professor Dr. Bithul Kumar Gupta sir and ma'am for inviting me in this great scientific feast, and Today, my topic is basically acute febrile illness in emergency room ICU. This was actually presented in MAPICON Eastern region in Cuttack, Orissa. And after subsequently, I met sir in a Bhubaneswar World Diabetes Congress. And after that, I told that this will be a good topic. So without delaying, I think sessions are late, so I can start. So we know that acute febrile illness in emergency room and ICU becomes difficult when a resident or house surgeon or a PG student gets the case of acute febrile illness who has got organ dysfunction. Not that all the fever cases are dangerous. Few of them, they present very cynically and becomes dangerous. So what we should do? So we know that humanity has the greatest three dangers: fever, famine, and war. And of the war, we know I was from army, so initially, so I was in Kargil also, but still, I'll still say fever is much more dangerous than the war, because you don't know what to deal with. Most of the physicians at the end of the day, when they deal with fever, they get always confused that whether what is the diagnosis and whether treatment is correct or not, especially in acute presentation with organ dysfunction. So definition, fever in ICU is basically a single temperature of more than 101 degree Fahrenheit or 38.3 degrees centigrade as per American College of Critical Care Medicine, also IDSA. Acute febrile illness, it's same, but if it is more than 2 days, this is our AIIMS Delhi guidelines. Also nowadays we are calling it acute undifferentiated fever. There has been a recent surge in the patients presenting to emergency department with acute febrile illness or AUFI and with multi-organ dysfunction syndrome. This has come in our 2016 Journal of Clinical Diagnosis. Epidemiology, we'll be discussing little bit. That is basically pan-India. If you see dengue all over India, it is going very high. Earlier malaria was the main, but now malaria incidence is reducing and dengue is increasing. Other than that, scrub typhus, meningitis, malaria, pneumonia, leptospirosis. While preparing for this, I studied little bit about Punjab, when we saw that especially southern Punjab, which is this part of Punjab, has got much more Plasmodium vivax. Unfortunately, in Visakhapatnam, where I stay, Orissa, Visakhapatnam, Jharkhand, this part where I see a lot of patients, more of falciparum or malignant malaria we see, less of vivax. And even if we are getting nowadays vivax, most of the vivax malaria are very complicated vivax. Earlier we are not getting complicated vivax. Nowadays vivax has become very virulent and it behaves just like falciparum. That is another thing. So basically, as per the API guideline, fever we are now managing with syndromic management. Undifferentiated fever, fever with rash or thrombocytopenia like dengue, and even sometimes chikungunya also. Fever with joint pain like chikungunya or sometimes dengue. Fever with acute respiratory distress, ARDS. Okay, we have seen recently COVID, and fever with encephalopathy. With a lot of viral encephalopathies or bacterial encephalopathies, and fever with multi-organ dysfunction. This is very important, and mostly we handle them in ICUs or emergency room. So acute undifferentiated fever, how we will approach? The approach will be like either malaria, first do a rapid diagnostic test kit, RDT malaria. If it is malaria, good, you can manage as per the protocol. If it is non-malaria, then it can be viral or bacterial. So you have to see all the things as per the chart: arbovirus, influenza, bacteremia. It can be zoonotic, it can be hepatic amoebiasis, amoebic liver abscess also we see. And what are the differential diagnosis? There is a long list DD of acute febrile illness. Like you have to divide like rash with shock, rash and conjunctivitis, and the diseases are there. Rash with diarrhea, rash with bully like Vibrio vulniferous gas gangrene. Gas gangrene is very common in army setup, especially bullet injuries, they get into gas gangrene. And similarly, catheter related infection like patients who are on CV catheter, dialysis catheter or pacemaker, they get a lot of time. So this chart you should just see. And fever with ARDS with tropical disease, leptospira very common, especially in the bigger urban cities like Bombay. I was there, lot of leptospira happens after monsoon. Okay, you know that it's basically rat is the transmitting zoonotic this thing, and they have 2 phases, 4th to 6th phase. You will have first a milder phase, then there will be a gap, then patient will come with acute liver failure or acute kidney injuries. So, and many of them die, almost 51% death rate in the leptospirosis, and they require a lot of time mechanical ventilation. Malaria, we know that falciparum malaria, it can cause dyspnea. Within hours, patient can get into ARDS very fast with all the complications of malaria like black water fever, acute kidney injuries, acute liver injuries. Scrub typhus, Nowadays, lot of scrap typhus we are seeing in both Andhra, Orissa, okay. And earlier it was most of a military disease, sub-Himalayan, most of the army troops, they used to get scrap typhus. Now it has gone into pan-India, Bangalore also a lot of cases, okay. So it can cause all sorts of organ dysfunction like myocarditis, encephalitis, and you know that doxycycline is a drug of choice, excellent drug, works nicely. And enteric fever, nowadays also we get complicated enteric fever, especially in Delhi region, the travelers from Delhi, drug resistant, this thing. And dengue fever, we get headache, rash, myalgia, arthralgia, and retroorbital pain. And acute dyspnea can happen in dengue and followed by ARDS. That is very important. That is why acute dengue fever, we must see the respiratory rate and saturation every 10 to 15 minutes. We should measure the saturation. It can go down anytime with ARDS. So this is the fever with encephalopathy approach. This is a basically Journal of Physicians of India, JAPI journal, and this is the guideline which is basically there. You can see it. And this I do very commonly. Many times we don't get a CT scan before doing lumbar puncture. So if you have an ultrasound, we use extensively ultrasound and echo in our ICU. Okay, so what we do, suppose we don't have a CT and we have to go for a lumbar puncture and we suspect that there may be a rise in ICT, intracranial tension. So what you do, just put your probe on the eyeball and you can see as clearly the diagram. Just below the eyeball, that 3 millimeter below, if your optic nerve sheath diameter is more than 5 millimeter, it is 94% sensitive and 87% specific of ICP rise more than 20 millimeter. So be careful. If you are doing a lumbar puncture, do a guarded lumbar puncture. That you know how to do guarded lumbar puncture. So these are the red flag signs with acute undifferentiated fever or acute febrile illness in ICU. So if patient has got prostration, patient has got hyperpyrexia, which is very common in this tropical season, especially this part. In armed force also we get a lot of hyperpyrexia, heat stroke we call, classical heat stroke or exgestional heat stroke, both. Respiration is very important if patient has got shortness of breath or saturation less than 92. And if you see the circulation failure like capillary refill time, very sensitive and very easily you can do capillary refill time. If it is more than 3 seconds, good. Okay, if it is more than 3 seconds, not good, prognosis is good, no, not good, and capillary refill time for poor setup is very good. And neurological altered mental status, abdominal pain, if any dengue patient with abdominal pain is definitely a dangerous sign, we should admit that case. Jaundice on examination of sclera, petechial rash, bleeding from any of these nose, gums or any site, venipuncture site, again it shows that there is coagulation abnormality. These are all red flag signs. So this is basically a clinical chart. History of the patient and meticulous examination is very important. Examination of all the systems in acute febrile illness is very important. So this we cannot emphasize more. Disease-specific clinical profiles we should see. Like if you see the first case detection by Dr. Arun from Kerala, with the first patient only, he could diagnose, he could suspect it is Nipah, and subsequently when the test was done in virology lab and confirmed at Bangalore, NIV at Pune, it was found to be the first case of Nipah. And Dr. Arun and team, they got a lot of awards also for that. And we must have a national database like USA and UK have, so that if we put all these atypical cases to the national database, the other doctors will be benefited by referring it. So, and we must use point of contact test. This recently I was presenting in South Zone MAPICON, like here. Last week it was South Zone MAPICON in our Vizag, comprising of all South states. And there I presented the point of contact test in fever, that is newer biological markers for diagnosis and prognosis in acute febrile illness. That was my talk there. So here I must emphasize that point of contact tests are very good, especially when the physician is alone in a small setup where you don't have much backup. Then point of contact test along with this rapid diagnostic tests are very important, which are PCR based, which are now made in India. I will show you. Some important investigations, this you can just see, arterial blood gas, rapid diagnostic test as I told, and 2 sets of culture you must take from 2 sets from different venipuncture sites, then ultrasound, then focus, that is focused ultrasound to diagnose where is the problem, CT chest and abdomen. And nowadays in all ICU admissions we are using Apache 2, SOFA, QSOFA, News and Muse course. QSOFA is not very much favored with the current guidelines of critical care. So this is the made in India tropical fever panel kit. It is only 1700 rupees and it should be used by most of the ER and ICUs because this really helps to diagnose dengue, chikungunya, plasmodium, rickettsia, salmonella, West Nile, Zika and leptospira instantly. results within 35 to 45 minutes you get. And this is a PCR based case test, so it is very good actually. And it is Indian. This is the other one, BioFire. This is a French company which makes, and cost is almost 25,000 rupees. So, but this can detect almost 16 tests, okay. But many of them may not be used in India, like Marburg, West Nile. So I prefer true PCR kit. In armed force, we use true PCR kit. In bigger hospitals, command hospital, we have in ICUs BioFire system, but this is costly. So protocolized treatment is always better rather than going haphazard treatment. This was also discussed in Surviving Sepsis campaign in 2021 by International Society of Critical Care Medicine. And ARDS we should handle by Berlin's definition. KDIGO guideline we should follow. Thrombocytopenia, platelet neutrophil ratio, neutrophil lymphocyte ratio. I must emphasize neutrophil lymphocyte ratio. NLR is very, very good. It is just simply one differentiated DLC count, differentiated leukocyte count you take. With that neutrophil versus lymphocyte, you take the ratio, and that is very important, going to give you prognostic markers. Similarly, lactate, procalcitonin, these are also very important, especially lactate when you are resuscitating patient in shock with sepsis. If a lactate rise is poor prognosis, procalcitonin is excellent for both diagnosis and prognosis. When you are treating a case of PEO, you don't know whether it is bacterial, viral, do a procalcitonin. If it is less than 0.2, then you can think that it is probably non-infectious, some other cause, maybe rheumatological other cause. Okay, procalcitonin, prognostically very important, because whenever you are de-escalating with antibiotics, you want to de-escalate, then you use a procalcitonin, excellent marker. And you must remember, procalcitonin does not go to the bloodstream as such. In a healthy person, there should be no procalcitonin. Only when there is a sepsis, procalcitonin is getting secreted, and that goes to the system. This I was talking about neutrophil lymphocyte ratio. This is very important. This is, I call it NLR meter, neutrophil lymphocyte ratio meter. When the neutrophil versus lymphocyte, you get around 9 to 18. Like suppose your neutrophil is 90 or 80 and your lymphocyte is 4 or 5, it is a bad prognostic marker. This was extensively proven in COVID time, and also in dengue fever also we see very good results. So just do an NLR and serial NLR every day. If you do, you can really know your patient is progressing or not. ARDS, we follow this ARDS protocol, is Berlin protocol. We all know that when your PaO2 by FiO2 is less than 300 in X-ray bilateral opacities, and you know that is non-cardiogenic failure, then you can, this is KDIGO guideline for kidney injuries. This everybody knows, that's KDIGO stage 1, 2, 3 failures, and how to manage AKI. Okay. But remember, AKI, we should not jump for dialysis or renal replacement therapy. Recently, 10 days back, my mother had diarrhea, post-diarrhea acute renal failure. I brought her to Vizag from Bhubaneswar, and I thought she may require dialysis because she was her creatinine was going up till 6, but still we prevented. Now she is in 2, creatinine 2, doing well. So that is my next in Calcutta MAPICON. My talk is on ARF, management of ARF, whether we should do dialysis or not. That I will be going in MAPICON Calcutta. So what we do, fluid resuscitation in ICUs, we usually use lot of non-invasive tests, whether the patient is fluid responsive or not responsive. If you are giving too much fluid, especially in sepsis or dengue cases, most probably you will overload the lungs and heart with lot of fluids, and patient will have frank pulmonary edema. So that is why there is lot of trials, but there are trials which shows that when we give bolus fluid versus restrictive fluid, and with the protocols like ultrasound and IVC diameter, still the difference of survivability is not much. You see this graph, overall survival between standard group where you are giving too much fluid, or between restrictive where we do hemodynamic management and fluid, the total outcome at the end of days like 30 or 60 days is not much. So this is what I do extensively in my ICU. In most of the cases when I give fluid, I just take, when I give fluid at the end of 1 or 2 hours, I put the probe, ultrasound probe on the lungs, see the A lines. A lines are nothing, they are basically rib, your own, this patient's rib, which gives a artifact. If you see these A lines like horizontal lines, that means the patient's lung is dry. Moment you get B lines like torchlight like shadows, moment you put the ultrasound probe, you get lot of torchline like shadows, that means it has got fluids. You must stop giving IV fluids. This is the basic thing we do to see the fluid responsiveness. And this is what little advanced. If you have a little bit of training, you just see the inferior vena cava, IVC. Just put the ultrasound probe on the right side of the chest, that is to see the liver, and you can clearly see the horizontal inferior vena cava, and put your meter like the M mode meter, and you see the distance between IVC during systole or diastole. That is the largest diameter. You can see the right side picture, the largest diameter of IVC and the least diameter of IVC. Divide it. And if the percentage is more than 12%, you can give fluid. That is fluid responsiveness. So this is what in my ICU I am doing a IVC assessment while giving fluid. So similarly, when you see patient is hemodynamically unstable, whether you see this patient is fluid responsive or unresponsive. If fluid responsive by all your tests which I told, then give fluid. If unresponsive, then you do other tests like lactate, skin mottling, differential PCO2, SCVO2, they are very good markers, and you give accordingly fluid challenge. Okay. So point of care ultrasound fluid resuscitation guide is very, very interesting and very important nowadays. We cannot bypass ultrasound in ICU. That is why I always, wherever I go, I recommend that we must follow the blue protocol, or all the ICUs should have ultrasound, or most of the trainees should be very good with the ultrasound. It's a very low cost machine. My ultrasound is a made in China ultrasound, because I work now after ARNI in a missionary hospital. My ultrasound is only 1 lakh rupees. And last 7 years I am working with this. It has got eco probe also. And even DVT also with a flat probe we can rule out. So it is very important. So this is just, I have already discussed A line and B line IVC parameters. So these are all important. So initial resuscitative therapy is the cornerstone. Initially we must give IV fluid. Saline is still best. If you get balanced crystalloid, then it is good, but most of the ICUs we are using salines. Then empirical antibiotic, there are many confusions. Many old professors, they say that don't use antibiotic unless you are very sure. But as per ISCCM guideline, patients should get antibiotic within 1 hour. And either beta-lactam antibiotic or a beta-lactam BLBI or a carbapenem should be the choice of antibiotic within 1 hour, and within 3 hours you send the blood for culture. And lot of trials, Merino trial in 2018 has told piperacillin tazobactam is not inferior to carbapenem, because piperacillin tazobactam is much cheaper. Now of course generic carbapenems are there. I have a doubt whether generic is that good or not. I don't use generic medicines much because I had bad experience in armed forces, because government is now forcibly giving us generic, which is not good. So when the patient requires renal replacement therapy, you can go with a peritoneal dialysis. In resource poor setting, when in different military hospitals I was alone and there was no CRRT facility, I have done lot of peritoneal dialysis, and we got saved many patients with peritoneal dialysis alone. If you have, now we are using CRRT, so we do CVVH also. So, but I told you as the example, if you are doing too early, there are a lot of things in AKI where you should go, where you actually get a hyperkalemia, or your pH of the patient is less than 7.1 despite of best of the therapies, all these conditions, then only you should go for renal replacement therapy. Otherwise, conservative approach, try to address the defects, AKI will resolve within 3 to 4 days. So acute liver failure, nothing much. Basically, acute liver failure is organ specific. You try to save most of the organs, and hemodynamics patient will recover if he has to recover. There is not much of thing in acute liver failure management. Steroid therapy, this I must tell that Surviving 2021 guideline for adults with septic shocks and ongoing requirement of vasopressor therapy. If vasopressors you are using all 2-3 dobutamine, adrenaline, noradrenaline, everything you are using, then you can go with vasopressors, corticosteroid, hydrocortisone or methylprednisolone, but quality of evidence is moderate. Severe dengue, as of now, the AIIMS guideline which Delhi we are following, they have told not to use steroids, but I am against it. Recently in AIIMS Bhubaneswar also we had a big fight with my friend HOD medicine, and we in SCB also we all supported that we should give steroid, and even Dr. Bhalla sir, who is here I think present, I saw his name is there, he also in Chandigarh in Midwa study, he has recommended that we should use steroid. He has used 1 gram of methylprednisolone in acute febrile illness or severe dengue patients. It really saved a lot of lives. So I am in favor of using steroids in severe sepsis. Heat trial acetaminophen, it did not statistically made any difference, but patient will be pain free if you are giving IV paracetamol. So management part, this is my favorite. This actually came from Journal of Physicians of India, JAPI. They have published a book on acute febrile illness. Muruganathan sir, Professor Muruganathan sir has actually authored that. And here doxycycline is a very good drug in acute undifferentiated fever, the first line. Actually, I also use, because doxycycline covers most of the viruses also, bacteria, and many of the things it is drug of choice, like scrub typhus, and in falciparum malaria, along with falcigo, you have to use doxycycline. As per recommendation, you have to use 2 drugs because falciparum has got a lot of resistance, especially complicated Vivox also. When you are using IV falcigo, you must use doxy also along with that. So this is a case study, acute reversible heart. I got a case of acute reversible heart failure because of acute mitral regurgitation due to acute scrub. Patient suddenly desaturated. When I did the NICO bedside, severe MR was there. And we started with steroid, Defidox, that is doxycycline. And this case was presented in Asia Pacific Intensive Care, Singapore. And ISCCM also I presented this case in ISCCM 2020. And in SITSCON also. So there are some questions because PG students are not much, so there is no point. So Susugamosi triangle is this triangle where the Susugamosi, that is scrub typhus, is very much dominant. And well-Felix test, these are all basically MCQs not required. So this I wanted to show. This I had a quiz question also on this, that lychee fruit in UP and Bihar. This they call in Bihar and UP chamki fever. So this is a encephalopathy ward, acute encephalopathy ward, you can see. So there was, till now it is a, actually nobody knows. Though we discussed in the quiz, the lychee fruit contains MCPG, which we told. But actually, whether it is a JE virus, because when they actually did PCR, they got 17.7 JEV scrub and dengue also. So this is another interesting case, hemophagocytosis. Nowadays, very much interest. Most of the API and tropical disease CMEs, they will have one speaker at least on hemophagocytosis, macrophage HLH diagnosis. So this basically clinical features of fever, splenomegaly, hepatomegaly, lymphadenopathy and confusion will be there, and that is basically hemophagocytic syndrome. And the classical this thing is rise in ferritin. So but rise in ferritin, we must remember that can also a very good clinical diagnosis for adult onset Still's disease. AOSD also actually one of the thing is ferritin. However, this is very important. Rarely we get such cases, and you didn't get any infection, any lab culture, everything will negative, and this patient goes into very rapid course and usually dies. So life saving is steroid. So my last slide is 9 commandments, take home points in acute febrile illness in ICU RECs. Detailed travel history is very important. Patient, what food, drink, animal contact, very important. Sexual encounters, vital link. Local epidemiology pattern, we must know. Complete detailed physical examination. Point of contact of blood, urine, fluid test, including the newer PCR kits you should use. Okay. And time is life, most critical. Fastest and accurate diagnosis is vital. Syndromic management is most important. Aggressive fluid management. Early antimicrobial or antibiotics, airway support, cooling measures, management of acute kidney injury, liver injury, coagulation disease are very important. Communication with the next step. This is where we fail. Most of the time, we keep the patient in ICU or emergency room. We don't talk with the relatives. And after some time, there is some problem. We know that it comes in the newspaper. The doctor. I also faced this, but we have to talk in between, or we have to send some representative, our paramedics who can go from the ICU outside and talk to the relative. Patient is in this condition and these are the probability of survival. We are doing this. So communication with the next of kin about the disease severity outcome is very, very important. Especially patient comes consciousness with high grade fever. After some time he will die with ARDS. So they will shout and create problems. So we must address those issues. Rare diagnosis rarely correct, as our professors used to tell, that may not hold any good anymore nowadays, especially with such international traveling, international people are migrating. So you can have some zoonotic, any other disease at your emergency room or ICU suddenly, and you cannot, you should be like Dr. Arun Kumar, who actually got the Nipah fever diagnosed very fast. I was posted in Kerala that time. So Jai Hind and love from Vizag. This is the only 3-dimensional navy of India where we have nuclear submarines, we have got stealth class warships and aircraft carrier, all 3 and are there in Vizag. So anybody who will come to Vizag in any of the CMEs, most welcome, and definitely we would like to have you there. Thank you.
Thank you, Dr. Datta, for an excellent talk. It is a very tough topic, acute febrile illness, especially in ICU. You are in dilemma what to do, because in ICU, the patient is already in a moribund condition. So over and above, febrile illness complicates any disease. So thank you very much. If there are any questions.
Most of the modern ICUs, we see that they quickly insert central line on the first day itself. So what is your thought on this?
Actually, sir, there are a lot of papers on this. Actually, I was also, when I was doing training also in base hospital and Safdarjung, I was also, my favorite this thing was central line. And then I used to put with that IV saline bottle only, we used to put the poor setup and we used to see the CVP. But of late, CVP is not a this thing because there are a lot of conditions like right heart conditions can give a false CVP, rise or fall. So nowadays, CVP as the predictability of a real fluid response is only 70%. The best thing is still now, the easiest thing is ultrasound guided USG, or you can do a fluid challenge test with leg raising test or physiological leg raising test, or you can give 100 ml of bolus fluid and see with an ultrasound the IVC refill and changes in the LV output. These are better markers. Though I also still CVP. My basically when I work in casualty, if I get a call, I go to casualty, put a CVP, put a Follies, give lot of fluid. If urine comes, that is best. I am happy and auscultate the lungs. Still I go by that. But in a conference academically, I must say that that is not as good as that. But in resource poor setting, we have to do this. CVP, Follies catheter, and a stethoscope with bilateral lung creeps. Good fluid marker. I mean, you can save the patient. Even most of the critical care guidelines, when teachers also say that first give lot of fluid and then take out the fluid later with diuretics. So that is best, because if you are early phase, if you don't give fluid and antibiotics, chances that you may lose the patient. Yeah, actually role of platelets in DIC is very less actually. Now the current recommendation is almost gone. I am also nowadays, I used to give, now I am after all this conference, attending ICMR guidelines and all, I have almost left now giving platelet. Even less than 10,000 I am not transfusing because it increases more antibody mediated killing of the platelets. So I don't give platelets anymore unless patient has got, even if dengue we get lot of cases every day. That is our bread and butter of most of our hospitals in Andhra. So dengue, what we do, we wait. Even if it is less than 10,000, I do a bleeding time, clotting time, and I repeatedly do the tourniquet test. Put the blood pressure cuff, inflate more than 10 millimeter of systolic, wait, and then see the peteches, count the peteches. I still do it, and that is a better marker. And I don't give platelet. I am very restrictive of platelet use. Thank you, sir.
Thank you, sir, for sharing this information with us. Now, I would like to invite Dr. Rohit Kapoor, Director, Carewell Heart and Super Specialty Hospital at Amritsar, to present his thoughts on SGLT2 inhibitors in heart failure. Sir, please come on the stage.
Where is that slide changer? So that is there. This is next, and this is we can't do. This is for next. This is for that. Okay. Thank you. Good morning, everyone. And first, I would like to thank Dr. Vittal, my friend, and organizing committee to invite me for this fantastic conference. So my topic of today is SGLT2 inhibitors in heart failure. So I'm not going to talk about what are SGLT2 inhibitors and their mechanism of action. So I'm going straight. Heart failure is a major public health problem. It's associated with significant healthcare cost worldwide. More than 64 million people suffer from heart failure, and you imagine the cost, 346.2 billion. Majority of the costs they are linked to the inpatient care and hospitalizations, specifically rehospitalizations. So there's a shift in the presentation of different types of heart failure. The global burden is increasing across the ejection fraction spectrum, while the prevalence of heart failure reduced ejection fraction HFrEF is remaining stable or declining, but heart failure with the preserved ejection fraction prevalence relative to the HFrEF is increasing at a rate of 1% per year. So HF-PAF is likely to become the most common type of heart failure. Heart failure poses two major challenges which greatly affect patient lives. Heart failure is the leading cause of hospitalization in US and Europe, and 8 days is the median length of stay after hospitalization, and frequent rehospitalization, they are accelerated path to mortality for patients. So 30% of patients, they reported low physical activity, 59% difficulty with one or more daily activities, and 63% of patients age more than 60, they report symptoms that are consistent with depression. So it's a growing public health problem with high morbidity and the mortality. You imagine the burden, and it's a number one cause of hospitalization in patients more than 65. And you imagine 5-year mortality rate for patients with heart failure is 50%. And mortality significantly increases after each heart failure readmissions. And this is when we called heart failure reduced ejection fraction less than 40%. Mid-range or mildly reduced ejection fraction is a 41 to 49% ejection fraction, and preserved ejection fraction when it is more than 50%, with some objective evidence of cardiac structure and of functional abnormalities consistent with presence of LV diastolic dysfunction. So changes in LVF occur over time, and they are associated with specific patient characteristics. Like heart failure, HFrEF can go back to HFMRF, can go back to HF preserved ejection fraction, and the same way it may deteriorate from HFpEF to HFrEF. Mortality risk remain urgent and life-threatening for heart failure patients. You can imagine here, in hospital mortality is high after acute decompensation. 1 in 5 patients will be re-hospitalized within 30 days of a hospitalization admission, and poor outcomes driven by the frequent non-CV deaths, particularly in the heart failure preserved ejection fraction. You imagine the 5-year mortality is around 50 to 75%. So each hospitalization will bring the patient to closer to the death. Why these slides are so important to understand that it's a very serious problem to understand. Very early diagnosis of heart failure is very important to diagnose and start as early as possible GTMT treatment in any heart failure case. So what are the goals of pharmacotherapy for patients with heart failure? That is, we want to reduce in mortality, the prevention of recurrent hospitalizations due to worsening heart failure, and improvement in clinical status, functional capacity, and quality of life. So there is urgent need to optimize evidence-based prescribing at every possible opportunity. And you can imagine, if you see this big grid on the right hand side, only 1 in 5 heart failure reduced ejection fraction, they are treated with the GDMT. What is GDMT? Is guideline directed medical therapy, and the number of HFpEF patients that are receiving GDMT is even very lower. And you see we are having a drug like SGLT2, ACE or ARB-MRA, beta blocker, then ARNI, you can imagine. HFrEF case with diabetes or no diabetes, and then down is HFpEF cases with diabetes and the no diabetes. Why this bar diagram is showing that how many percentage of the people they are receiving this respective drug. Improving outcomes and quality of life of patients with heart failure, they are fundamental treatment goals. We want to improve functional status, improve symptoms, decrease mortality, and decrease hospital readmissions. We are having 2 large multi-center international randomized placebo-controlled clinical trials. They provide evidence that dapagliflozin is one of the SGLT2 inhibitor, is effective across the range of ejection fraction. So we are talking 2 trials. On the one side is DAPA-HF, left hand side, right side is DELIVER trial. We are talking about these 2 trials sideways. DAPA-HF 4,744 patients, and in DAPA-HF we had patients who had ejection fraction less than 40%. In DELIVER trial we had ejection fraction more than 40%. So, and their elevated NT-proBNP and definitely eGFR was more than 30 in DAPA-HF trial, and here DAPA declared DELIVER trial, it was eGFR more than 25. So it was 1:1 randomization.
So this is a pivotal study assessing DAPA-HF in HFrEF, and this is delivery's largest and broadest trial to date in patients with ejection fraction more than 40%. So this is then it was a final that prescribed Foxiga is a brand name of dapagliflozin to significantly reduce your patient risk of CV death or the worsening heart failure. You imagine in DAPA-HF trial 26% relative risk reduction of these primary events like CV death or worsening heart failure. And what is happening in deliver trial 18% relative risk reduction of this CV death or worsening heart failure. And this number is not small to understand. It's a very big number and very fantastic number. And there's another one questionnaire was there which is self-administered instrument for patient with heart failure that quantifies a broad range of health status domains. The questionnaire measures patient perception of heart failure impact across 6 domains like physical function, symptoms, symptom stability, social limitations, quality of life, and self-efficacy. After in this study, this KCCQ questionnaire was important. And you can provide your heart failure patient with rapid and sustained symptom improvement by prescribing dapagliflozin. So DAPA significantly improves symptoms as measured by these KCCQ across all clinical significant domains like physical limitations, quality of life, and social function. DAPA-HF trial shows benefits were seen as early as month 4 and sustained at the 8 months. You see, the drug is so effective that you are finding so many good effects very early. And deliver trial, they show benefits as early as 1 month and sustained at the 8 months. They're not a simple thing. I mean, some drug you're prescribing in any heart failure and you're finding so many good results. There was no attenuation in the benefits or DAPA on symptomatic improvement in those with LVF more than 60%. So only DAPA consistently reduces the risk of hospitalization for heart failure or CV death for your patient across the range of ejection fraction, whether the patient is of HFrEF, HFMRF, or HFpEF. All ranges of ejection fraction, dapagliflozin is really fantastic molecule as SGLT2 inhibitor. And there is no evidence of attenuation regardless of the LVF. There were previous trials, they have shown attenuation of effect at higher EFs like empagliflozin. Digitalis was not good found, ARB, ARNI, or MRA. All these drugs, they have shown attenuation of effect at higher ejection fraction. They were found in this some of the drugs in the HFrEF reduced ejection fraction. So dapagliflozin significantly reduces your patient risk of CV death across the ejection fraction range, 14% relative risk reduction. That's not a small number what we find with these SGLT2 inhibitors. Rather in the last few years, in the last 15 to 20 years, SGLT2 inhibitor is only the fantastic drug which have shown such a benefit on the cardiovascular mortality. So no benefit in CV death and with AMPA. If we talk about other SGLT2 inhibitor, we are having 3 like DAPA, AMPA, and canagliflozin. So we are not talking canagliflozin as far as heart failure is concerned. That's very renal safe drug. But what about empagliflozin? And many times this question arises, DAPA versus AMPA. AMPA, it has not shown any benefit in CV death even in the pooled analysis. So DAPA is the first and only SGLT2 inhibitor with mortality benefit in patients with CKD with and without type 2 diabetes. You imagine these trials, they had even non-diabetic population. So here was a question many times. They asked me, I mean, Dr. Kapoor, if DAPA is given to some non-diabetic person, is there any danger of hypoglycemia? I say 0. There is no danger. You can prescribe very easily to non-diabetic population because these trials, they are non-diabetic population. So in CKD with or without type 2 diabetes, you can imagine 31% relative risk reduction of all-cause mortality with this dapagliflozin. So European Society of Cardiology recommends now SGLT2 inhibitor as a first-line therapy for patients across all EFs to reduce the risk of hospitalization, heart failure, or CV death. You imagine HFrEF, HFpEF, or HFMRF, sorry. So DAPA and AMPA, they have level of evidence is 1A, 1A, 1A. And that is really fantastic. That's now after so many years, we have a drug which is a fantastic as far as the non-diabetic population. You are going to write down with much of the benefits in all ejection fraction. We don't have any drug for heart failure preserved ejection fraction in for the last so many years. Now we are having, we can say we have a drug which we can prescribe in heart failure in preserved ejection fraction. SGLT2 inhibitors, they are a core therapy for heart failure reduced ejection fraction, should be initiated as early as possible as a pillar of comprehensive guideline directed medical therapy. This is 2024 ACC expert consensus pathway decision. SGLT2 plus ARNI plus MRA plus beta blocker evidence base. This is GDMT, 4 drugs. They are the pillars of HFrEF, and you can imagine, but there is algorithm to show like somebody is not okay with the volume overload, you can add loop diuretics. Then somebody is not resistant heart failure, you can add hydralazine or isosorbide dinitrate combination as solazine. And when the heart rate is not less than 70, the patient is in sinus rhythm, you can use ivabradine. And when the patient is on very resistant heart failure, you can add Versequat. All these drugs, they are available. We are using it. The latest is Versequat. It's a fantastic molecule. We are adding to our resistant heart failure reduced ejection fraction cases. And what about in preserved ejection fraction? Talk about SGLT2 is a really drug. In a reduced ejection fraction, we have 4 drugs. But in preserved ejection fraction, the only drug is SGLT2 inhibitors. And you can add loop diuretics if there is a volume overload. And for the woman all ejection fraction, you can add MRA. And for women, men with the LVF, and add ARNI. And for ARNI eligible who cannot take due to cost, you can add ARB. This is a very important algorithm to understand in the HFF case. So the time to rethink heart failure management is now. Groundbreaking heart failure guidelines reflect how DEPA can protect your patients across all EFs. And with the GDMT, you can reduce your patient risk of CV death across the EF range, give your patient symptom improvement and improved quality of life, reduce your patient risk of hospitalizations. So heart failure guidelines, they are for the first line treatment in the HFrEF, reduce ejection fraction, start 4 GDMT, then there is again you can add diuretics or MRA as indicated. So what are the opportunities to significantly reduce the burden? DEPA is indicated in adults for the treatment of symptomatic chronic heart failure. It offers simple dosing, 10 mg OD. And these are the DEPA has well studied safety profile. We don't find any much of the adverse events. They revolutionize heart failure management in your practice. Prescribe DEPA to all eligible patients. Drive the change by encouraging GDMT adherence and supporting multidisciplinary working to help optimize care for heart failure patients. Provide guidance to multidisciplinary teams such as those with nephrology, endo and primary care to consider introducing DEPA in symptomatic heart failure patients across the range of ejection fractions. And now study in patients with all ranges of ejection fraction. DEPA is proven to reduce hospitalization episodes, proven to improve symptoms that limit their lifestyle, and only SGLT2 with clinical evidence from multiple studies that it reduces the risk of death for patients with heart failure or the CKD. Must be my last slide. Thank you very much. Yes.
Thank you, Dr. Rohit. This is real important to discuss SGLT2 because SGLT2, as it was introduced, now the therapeutic horizon is widening for SGLT2 and supposedly being given in almost each and every condition regarding metabolic diseases.
Yeah,
so thank you very much.
Thank you very much.
For the audience information, Dr. Rohit Kapoor is a celebrated, speaker, famous practitioner from Amritsar. Thank you very much for taking out time to attend MAPICON out of your busy schedule. We are really appreciating your presence.
Thank you.
And acknowledging your endeavor to promote MAPICON. Thank you very much.
Thank you
if
very
there are
much,
any
Dr.
questions?
All right. Thank you.
So
Thank you, Dr. Vittal.
Thank you very much.
Thank you for your insightful presentation, sir. Now we'll move forward with the next presenter, Dr. Gagandeep Quatra, Additional Professor and Head, Department of Pharmacology, AIIMS Bathinda, on her topic, Exploring the Relationship Between Antimicrobial Resistance and Climate Change.
So again, I must thank Dr. Saab for choosing this topic, because antimicrobial resistance is supposed to be the now public health issue. And in presence of climate change is also a burning topic, as well as antimicrobial resistance. So thank you very much for apprising us. You will apprise us about antimicrobial and link to the climate change. Because we are also publishing a book, that is Pollution and Health. And we have 2 chapters on climate change as well as global warming. Thank you very much.
Good morning, everyone. And at the outset, I would like to thank Dr. Vitul Gupta and the organizing team for this opportunity. And as Sir has already briefed, so this was in 2016 that at the UN meeting, it was said that a fundamental long-term threat to human health, sustainable production, food production and development. This was said in the context of antimicrobial resistance. But if we consider it, it is equally true for the climate changes that we are now looking at. So individually, we know that climate change and antimicrobial resistance, they are both public health concerns, as Sir just mentioned. But we also now have evidence to suggest that these two are connected. So for this session, I'm going to discuss what is the interplay between these two public health issues that we're looking at, climate change and antimicrobial resistance, and look at some ways of how we can tackle this. Okay. Now, this was a UK study in 2016 which reported that if antimicrobial resistance is not addressed, then by the year 2050, 10 million lives a year and a cumulative $100 trillion of economic output will be at risk. The WHO in 2019 declared this as one of the top 10 global public health threats along with climate change. Now we are all aware of what happens when there is antimicrobial resistance. So there is increased duration of hospitalization. We move down to second and third line therapies. It increases the cost of treatment. The outcomes are inferior, and all these are something that we are all familiar with. And we are now looking at pan and multi-drug resistant organisms where we are struggling to find appropriate treatment options. And to add to this, our pipeline for new antimicrobials is not very encouraging at the moment. So this high consumption of antimicrobials that we see, we as the users and the prescribers to a large extent have contributed to this problem of antimicrobial resistance. The causes are many, and it's a complex issue which involves many factors, not just the over and the misuse of antimicrobials. Now moving on to another issue that we are all looking at the evidence of. So our media flashes things like the hottest month, glaciers are melting, food supply is under threat. So we are all looking at this. So today we can no longer deny and say that this is a problem which will happen sometime. It is already here. Now I'm going to look at infectious diseases and their influence on climate changes, because many of the infectious diseases are climate sensitive. So again, there are multiple factors in play here. We are looking at the host factors, the vector factors, and we are looking at organisms which are now being seen in areas where we did not see them earlier because of the conditions that have changed. Temperatures are rising, heat-related morbidity and morbidity we are looking at, but it is also influencing the bacterial growth in areas. So we are all aware that temperature itself and a rising temperature has an influence on bacterial growth. So there is now evidence to suggest that plasmid transfer and potentially gene transfer of resistant genes is facilitated by an increase in temperature. Generally, increase in temperature tends to improve the bacterial growth rates. Now, some studies are beginning to look at a correlation of a rise in temperature or a change in temperature with the growth of bacteria and the incidence of infections. So there are several studies which are being published which are correlating this, what is the area, what is the altitude and the altitude and the growth of organisms. So many of these studies are being published. So this study has looked at distance from the equator and socioeconomic factors, both which were associated with a higher risk of gram-negative bacteremia. Water vector-borne diseases is something that we see very often here in our scenario. So Zika virus, dengue, chikungunya, these are usually localized to the temperate climates because they need a higher temperature for their life cycle. But now they're moving towards the temperate climates as the global temperatures are rising. Malaria is something that we see a lot of in our country, and Dr. Datta was talking about the diagnosis and management of malaria. So here again, what we are looking at is an increased incidence of malaria in areas which earlier did not have so much of malaria. It's because of the reduced larval size and which requires the adult to feed more frequently, the rates and spreads of infection are now increasing. I'll take the case of Candida auris, which was first found out in 2009 in the human ear. And from then onwards, it has been implicated in a number of disease cases. Now this first was a plant saprophyte, gained thermotolerance, salinity tolerance because of the influence of the climatic changes that happened. Now it is hypothesized that it was transplanted by birds across the globe to rural areas where we see more interaction between the humans and the birds, and because of the population migration it then moved towards the urban areas. Now this is a candida which we now know is resistant to most of the antifungals that we know. So this is how such species which earlier were seen in sometimes animal species, sometimes in plants, are now gaining human value. Another thing which happens is water and soil contamination. So extreme weather situations such as floods and droughts can cause contamination of the water supplies and soil with human and animal waste. This also includes some amount of antibiotic residues and resistant bacteria. Now this creates a reservoir for the resistant microbes which can then spread into our ecosystems and the human communities. Now as we are seeing a rise in temperature, the capacity of the atmosphere to hold water increases, storms are becoming more severe and they come with a higher degree of precipitation. This precipitation causes more flooding, overcrowding because people now need to migrate, populations move, and it results in a higher incidence of waterborne infections, higher uses of antimicrobials and more chances of resistance. The use of fertilizers, particularly those with nitrogen, they are known to cause increase in antibiotic resistance, and floodwater pollution by nitrogen fertilizers during the conditions of flooding because of climatic changes again leads to a rise in antibiotic resistance. Eutrophication, which is a phenomenon which we see because of increased overgrowth of simple plants and algae in the water sources, which uses up all the oxygen of the water system, is also worsened by flooding. So all of these are the implications. Now agriculture industry also uses a lot of antimicrobials for varied reasons, some justified and some not so clear. So when there is a lot of use of antimicrobials in the livestock, again the water goes, some of the residues go into the water through the runoff, and climate change induced rainfall variability and flooding, they both exacerbate this contamination, increasing the proliferation of the resistant bacteria. Migration of populations because of these climate changes, urbanization, again they are leading to conditions which are favoring the growth of resistant bacteria because of sanitation issues, overcrowding, and lack of proper access to healthcare facilities and sanitary conditions. Okay. We are now looking at emergence of new disease patterns because we are looking at organisms which are found in areas where we did not see them earlier. So as we are going to use more antimicrobials for managing those conditions, it is thought that there will be an increase in the antimicrobial resistant patterns as well. Now this is how we looked at how climate was influencing the antimicrobial resistance. But there is the other side too, how antimicrobial resistance contributes to climate change. Now, as we are looking at higher rates of antimicrobial resistance, it is resulting in hospital stays which are longer, more intensive treatments, and increased use of resources such as energy and materials, which is raising the carbon footprint. There is increased manufacturing and waste which is being generated, particularly as we move on to the second and third line options. Again, it is causing environmental degradation. Now, overuse of antimicrobials, their metabolites, they are all going into the water systems. And slowly and slowly there is resistance being developed through the water systems as well. Where in the sewage systems, they are interacting, the antimicrobials will interact with the microbes and they get dispersed into the ecosystem. The presence of microplastics is something that is not new, but it is increasing and is being linked to antimicrobial resistance now. Possibly because of genes being transferred and the organisms are developing resistant biofilms and they are not getting washed off and they are being taken up, and even nanoparticles are now being taken up through the root system of the plants and leading to antimicrobial resistance. So we see these microplastics everywhere now. Overuse in the livestock for growth purposes is something that we are all familiar with. To take an example of the use of antimicrobials to prevent mastitis and promote the milk production in cows results in an overutilization and leading to some of these residues getting into the water systems. Aquaculture again uses antimicrobials, and as we are looking at climatic changes, the incidence of diseases in the animals is also increasing, which leads to a greater use of antimicrobials in the livestock and so thus resistance. Now where does this lead us? So we understand that there are connections, that there are links between climate change and antimicrobial resistance, but it is a complex phenomenon that we are looking at. We need more evidence and we need to now look at collaborative efforts to deal with these two public health concerns effectively. So can we look at the One Health approach, which is looking at the health of humans, animals, and the environment all as a correlated phenomenon, as a solution to dealing with both of these? So what are some things we can do? We are all aware that we need to be using our antimicrobials more judiciously, get appropriate tests. We need better diagnostic facilities so that we are able to quickly and accurately test for the presence of sensitivities and the organisms. We need collaborative efforts between all the healthcare professionals. So that means the medical doctors, the veterinarians, everybody needs to come together on a common platform, join hands with the other practitioners so that we can work towards this common goal. We need innovative strategies, and of course we need more research into looking for newer antimicrobials as well. So some measures which have been effective, for example, mass vaccination of the animals, feasible, can be done, has been shown to be effective. Okay. Then collaborative research and surveillance between microbiologists, ecologists, and climate scientists to better understand the consequences and how to deal with them. And also, very importantly, we need to look at the social determinants of health, because climate change disproportionately affects the vulnerable populations, including those who have a limited access to healthcare. So, to summarize, antimicrobial resistance and climate change are among the top public health concerns globally. Tackling these dual threats needs a collaboration between the healthcare professionals, and successful public health interventions require the cooperation of human, animal, and environment health partners. So professionals within these sectors need to communicate, collaborate, and coordinate activities for effective interventions. So, thank you. These are some of the references.
Thank you, madam, for your masterly deliberations and lecture. And One Health approach, I think, is the solution for global benefit.
Yes.
Thank you very much.
Thank you, sir.
Thank you. Ji.
Thank you, ma'am, for sharing this information with us. Now, I would like to call upon Dr. Akhilesh Pathak, Dean Academics, Professor and Head Department of Forensic Medicine and Toxicology at AIIMS Bathinda, to share his presentation on medico-legal pitfalls in daily practice.
इससे मूव होगा स्लाइड कैसे मूव हो जाएगी इससे So thank you all. So this is my topic for today, medico-legal pitfalls in daily practice. Actually, this topic, it highlights that whatever the routine practice a doctor is doing or a physician is doing, then what kind of the medico-legal problems may come. So that is the main thing. We are receiving so many cases for the routine treatment in emergency, OPD or IPD, like different cases of the road traffic accident, burns, any assault, then the firearm injuries, so stab injuries and all that. So these patients are coming to us basically for the treatment, but simultaneously, as we all know that there are the different type of the cases in which we have to perform the medico-legal duties also. So what kind of the medico-legal duties are attached with that, and where we commonly do mistake. So that is the basic outline of this lecture. So this is the overview of the presentation. These are the common mistakes we do. We may mistake in identifying, first in identifying of the medico-legal case. Second, whenever it is a medico-legal case, then we have to perform the various legal duties. And we often does the mistakes in performing the legal duties. Then we have to intimate the police in all these cases. So that we may mistakes in police information, we may mistakes in preserving samples. So अगर कोई sample उस case के अंदर preserve करना, then that can be the problematic. Especially in consent taking and whenever the death is occurring in such kind of the cases or any legal issue is coming out. So here we can divide the all cases in two groups. First is the alive, or when you are treating the patient of medico-legal case, and after death. So here are some of the examples I am putting here. This is a case of road accident. You can see one person met with an accident. Is it a MLC? So some of you may agree or disagree with that. The second scenario, the person is going on the bike and slipped this time and got injured and came to us as a road traffic accident due to slipping. Is it a MLC? Third scenario, the same person or different person may hit by the cow or any of the animal. Dog is coming in front of the bike and got injured. Is it a MLC? So these are the scenario. You may differ, some of us may differ for this, that yes, it is a case of MLC, and some may agree for the same. Another scenario, falling of the person in manhole, slipping in bathroom, fall from tree, snake bite case, honeybee stinging. So these are the different scenarios. We are receiving the different scenarios where the identification of the medico-legal case. Many of us can say that these are the not medico-legal case, or some may say that yes, these all are the medico-legal cases. So again, what I was saying, that we may mistake in identification or labeling in the medico-legal case. So what is the medico-legal case? If I will tell you in a very simple language, anything which is unnatural is medico-legal. Suppose you are attending here the lecture, okay? So this is a very common scenario that you guys are attending the lecture in any of the conference and sitting comfortably. But suddenly a tile is falling over your head. So is it natural? No, it is unnatural. Or you are sitting on the chair, or when you are trying to stand up, you got injured from any of the defect of the chair. So is it a natural thing? No, it is not natural thing. So anything which is unnatural and you think that it can be investigated by the police officer, that is medico-legal case, ideally. So I am telling you the ideal thing actually, but what practically is you are conducting, that is a different scenario. You may take advantage of that. So if these cases are identified, then we have to treat the first patient. Then again we have to register the MLC case. Third one is the information to the police. Then again we have to inform the person who will prepare for the injury report of such kind of the cases. Then if any sample is collecting, then we have to preserve it. So that question, I think we have already discussed about this, that this case is MLC or not. So once we have decided that it is a case of MLC, then first duty of that doctor with the treatment, I'm talking about the legal duties only. So first duty of doctor is registering that case as MLC. So how to register that case as MLC? So there are different scenarios. In some of the institute, the registration of the MLC cases are done on the computer or digital form, while in some of the institute, we are having a written proforma that is sent for the, so different scenario are there. So here we can see, if you are maintaining a medico-legal register, then the details of the patient and all that should be maintained in, written in that, and the case should be labeled as a medico-legal case. So all these things should be mentioned in register if you are doing it manually. Then we have to allot a medico-legal number, MLC number, and document it on the case paper. So whatever the case paper, whether it is OPD or IPD, you have to clearly mention with a red pen or at least in a bold or make a circle that this case is a MLC. So anybody who is treating behind you or he can see that yes, this case belongs to the MLC, and he has to also do the legal duties with the treatment in that particular case. So we are having lots of the cases in the ward. So some of the cases are medico-legal. Then it should be clearly visible on the record of the patient. So how it can be done? Second thing, whenever you have sent a call to the treating to a doctor who is preparing the medico-legal report of these cases, then whether this MLC has been attended by the forensic person or CMO or anyone, that should be clearly mentioned that yes, MLC call has been sent to the forensic person or to the CMO and this call has been attended. So MLC done or not, and what time. Second duty in all these cases, that it is mandatory duty to all of us to inform the police in all such cases. So we have to inform the police, and simultaneously we have also to inform the doctor who will prepare the medico-legal report of this, because a treating doctor is basically related for the treatment. So if you are a physician and you are alone there, then obviously you have to prepare the medico-legal report also simultaneously. Or at least you can hire a forensic friend to prepare the medico-legal report, MLC, or you can send the patient to the government hospital. So these two things are mandatory कि पुलिस को information हो जाए और साथ में उसकी मेडिको लीगल रिपोर्ट, इंजरी रिपोर्ट जो है वो बन जाए. So make sure that. So we are having the legal bindings to label the MLC as well as to inform the police. So here are some of the BNS sections you can see that which force us to inform the police in all such cases. अगर नहीं करेंगे तो we are inviting the problems. So we may do mistake in such kind of the cases. So please avoid all these pitfalls. Now the question comes कि पुलिस को इन्फॉर्म करना, लेकिन कैसे, किस पुलिस को करें, कहाँ करें और क्या करना है. So again that is a query. So here is a simple method. It can be done in two ways. One thing is it can be done through the telephone. So for that you will require a telephone number of the local police, of local police station. You have to call them and document this information over your case sheet that you have informed the head constable Ramesh Bhai, buckle number ये, police station ये, on this date at this time. ये सारा डिटेल्स आपको केस शीट के ऊपर लिख देना है कि भैया ये इन्फॉर्मेशन हो चुकी है. देन अगेन ड्यूटी टू डॉक्यूमेंट दैट पीआई हैज़ बीन गिवन. तो इस सेंस में हमें पीआई करनी है. यू कैन सी द एग्जांपल. पीआई हैज़ बीन गिवन टू हेड कांस्टेबल रमेश सिंह, बकल नंबर 3210, पुलिस स्टेशन सदर, हॉस्पिटल चौकी एट 7:45 PM, डेटेड 10/11/23. तो ये लाइन आपके जो केस ये कि भैया इतने बजे इस बंदे को इन्फॉर्मेशन दे दी गई है. दूसरा मेथड है कि आप रिटर्न पीआई कर सकते हैं. इस तरह के परफॉर्मा हम लोगों ने एम्स में बना रखे हैं. दैट इज़ अनदर मेथड. तो उसके अंदर आपको एक ओरिजिनल और एक कार्बन कॉपी बनानी है. ओरिजिनल पुलिस स्टेशन ले लेगा और कार्बन कॉपी पे आपको रिसीव करके दे देगा. सो दैट इज़ अनदर वे दैट वी कैन गिव दी पुलिस इन्फॉर्मेशन. कई सारे सिनारियो ऐसे आते हैं जिसके अंदर रिलेटिव्स रिक्वेस्ट करते हैं कि सर इस केस में मत करिए, हमारी बदनामी होगी, लड़की है, उसने सुसाइड अटेम्प्ट कर लिया, ये है वो है. बट रिमेंबर वी हैव टू डू आवर लीगल ड्यूटी एंड वी आर बाउंड टू डू दैट. इफ वी आर नॉट डूइंग then we may invite problems. So we may next mistake what commonly we do, we may mistake in referring the case for preparation of medical legal report. So it is the duty of the doctor who is attending first to prepare the medical legal report. कई बार ऐसा होता है कि भाई गांव के अंदर सिविल हॉस्पिटल में देखा और वहाँ पे मेडिकल लीगल रिपोर्ट नहीं बनाई है और आगे सिविल हॉस्पिटल में भेज दिया. सिविल हॉस्पिटल ने एम्स में भेज दिया और उसकी दोनों जगह पर रिपोर्ट नहीं बनी है और एम्स वाले सोच रहे हैं कि भाई दो सिविल हॉस्पिटल में बन के आई है, शायद बन गई होगी. अब वो बेचारा परेशान हो रहा है. सो दैट शुड नॉट बी डन. वॉट एवर दी हॉस्पिटल और द डॉक्टर हु हैज़ अटेंडेड फर्स्ट, it is the duty of that doctor to prepare the medical legal report of that person or to ensure that the MLC has been done. If it is you are in a private hospital, send the patient to the government hospital for the MLR preparation, and or you can hire a forensic friend to prepare the MLC in your hospital who can come and prepare the MLC for that. Duty to preserve the various samples for investigation. कई बार इस तरह का होता है कि फायर आर्म का केस है तो उसके अंदर हमें उसके कपड़े प्रिजर्व करने होते हैं, बुलेट अंदर से निकल रहा है सर्जरी में, दैट वी हैव टू प्रिजर्व. और इन केसेस ऑफ द पॉइजनिंग वी हैव टू प्रिजर्व द वेरियस सैंपल्स ऑल्सो टू डिटेक्ट द पॉइजनिंग. सो देर आर दी मैनी इंस्टेंसेज. कई बार आपने सर्जरी की, उसके अंदर से कोई फॉरेन बॉडी निकली, देन दैट हैज़ टू बी प्रिजर्व फॉर दी forensic science laboratory examination. So preservation of the sample, here are the some of the examples. In cases of poisoning, blood, urine, gastric lavage to be preserved. Rape के cases में मिनिस्ट्री ऑफ हेल्थ एंड फैमिली वेलफेयर की गाइडलाइंस हैं क्या क्या प्रिजर्व करना है और कैसे करना है. तो वी हैव टू डू अकॉर्डिंगली. देयर इज़ ए लॉन्ग लिस्ट. कई बार वेपन मिलता है, बॉडी के अंदर ही चाकू घुसा हुआ है, वो आपने ओटी में रिकवर किया, देन इट हैज़ टू बी प्रिजर्व्ड एंड सेंड टू दी फॉरेंसिक साइंस लेबोरेटरी थ्रू दी प्रॉपर चैनल. This is one of the common mistake we are doing when during the routine practice. Imposing himself or herself as a specialist without having any degree. I am not having a degree. I am just done a fellowship in rheumatology, and I am writing a rheumatologist for myself. And you are treating the patient, but if he will claim or he will sue in the court, then it will be when it will be analyzed, it will be observed. Means in so many cases it has been observed the doctor is not having that particular recognized degree, by the NMC. So it is again we do mistake. तो अगर केस होता है then it creates problem. तो वी हैव सीन कि किसी ने 3 महीने का कोर्स किया है, कहीं पर ट्रेनिंग कोर्स किया है, फिर वो लिख रहा है कि रूमेटोलॉजिस्ट, कुछ लोग लिखते हैं डायबिटोलॉजिस्ट। डायबिटोलॉजिस्ट की कोई डिग्री नहीं है हिंदुस्तान में, पर वो लिख रहे हैं कि अपना मैं डायबिटोलॉजिस्ट हूँ और ऑल द डायबिटीज़ पेशेंट आर गोइंग टू हिम, क्योंकि उसने लिखा हुआ है इतना बड़ा। MBBS डॉक्टर रनिंग ए मैटरनिटी होम, इस तरह के बहुत सारे केसेस हैं, आई एम नॉट गोइंग इन डिटेल, आप गूगल करके देख सकते हैं, जिसके अंदर डिफरेंट काइंड ऑफ सिनारियोज या MBBS पर्सन है रनिंग ए मैटरनिटी हॉस्पिटल, और वहाँ पे केस हो रहा है, रेगुलर डिलीवरी हो रही है, सब कुछ हो रही है, बट व्हेन द केस गोज इन साइड द कोर्ट देन इट क्रिएट्स प्रॉब्लम दैट यू आर नॉट क्वालिफाइड पर्सन फॉर दैट, एंड heavy penalty has been awarded by the court in so many cases. So even I have also conducted an autopsy of the pregnant female who was referred from the nearby blaze, in which the allegation was that the patient was not attended as per the demand of the relatives. तो relatives रात में उनको बुलाते रहे कि भाई इसके दर्द हो रहा है, ये हो रहा है, वो हो रहा है, but the doctor did not came from his home, or finally that lady was referred to the higher center and died. So in such kind of the cases there is always a allegation of the another mistake we do, starting a hospital without proper infrastructure and equipment. अब आप देख सकते हैं इसके अंदर नीचे की सनशाइन मल्टी स्पेशलिटी हॉस्पिटल, और देखिए नीचे फोटोग्राफ में, इज इट ए मल्टी स्पेशलिटी हॉस्पिटल, एंड he has written that 24/7 hours emergency services are available. So if you are doing this then it should be available there, और अगर आप नहीं कर रहे हैं तो इस तरह के lakhs of examples you can see in the India, but when the problems comes or when the matter goes in court then it creates problem. So doctor conducted hysterectomy where ICU was not done, so in such kind of the cases heavy penalty has been awarded by the court. There are lots of the examples, I am not going in detail. Not having a ventilator and doing the surgery, this is the case of BL Kapoor Hospital. Apollo Hospital Chennai, that was also penalized by the court for not having an equipment to check the methotrexate level in the body, and it caused the severe side effect in the patient. And this another common mistake we do कि हमने पेशेंट को भर्ती कर लिया है और अपने भर्ती करने के बाद में पेशेंट इज़ इन आवर हॉस्पिटल, ही नीड्स योर असिस्टेंस एंड यू लेफ्ट द टाउन, आप अपने कहीं गांव चले गए या आप मूवी देखने चले गए और वहाँ इमरजेंसी में आपने अपना पेशेंट एडमिट कर लिया है, एंड ही इज़ कॉलिंग, ही रिक्वायर्स योर असिस्टेंस बट यू आर नॉट अवेलेबल, एंड यू आर लीविंग दैट पेशेंट विदाउट हिज और कंसेंट टू योर जूनियर और untrained staff especially. So again that kind of the mistake cannot be assumpted by the different scenario in the court. तो यहाँ देख सकते हैं कि ICU के अंदर पेशेंट एडमिटेड है और अगर इसको ज़रूरत है और डॉक्टर नहीं है अवेलेबल, वो मूवी में बैठा है या अपने गांव चला गया है, then these kind of the scenario cannot be accepted by the court. So a patient was admitted in a hospital and doctor left the town leaving his patient to junior staff. So this was the case of Dr. Bejasuren case. You can see that scenario. So in this case, the Honorable Court penalized. In this case, the patient expired and a case of alleged negligence was registered and the doctor was penalized. We may mistake in not recognizing the complication or referring the patient timely. जब हमें टाइमली पेशेंट को रेफ़र करना है हम नहीं कर रहे हैं, या कोई कॉम्प्लिकेशन हो रहा है उसको हम रिकॉग्नाइज नहीं कर पा रहे हैं, दैट दीज आर दी अगेन कॉमन मिस्टेक्स वी डू एंड दीज आर दी मेडिको लीगल पिटफॉल्स दैट मे कॉज दी प्रॉब्लम्स टू अस सम टाइम. So this was the another example where the 25 lakh rupees of compensation awarded against the laparoscopic surgeon of Preet Hospital, Patiala on 11 June 22 for causing traumatic injury to the intestine that leads to the septicemia. Though the patient was operated for some surgery, but the injuries was done to the intestine, which was later detected, and 2 times that lady has to let lady underwent the different type of surgeries, and the hospital was penalized. Another, the most common type of mistakes we do, that is in consent taking. Consent taking के बारे में concept clear maximum लोगों के नहीं होते हैं, और वो किस तरह से करते हैं और क्या होता है वो फिर बड़ा प्रॉब्लम होता है. So whenever the case is examined for any kind of negligence, there are majority in cases the consent is not taken the properly. हम लोग उसके रिलेटिव से ले रहे हैं consent, हस्बैंड एडमिटेड है लेकिन वाइफ से साइन करा रहे हैं, उसके पिताजी से साइन करा रहे हैं, जबकि वो एडल्ट है, मैच्योर है, फुली कॉन्शियस है, कोऑपरेटिव है, ही कैन गिव द कंसेंट, लेकिन हम उससे साइन नहीं करा रहे हैं, बाहर किसी से और से करा रहे हैं. डायग्नोस्टिक लेप्रोटॉमी के लिए साइन आपने लिया हुआ है कंसर्न और आपने कर दिया अंदर ही कोलिसिस्टेक्टोमी साथ में, तो उसके लिए आपने कंसेंट नहीं लिया, दैट कैन क्रिएट प्रॉब्लम. उस बंदे की लैंग्वेज में नहीं है, आई एम ए पंजाबी एंड यू हैव टेकन द कंसेंट इन इंग्लिश लैंग्वेज. So all these things cannot be accepted when the case goes inside the court में जाता है. तो आपके सिग्नेचर नहीं है, the name of the procedure not mentioned, blood transfusion anesthesia के लिए अलग से consent नहीं लिया है, ये सारी चीज़ें हैं जो common mistakes हैं हम लोग करते हैं, और when the case goes inside the court प्रॉब्लम होता है. कंसेंट लेने का बेस्ट तरीका है CCTV रूम में होना चाहिए, सारा प्रोसीजर उसका रिकॉर्ड होना चाहिए, एंड दी ऑल थिंग्स टू बी डन. 2 न्यूट्रल विटनेस, डॉक्टर साइन एंड पेशेंट साइन, ये उसमें होना चाहिए. अदर मिस्टेक्स जो हम लोग कॉमनली करते हैं कि हम लोग अपनी सिक्योरिटी नहीं करते, कि अगर कोई नेग्लिजेंस का केस लगेगा और अगर सिविल सूट है तो आपको हैवी पेनलाइज कॉम्पनसेशन देना है. हमने अपना इंश्योरेंस नहीं ले रखा, सो इंडेम्निटी इंश्योरेंस मेजॉरिटी ऑफ द डॉक्टर्स वी आर नॉट हैविंग. अगर ये नहीं है तो आप बहुत बड़ी भूल कर रहे हैं, बहुत बड़ी. तो जब अगर पेनल्टी लगेगी, और अभी जो कोर्ट पेनल्टी दे रही है यू कैन सी इन करोड्स, राइट. सो अगेन ये बहुत बड़ा टॉपिक है, कैसे लेना है क्या लेना है, आई एम नॉट गोइंग इन डिटेल ऑफ दैट, एंड हियर आर सम ऑफ द एग्जांपल्स ऑफ दैट. Record keeping and documentation, and again but this one is important, often we do mistake in documentation. So proper documentation should be done. If you did not document, the court will consider that you did not do it. अगर आपने नहीं लिखा तो आपने नहीं किया. आप कहेंगे सर मैंने ये किया, आप CCTV देख लीजिए, कुछ देख लीजिए. नो डॉक्टर साहब, आपने कागज़ में नहीं लिखा है मतलब नहीं किया. आपने कागज़ में लिख दिया और आपने नहीं किया है तब चलेगा कि आपने नहीं किया, लेकिन यू हैव डॉक्यूमेंटेड कि आई हैव डन दिस थिंग. क्योंकि बाद में केस जब होता है देन ओनली द डॉक्यूमेंट्स विल बी चेक्ड, दैट फाइल विल बी एनालाइज ओनली. So poor documentation is the poor defense in court. So there are the lots of the examples, you can go through the Google, जिसके अंदर documentation की importance दिखाई हुई है. डेथ के अंदर हम लोग कॉमनली मिस्टेक्स करते हैं कि MLC का केस है, उसकी डेथ हो गई है एंड वी आर नॉट रिपोर्टिंग टू द पुलिस. इमीडिएटली इन्फॉर्म द पुलिस और हॉस्पिटल मॉर्चरी को के अंदर डेड बॉडी को शिफ्ट करना है. आपको डेड बॉडी हैंड ओवर नहीं करनी है रिलेटिव को. वो कहेंगे साहब ये तो MLC नहीं है, पुलिस खुद कहेगी कि साहब इसमें वो डॉक्टर साहब क्या ज़रूरत है इसमें तो पोस्टमार्टम की. पर नहीं, यू हैव टू फॉलो दी वॉट एवर दी रूल्स ऑफ दी एज पर दी लैंड ऑफ लॉ. So request a medico legal postmortem, do not issue death certificate and send the dead body to the cold room for autopsy examination. लामा डामा इन सब केसेस के अंदर भी अगेन आपको पुलिस को इन्फॉर्म करना है अगर MLC केस है तो, कि भाई ये बंदा भाग गया है या जा चुका है. टेम्परिंग ऑफ हॉस्पिटल रिकॉर्ड कहीं भी कर रहे हैं, केस को मैनिपुलेट कर रहे हैं, अगेन वी डू सच काइंड ऑफ द मिस्टेक्स, दैट शुड नॉट बी डन. आप एडिशन कर सकते हैं लेकिन टेम्परिंग ना करें कि पहले टाइम कुछ लिखा था उसको काट के फिर दूसरा लिख रहे हैं, ओवर राइटिंग एंड ऑल दैट. प्लीज अवॉइड दैट. So now I am concluding. So we should be able to identify the MLC, inform the police, preserve the evidence, proper consent, proper documentation, indemnity insurance. Please ले लीजिए अगर नहीं लिया तो. Have forensic friends and lawyers, जब भी फंसें तो कम से कम वो आपकी मदद कर सकें. So medical practice, it is like driving through an accident-prone highway. Make sure that you are competent driver. Means stay within the limit of your expertise. आप ऐसा ना बोलें कि जिस चीज़ का मैं एक्सपर्ट नहीं हूँ उसमें एक्सपर्ट हूँ. द इग्निशन इज़ वर्किंग फाइन, मीन्स यू हैव टेकन इन्फॉर्म कंसेंट. द इंजन ऑयल एंड फ्यूल आर ओके, मीन्स यू हैव डन प्रॉपर डॉक्यूमेंटेशन एंड मेडिकल रिकॉर्ड कीपिंग. GPS is working, means your communication should be good. And importantly, your brakes are good, मीन्स यू शुड नो वेयर टू स्टॉप. ऐसा नहीं कि डायग्नोस्टिक लेप्रोटोमी के लिए हमने कंसेंट लिए और कर दिया कोलिसिस्टेक्टोमी, या जिसके लिए कंसेंट लिए और फिर जाके कुछ और कर लिया. इफ़ यू रिक्वायर दी कंसेंट की कोलिसिस्टेक्टोमी करनी है, कम अगेन आउटसाइड, टेक दी अगेन कंसेंट, देन यू कैन प्रोसीड फॉर दैट. बट ऐसा नहीं कि बिना लिए आपने अंदर ही कर दिया सब. So this was all happy and safe medical practice. Thank you.
Thank you for sharing your knowledge with us, sir. Now let's turn our attention to Dr. Pawan Suri, Director and Chief Cardiologist, Global Multispeciality Hospital, Jalandhar, Punjab, on his topic, Sudden Cardiac Death Perspective in 21st Century.
Dr. Pawan Suri is not only a doctor, but a health and public health activist. And you can Google his name and can read excellent writings on almost every burning current topic. So he's a prolific writer with a human touch and human rights attitude. Thank you, Dr. Suri, for coming and gracing the MAPICON 2024. Your presence and your lecture is going to add to the prestige of MAPICON 2024. Thank you very much.
Thank you, Dr. Vittal, for such a humble and nice introduction. And I thank the organizing committee for giving me an opportunity to be here. So this is the topic actually chosen by Dr. Vittal only, that I have to talk about sudden cardiac death, the perspective in 21st century. The reason being that we have in the last few years, we have seen, especially after the COVID, we have seen that a lot of young people are dying suddenly at home. So this might be the thing in Dr. Vittal's mind, and he told me that you have to talk on this topic. So when we talk about the concept of sudden cardiac death, it started back 120 years ago, and it was Dr. John A. McMillan who introduced this term. And when we talk about the definition of sudden cardiac death, it is an unexpected natural death which occurs within 1 hour if the death is witnessed. But if the death is not witnessed, then we take this time period as the 24 hours. So each one of us know these personalities. This is just the tip of an iceberg. And one of these was my favorite, the Siddharth Shukla, who was a Big Boss winner. And actually after winning the Big Boss next year, he collapsed at home and he died of the sudden cardiac arrest. So the magnitude of the problem when we talk about the epidemiology of sudden cardiac arrest and sudden cardiac death, about 0.1% is the incidence, is the prevalence in the US, and same is in the Europe as well. About 3 million to 4 million deaths occur in a year in US. And when we talk about India, about 7 million deaths occur due to the sudden cardiac arrest every year. So you can see how much prevalent this disease, we can call it a disease, is. The important thing about this sudden cardiac arrest and sudden cardiac death is that though in general population we see that it's 0.1%, but keeping in view the large population, so this sudden cardiac arrest is more commonly seen in the low risk patients. You can see in the if the patient is having a high risk, like the patient is having a myocardial infarction, the number of deaths is more. But when we take into consideration the general population, the absolute number of sudden cardiac deaths is more in the low risk group as compared to being in the high risk group. And unfortunately, we don't have much to preempt whether the person in a low risk in the general population is going to have the sudden cardiac arrest. These are the general routine risk factors: the older age, the male gender, the race, obesity, cardiometabolic risk factor. These are the risk factors what we assess in the general population and come to the conclusion whether the patient is going to have the sudden cardiac arrest in future or not. The only good thing about these risk factors is that these risk factors, they only identify the people who are at risk of developing the structural heart disease. That is, these risk factors are only there to find out whether the patient is having a high risk of developing the myocardial infarction or the coronary artery disease. So we don't have much to give to the general population as far as a certain cardiac. The exercises, they are doing the treadmill and there's a certain collapse on the treadmill. So there is a role of activity. So it is recommended that once we are doing more exercises, the chances of having the certain cardiac arrest is more as compared to having the moderate exercises. If we talk about the annual incidence of cardiac deaths during the exercises, 1 in 2 to 3 million. But in cardiac rehabilitation programs and the stress testings, the 6 times higher if we are doing the exercises. So these are the other risk factors what we have for the coronary artery disease: the age, hypertension, intraventricular conduction blocks, the dyslipidemia, the diabetes, smoking, and the obesity. These are the risk factors. The only thing is that more the number of the risk factors, the more are the chances of having the certain cardiac arrest. So if a person has only a single risk factor, the chance of certain cardiac arrest is less. But if the number of risk factors is more, the chance of cardiac arrest is more. So causes of sudden cardiac arrest: about 70% of the patients, they have a coronary artery disease, and the cardiomyopathies, they form the second most common, and rest of the 2 to 3% of the patients, they have an inherited arrhythmia or the valvular heart diseases. So when we come to the causes of the sudden cardiac arrest, we usually divide the patients into 2 groups based on the age. If the age is less than 35, the chances of sudden cardiac arrest due to the cardiomyopathy is more, and when the age is more than 35, the chance of cardiac arrest due to the coronary artery diseases is more. So depending upon the age of the patients, we can just make an assessment whether this patient has a familial cardiomyopathy or is having an idiopathic or the coronary anomalies, or if the patient is having a coronary artery disease. But as we are seeing, number of patients who are coming with the coronary artery disease are younger in age, so maybe in future this classification may not be applicable for the certain cardiac arrests. So this is again showing the same thing, where you can see that the genetic diseases and the congenital diseases are more common in the younger age groups. In the middle age group, it is the cardiomyopathies, especially the hypertrophic cardiomyopathy, and in the age more than 35 or 50 years, it is the coronary artery disease or the heart failure patients who are more prone to have these certain cardiac arrests. So in the disease states, the coronary artery disease, it is the commonest. About 80% of the patients of the coronary artery disease, they have the sudden cardiac arrests. And it has been seen in one of the nationwide study that there are 13% of all first MIs present with the out-of-hospital cardiac arrest. So you can see that coronary artery disease can be, the first presentation of coronary artery disease can be a sudden cardiac arrest. So there are 2 major scenarios of sudden cardiac arrest in case of an acute setting, in case of a chronic ischemic heart disease, and the 2 parameters which are important in suggesting whether the patient is going to have a certain cardiac arrest is the ejection fraction and the premature ventricular contractions. But as we have started understanding the ejection fraction better, we have seen that these risk factors, they are not applicable for the certain cardiac arrest, because we have seen that even in the patients who have a less ejection fraction, they may have the mortality may be higher, but the incidence of certain cardiac arrest is less as compared to the patients who have a preserved or reserved ejection fraction. So on the basis of clinical history, the following 4 variables, they should be kept in consideration when the patient of a coronary artery disease or an acute coronary setting comes. If the patient gives a history that he has a syncope at the time of chest pain, if he is in an NYHA class 3 or 4, if he has documented ventricular tachycardia or fibrillation, early after myocardial infarction between 3 days to 2 months, and there is a history of previous myocardial infarction. So if you find these 4 variables in a patient of coronary artery disease, so these are the patients who are more prone to go for the sudden cardiac arrests. Similarly, the cardiomyopathy is the second leading cause. About 2 to 4% is an incidence of sudden cardiac arrest in these patients. It is a heterogeneous variety, so some cardiomyopathy patients who have an ejection fraction of 20%, 15%, they live longer. Some with an ejection fraction of 25-30, they have a certain cardiac arrest. So it is a heterogeneous variety, so some genetic mutations or the genetic variants come into the play at that point of time. And the various non-invasive parameters they use for risk stratification, or if you find the non-sustained VT on the Holter, if you find the T-wave alternance, late potentials, heart rate variability, or the other autonomic, associations. The hypertrophic cardiomyopathy, it is more commonly seen in males in the middle age groups, and the patients with hypertrophic cardiomyopathy who have a history of syncope in the past, who have a sustained ventricular tachycardia, family history of certain cardiac deaths, diverse genotype, recurrent syncope, multiple episodes of non-sustained ventricular tachycardia, they are the strongest risk factors for the certain cardiac deaths. The other thing is when we go for the genetic study in these patients, the mutations in the alpha-tropomyosin and the beta-myosin heavy chain gene has been found to be associated with the certain cardiac arrest in these patients. So a couple of points about the arrhythmogenic right ventricular dysplasia. It is again one of the congenital diseases where the muscle is replaced by the fatty or the fibrofatty tissue in the right ventricle, and in 1/3 of the cases in the left ventricle as well. So we can get the in these patients we get an idea from an ECG only. Similarly, the couple of points about the arrhythmic mitral valve prolapse. Mitral valve prolapse was considered as one of the benign things, but nowadays it has been seen that if you are not able to find the cause of certain cardiac arrest in a patient, then on echo you find a mitral valve prolapse, then look for the risk factors for certain death in these patients. If the patient has syncope, non-sustained VT, presence of mitral inner disjunction, late gadolinium enhancement on the MRI, and the reduced ejection fraction T-wave inversions. If you find these parameters in a patient of documented mitral valve prolapse and a patient has a syncope, then keep in mind that these patients may land into the certain cardiac arrest. So only 1 to 2% of these patients, the primary electrophysiological abnormalities, they are especially seen in the young patients, and they represent an electrical imbalance, and they structurally and mechanically the heart is normal. The only problem is in the channelopathies. So these are the patients or the children who have a congenital long QT syndrome, WPW syndrome, idiopathic ventricular fibrillations, Brugada syndrome, CPVT. These are all the, but this group of patients is only 1 to 2%. So we should, and these are mostly seen in the young, the children less than 20 years of age. So you should keep into consideration elderly patients. The chance of these things are very less. The only thing is that the long QT syndrome can be seen in the older patients, especially when the patient is taking some medications as well. Regarding the congenital long QT syndrome, there are a number of subtypes of QT syndromes. The only thing worth mention is that the incidence of cardiac events is higher in long QT 1 and 2 than in the long QT 3, whereas the lethality of cardiac events is higher in the long QT 3 than in long QT 1 and 2. So this is diagnosed on the genetic study. So there is a genetic panel available for diagnosing these subgroups. So WPW, this is again an ECG abnormality you can find. The incidence is cardiac death is about less than 1 per 1,000 patient years. Similarly, Brugada syndrome, you can see on the ECG, you can find it or give a provocative medications and find it on the ECG as well. I have seen in my lifetime only one patient of Brugada. That patient was from Italy, and we inserted an AICD. Once she was operated for some abdominal problem, and ultimately she had a recurrent and refractory VT. So we diagnosed her on the ECG, and we had put an AICD long time back, about 7 years back. She is doing well. So the mechanism of the sudden cardiac arrest, it needs a structural or anatomical abnormality. The transient risk factors come in between, and then the arrhythmia comes. So this is in the nutshell what happens in the sudden cardiac arrest. We have a mechanical or a structural defect in the heart, some transient risk factor comes in between, and the patient develops arrhythmia and the sudden cardiac arrest. So these are the tests used for risk stratification. I don't want to go deep into this. The only thing is which has come in a long way nowadays is the looking for the coronary artery calcium by doing the CT angiography. So it is one of the robust midterm predictor of poor outcomes than other cardiovascular risk factors. So apart from the ECG, echocardiography, MRI, the CT angio has also come up and in a big way in these high-risk patients. As far as the treatment, none of the antiarrhythmic medications, they are effective in the certain cardiac arrests, especially In fact, there are various classes 1 drug, class 3 and calcium antagonists. They in fact increase the incidence of the arrhythmias. The only antiarrhythmic medications which have been effective in reducing or in subsiding the arrhythmias, the beta blockers and the amiodarone. The rest of the medications we don't, the rest of the antiarrhythmic medications we don't have. But now we have the IGLT2 inhibitors, the AC inhibitors used in the heart failure patients, ARNI. So they are more or less very much effective in the arrhythmia patients and reducing the arrhythmias. So once the patient has suffered a cardiac arrest, so this is the treatment algorithm given for them. The only point I want to mention here is that there is a role of an AICT, that's a cardiovascular defibrillator. So this is what we have till date as far as the sudden cardiac arrest is concerned and its management is concerned. So what is the envisioning near-term sudden cardiac death prevention in 21st century? So there is a call for changing the paradigm of sudden cardiac death prevention, because ejection fraction, which was once considered as one of the tools for the patients at a high risk of developing a certain cardiac arrest, it has been seen that only 1/3 of the patients who have an ejection fraction less than 35, they go into the sudden cardiac arrests. So there are competing risks which are not being considered right now. There are absence of the risk factors or the risk scores actually in the general population. The ICD complications are there, and the sudden cardiac death risk is dynamic. So these are the three things which need to be evaluated, or which are the current, which are currently being focused upon: the competing risks, the risk factors in the general population, and the dynamicity. So a new approach to sudden cardiac death, we have been talking about the sudden cardiac death, but the paradox in the 21st century is that it is not sudden, because it has been seen that about half of the patients who have a sudden cardiac arrest, they have some warning symptoms. So what we are talking about, the sudden in the last 10-12 minutes, in fact, we are paradoxically negating that. So these warning symptoms, one should be very aware and one should be very knowledgeable to understand those warning symptoms. And it has been seen, if a person is able to understand these warning symptoms, the chances of survival is increased by 7-folds. So some transient risk factors, we have been talking about the stable risk factor as far as the age, hypertension, diabetes is concerned, but it has been seen that only 20% of patients who survive the cardiac arrest develop features of transmural myocardial infarction, and 50% of deaths in heart failure patients are sudden, even in NYHA class 1 and 2. So this probably relates that some transient thing occurs in between and it leads to the sudden cardiac arrest. The transient thing can be in the form of myocardial ischemia, maybe a spasm for some time, hemodynamic dysfunction, abnormalities in the electrolytes. We see that hypokalemia, hypomagnesemia, it creates a problem. Change in the pH or PO2, and influence of the central and peripheral autonomic neuropathy. So these transient risk factors should be kept into consideration and should be evaluated or thought upon in these patients. The other thing is that what we have been doing till date is we have been reading and understanding the static ECG. The static ECG, it reflects a one-time electrical status. But what we need to understand and what we need to follow is the dynamic monitoring. So dynamic monitoring can help us in understanding the transient risk factors, especially we have the Holters nowadays, which can read the rhythm, ECG rhythm 10 minutes and 10 minutes before and 10 minutes after the episode, and we can understand the dynamic monitoring in the form of J-point amplitude. If there's an increase in the J-point amplitude, the chance of sudden cardiac arrests are more. So they can assess these patients at least 1 hour. The studies have shown that they can assess these patients who are prone to develop the sudden cardiac arrest 1 hour before the episode. So dynamic monitoring is another field where we should focus upon. So when we come to the 21st century, the real risk time acute risk stratification, we have to use our devices. This is the sudden cardiac death prevention. Once the patient develops the symptoms or he feels that something is not going well in my way, he can start using his connecting devices, be it the smartwatches, be it the mobile phones, and then the data will be captured and it will be acquired by the device, then diagnosis of sudden cardiac arrest, Then the continuous data analysis will be done, use of an artificial intelligence, and then ultimately the patient will develop we will be able to understand with the high-risk patients. So in the 21st century, when we talk about the envisioning of 21st century, the combination of the warning symptoms, connected devices, and artificial intelligence will make near-term prevention effective in reducing sudden cardiac death burden in near future. And this strategy will improve the sudden cardiac death prediction, reduce delay for resuscitation, decrease delay for medical contact, and improve referral to the appropriate level of healthcare expertise. So in a nutshell, of all presentations of the cardiovascular disease, sudden cardiac death is the most challenging and feared. It may strike without any warning in previously apparently healthy individuals and results in tragic events for those left behind. Despite major advancements and investments by the Medical Research Committee, over the past decade, the prognosis of out-of-hospital cardiac arrest countries continues to remain dismal, with the highest reported overall 30-day survival of only 13%. More work needs to be done on transient risk factors and near-term prevention using the concept of dynamic monitoring. In this regard, artificial intelligence, machine learning have the potential to play an important role in arrhythmia diagnosis and prediction. And in the near future, one can imagine that connected devices such as smartwatches will continuously monitor the at-risk patients and automatically detect sudden cardiac arrest by utilizing key parameters such as heart rate and oxygen saturation, and by detecting the absence of physical movement. And this is all possible when we are able to penetrate deeper into the society and make everybody and each one aware about this dreadful disease. Thank you very much.
Thank you very much, Dr. Suri. You have given the overview of the serious condition which daily we are seeing on social media, that this young person has collapsed on road, collapsed in gym. So we need to be careful, and as rightly said, that all the high-risk populations should get their profile done so that sudden cardiac death can be prevented, or at least we can save some people. Thank you very much.
Any questions?
You are being watched online by a lot of people, but we don't have any, communication with them. So thank you very much.
Thank you, sir, for this amazing presentation. And it's my pleasure to introduce Dr. Bhupender Singh, Additional Professor and Head, Department of Cardiology at AIIMS Bathinda, for a presentation on topic heart failure with preserved ejection fraction evolving trends.
Good afternoon, everyone. First of all, I'd like to thank the organizers, and specifically Dr. Vitul Kumar Gupta, for giving me the opportunity to present this particular session in this prestigious conference. So my topic is basically on the more highly prevalent disease in cardiology, which is heart failure. And out of heart failure, a little, we can say the neglected component of heart failure is the heart failure with the preserved ejection fraction. Or you can say the underdiagnosed disease amongst the heart failure patients. So I'll be discussing under these headings. Basically, I'll be discussing the newer concepts which are coming up in terms of heart failure with preserved ejection fraction. So the concept of preserved ejection fraction started very early when there were numerous trials for the heart failure with reduced ejection fraction, which included less than 40%. So initial trials they started including ejection fraction more than 40% in the form of CHARM preserved trial. And then recently we had Emperor preserved deliver trial, which included again less than 40%, more than 40% as a other than reduced ejection fraction. Then I preserved trial, which included patient more than 45% of ejection fraction as a patients without heart failure reduced ejection fraction. Now universally we divide heart failure into 3 categories as per the ejection fraction is concerned, and our topic is basically heart failure preserved ejection fraction, which will be including heart failure with ejection fraction of left ventricular more than equal to 50%. So that's how the evolution of ejection fraction in terms of preserved ejection fraction or mildly reduced ejection fraction has came up. So why do we need there is a continuous evolution of heart failure management strategy. As we know, the need is basically primarily driven by the disease prevalence in the community. So globally, we can see the prevalence is about 1 to 2%. Even in India, the prevalence remains same. But in 2016, the data which has shown that 8 to 10 million patients population is having heart failure. Globally, the prevalence of heart failure with preserved ejection fraction is almost equal to heart failure reduced ejection fraction. But various Indian registries has shown that the heart failure with reduced ejection fraction is to the tune of 60%, and the preserved ejection fraction is about 35–40%. So probably we are underdiagnosing HFpEF patients. And the 30-day mortality is to the tune of 12 to 14%, and 1-year mortality is 25 to 30%. It is not about the mortality. Even the morbidity is very high in terms of repeat hospitalization and the daily cost of living and the medication. So these are the various data which has shown, as we can see that the Indian mortality, 1-year mortality is to the tune of around 25 to 30% in 1 year. These are the international data where India has component in one of the trials. And below we can see our own Indian heart failure registries. And the latest one to 2022 and 2022, one National Heart Failure Registry and the Indian College of Cardiology National Heart Failure Registry. And we can very well see the HFrEF patients are more. So what we feel, probably they are more in proportion because HFpEF is little less diagnosed and undermined. I mean, it is considered maybe less important. So why those things are there, we will see. How HFpEF is different from HFrEF patient. They are more elderly. They are more comorbid. About 70% they have coronary artery disease. They are hypertensive, diabetic. So the combination of diseases is more common in patients with HFpEF patient as compared to HFrEF patient. They are anemic, obese. Obesity with HFpEF is far common as we think in our OPD practices. And atrial fibrillation is more common to the tune of 44%. And in this slide, we can see these patients are overall far more comorbid than HFrEF patients. And another thing which is shifting nowadays, rather than considering HFpEF as a disease, we consider that it as a heterogeneous syndrome. So there is a concept of HFpEF phenotypes. Rather than saying that this patient is having ejection fraction of more than 50% and the BNP is high and we are just treating heart failure in the form of fluid overload and that particular scenario, we assess the pathophysiological aspects of HFpEF in terms of the associated comorbidities, the biomarkers, by doing more and more cardiovascular imaging of CT, CMR, and hemodynamics, and then we try to divide those pathophysiological factors into the phenotypes. So we see that based upon comorbidities, we can divide HFpEF into obesity related, and which is probably the most common phenotype of HFpEF syndrome. And we see an obese patient with dyspnea, our first thought is probably this patient could be HFpEF, and we go for echo. Then the other, based on comorbidity, the second component is the coronary artery disease and then the coronary microvascular dysfunction scenario, where you can have normal epicardial coronaries, but you have microvascular dysfunction leading on to HFpEF. Coming on, based on pathophysiology, you can have systolic dysfunctional phenotype associated with coronary artery disease or microvascular dysfunction, left atrial dysfunction phenotype. It's an upcoming thing. Again, atrial cardiomyopathies are newer upcoming things. Then you have pulmonary hypertension, pulmonary vascular diseases, and right heart dysfunction. Chronotropic incompetence, like bradycardia patient, they present with HFpEF, with LVH, and this is based upon pathophysiology. You can have these classifications. So this is a nutshell of the overall pathophysiological process of HFpEF. So as we can see, this is a multifactorial combination of various comorbidity and pathophysiological changes, not in the heart, but in the blood vessels, even in the skeletal muscles at the level of vessel wall as well. So there is a concept of as to how do we evaluate these patients. So age-old definition of HFpEF will be you have the clinical symptoms, ejection fraction of more than equal to 50%, and you have the evidence of increased filling pressures of left ventricle, which could be invasive element or a non-invasive evaluation. And the basic hallmark of HFpEF will be the raised filling pressure of left ventricle. But there is a diagnostic challenge for the HFpEF patient. Why that is so? If we just rely on the biomarkers or echocardiography, we'll be missing some of the patients, because echo is less sensitive to diagnose LV filling pressures, or sometimes these are not checked, and the BNP level may be low in some of the HFpEF patients. Again, if you are just diagnosing on the basis of these levels, we may miss some of the cases. Even in patients meeting diagnostic criteria, symptoms may also be related to other conditions such as anemia, obesity. So these are all competing interests or the symptom producing associated findings which can be produced. So you may be over-diagnosing sometime. Most of the time you are under-diagnosing, but sometime your symptoms might not be related to HFpEF, but related to these competing syndromes associated with HFpEF. So they have come up with a newer diagnostic algorithm for the management of HFpEF, where you have the patient of dyspnea under evaluation with ejection fraction of more than equal to 50%. Then you see the bias in probability, that whether this patient is at a low risk, intermediate, or a high risk. For those probability, they have come up with two scores, H2 HFpEF score and HFA PEF score. Based upon these scores are based upon the clinical, the biomarker, and the echo findings. So all these things are going to be the non-invasive evaluations. So you have a patient ejection fraction more than 50%, you go for these probability score. Out of these, the first one on the left side, H2 HFpEF score, is more commonly used. You have the score system, then you can label that patient as a low, intermediate, or a high probability. If it is a low probability, you rule out the diagnosis. If it is a high probability, you rule in the diagnosis of HFpEF. And you have intermediate probability. There you can further go for the exercise stress testing, which could be non-invasive or invasive. So non-invasive, it is like diastolic stress testing you can go for. But mostly, if you follow this, you will either rule in or rule out the diagnosis of HFpEF. And very less number of patients you will have intermediate probability. So apart from this, you should be aware of some of the conditions, clinical conditions, which are mimickers of HFpEF, which are valvular heart disease. Obviously, that will be ruled out by echo. Pulmonary hypertension, again, can be ruled out by echo. Pericardial diseases, right ventricular dysfunction, sarcoidosis, HCM. Some of the things will be mostly ruled out by echocardiography, and some will be further ruled out by other imaging modalities like cardiac MRI. Then what is the evolution in the management concept? Till now we were like HFpEF management is just like a diuretic, and in heart failure reduced ejection fraction, you have 4 pillars of management of heart failure. Everything was focused on the HFrEF patients. Now there are newer things which have come up in HFpEF management. So it has got poor prognosis because of increased proportion of non-cardiac causes of mortality. And reduced cardiorespiratory fitness, and quality of life is far poor compared to HFrEF patients. So we have 3 modes: non-pharmacological, pharmacological, and device-based management strategies. So in the non-pharmacological, we have cardiac rehabilitation program, which includes the moderate intensity continuous exercise training. As per the functional capacity, you can ask the patient as to follow one of the protocol for the cardiac rehabilitation, and the dietary interventions in the form of calorie restriction, intentional weight loss, because most of the cases they are obese with HFpEF scenario. So these cardiac rehabilitation will increase the VO2, improve cardiac output, cardiac function, improve ventilatory efficacy, and other way, and eventually improves the quality of life of patients of HFpEF. Amongst the dietary, it's a routine with the reduced salt intake and increase in protein intake, and saturated fats should be, so routine DASH diet and Mediterranean diet has to be followed. Then coming to the pharmacological, which is most important nowadays, has been studied too much. The optimization, most important will be optimization of the comorbid illness like hypertension management. You have set goals for the management of hypertension, CAD management, atrial fibrillation, and appropriate management of diabetes mellitus. And more importantly, you have a SGLT2. The coming up things are SGLT2 inhibitors, ARNI, GLP-1 analogs, and non-steroidal mineralocorticoid receptor antagonists, which is finerenone, the latest one in 2024. So this is how the journey of SGLT2 started. First, they studied in diabetes. We are more concerned with these two trials, which have changed a major paradigm change in the management of HFpEF patient with the empagliflozin and the dapagliflozin, which have reduced the combined risk of CV death, hospitalization for heart failure in patients with heart failure and preserved ejection fraction, regardless of the presence or absence of diabetes. This is a breakthrough in the management of HFpEF patient. Previously, everyone knows the HFrEF management. We have 4 pillars: ACE inhibitor, ARB, ARNI, SGLT2, MRAs, and these beta blocker, and nothing was there with the HFpEF patient. So this is a breakthrough medical therapy which has been labeled as class 2A indication, and probably in near future it will rise up to class 1 indication as well. So this becomes the first pillar of management of HFpEF patient. There comes the role of ACE inhibitor, ARB. There were a number of trials right from the beginning. Previously they studied charm preserved in more than 40%, 45%, then PEP, perindopril ACE inhibitor trials. Now the recent one, the Paragon HF and Parallax trial, where they have studied the role of ARNI in HFpEF patients. But overall it was not positive. So in one of the subset, it was found that the subgroup analysis showed the benefit was there in relatively, not in all patients with normal ejection fraction, but ejection fraction less than 57%, and in females it was found to be beneficial. So thereby the indication, the class of indication is not class 2A for ARNIs or ARBs or ACE inhibitor, it is class 2B indication. Probably the future will guide us further to whether these are still beneficial or not. It is under process. There comes the role of mineralocorticoid receptor antagonist is one of the important pillar for the HFrEF patients. In the meta-analysis, they have found the steroidal MRAs like the aldactone, spironolactone reduces the risk of CV events in HFrEF patients, but non-steroidal MRAs, which is the latest one, the finerenone, reduces the risk of patient with HF mid-range as well as preserved ejection fraction. So TopCat studied spironolactone, and the latest one which was presented in 2024 ESC Congress, which has shown reduce the primary endpoint, and this will become probably the second pillar for the management of HFpEF patients. So this is an important molecule. Then comes the role of the finerenone could be a second pillar after SGLT2 inhibitor. Presently till now it is class 2B indication to start MRAs. Then another drug which is semaglutide GLP-1 analog, the latest trial has shown STEP heart failure trial in preserved ejection fraction on obese patient. It has shown to improve the cardiovascular events. So in near future, this is another molecule which probably will come as a management of in due course of coming years in the management of HFpEF patients. So now we have numerous, at least 2 to 3 drugs which could be beneficial in reducing the heart failure hospitalization in HFpEF patient as well. Then there is a concept, devices which are being studied for HFpEF patients. So basic pathology for HFpEF is LV dilatation or LV hypertrophy or autonomic imbalance. So you are dealing LV dilatation by producing intra-atrial shunts to decrease the LA pressure. You have atrial shunts to expand the LV volume. You have left ventricular expanders, and then you have a stimulation therapies for autonomic imbalance. These are all under trials, but these are there. So various modes of device therapies are intra-atrial shunts, implantable CPWP like left atrial pressure monitors, the cardiac contractility modulation, renal denervation, baroreflex activation therapy, vagus nerve stimulation, and splanchnic ablation therapy. These are all device-based therapies which are being studied for HFpEF patients. So these are the trials which has been done for atrial shunts, for the CardioMEMS or the remote monitoring of pulmonary artery pressure. You put in these CardioMEMS in the pulmonary artery invasively, and you just have data with you as how's the pressures monitored, and then you manage those patients or alter the therapies by using these techniques. So you have trials. The latest trial is a positive trial for that is Monitor HF 2023 trial is there. And then you have Optimizer Smart, that is CCM. These are all modulators which modulates the function of the heart. Then you have various other modes. These are all therapies which are under trials, which might come as later on as FDA approval and maybe class 2A indication later on. So take home message for the HFpEF patient is basically the HFpEF, we must understand it is not just a disease, it is a heterogeneous syndrome with various phenotypes. So you try to classify those patients into obesity related or coronary artery disease related or according to pathophysiology whether LA is more abnormal or left ventricular hypertrophy component is produced. So you have to classify that particular syndrome into particular phenotype. And then there is evolution in the form of these scores which are crucial for the diagnostic accuracy so that we don't miss HFpEF patient. That's why probably in Indian registries, the component of HFpEF is less compared to HFrEF. So overall worldwide, because they have better diagnostic algorithmic strategies, so there it is 50-50%. In India, it is like 60-30%. Then we have emerged SGLT2 inhibitor as a breakthrough first pillar for the management of HFpEF patients, and finerenone is likely to come up as a second pillar, and following that ARNI and semaglutide are already in line and are being studied in the this thing. And the potential device therapies are still in the experimental stage. So thank you.
Thank you very much, Dr. Pupinder. Great talk. And heart failure with preserved ejection fraction, I think it is coming up in a very big way, and people are being sensitized by lectures like yours to look for heart failure with preserved ejection fraction. Otherwise, it is a neglected entity and nobody is caring about it. Definitely. And with introduction of SGLT2 and other modalities, so it is good to have patients under control and being treated great. Yes. Thank you very much for your enlightening talk.
Thank you, sir.
Any questions? Thank you.
Thank you, sir, for your informative presentation. Now we'll proceed forward with the poster presentation certification. I'll request Dr. Rajiv.
We will do it after next lecture, please.
Sorry, the next presenter is Dr. Vikas Lakhanpal, Assistant Professor, Department of Neurology, AIIMS Bathinda, for his presentation, Newer Therapies in Parkinson Disease.
A very good afternoon to all of you. So let's move on from heart to brain. The topic is neurotherapeutics in Parkinson disease. So I will be discussing the topic in following subheadings: the introduction, what is Parkinson disease, what are its clinical manifestations, and brief about its epidemiology, and subsequently, what are the newer symptomatic therapies, be it invasive or non-invasive in Parkinson disease, and finally, if at all there are any disease-modifying therapies which has been developed or under in various phases of or trials are present or not. So first of all, what is Parkinson? So it is a neurodegenerative condition characterized by loss of dopaminergic neurons in substantia nigra and is characterized by presence of Lewy bodies. Levodopa is still considered the gold standard that controls the motor deficits in early stages of the disease. However, the caveat is that once we start levodopa, after 3 to 4 years, the patient starts giving us symptoms which are not controllable with levodopa, which is the conventional and most widely spread treatment which is being used in Parkinson disease. So the Parkinson disease, it is a growing source of disability and mortality among neurological disorders. Ours is a 140 crore population country, and accounting to Parkinson disease, accounts for around 1 crore population of ours is suffering from Parkinson disease. And I'm talking about only idiopathic Parkinson disease. I'm not talking about all other Parkinson's plus syndromes. So idiopathic Parkinson disease accounts for around 1 crore of our population that is affected with IPD. So what are the stages of progression? The first stage is preclinical PD. The patient doesn't present because the symptoms are very minute, also known as honeymoon period, and subsequently which is followed by early stable period in which the symptoms are dramatically responsive to levodopa or the conventional therapies. And finally the clinical PD, where we see all kinds of fluctuations, motor fluctuations, gait abnormalities, psychiatric manifestations, cognitive disturbances, and where our clinical practice, clinical judgment, and newer therapies come into place. So a brief about major non-motor and motor manifestations of PD. We always know there are the 3 cardinal manifestations: resting tremor, bradykinesias, and rigidity. This is the cardinal 3 pillars of Parkinson disease. According to the latest guidelines, bradykinesia and rigidity are more important than tremor. We divide Parkinson into 2, a tremor predominant IPD and a rigidity predominant IPD. So bradykinesia is a must for a person to be diagnosed as having Parkinson's disease. Tremor may or may not be there. And other non-motor symptoms are like hyposmia, fatigue, depression, and constipation. Later on, as the disease progresses, I've already told you the symptoms develop in form of psychiatric manifestations, autonomic disturbances, and finally a stage of cognitive impairment also. So what are the caveats or what are the issues which we are daily facing with levodopa? The classical syndopa preparations or LCD preparations which we are using. It has a irregular gastric emptying time, a variable jejunal absorption, and it competes with dietary amino acids and has a irregular absorption and an extensive first pass metabolism and has a very short half-life. So what these all the issues lead to? They lead to these side effects. It leads to early wearing off. Wearing off means that as the drug is having a very short half-life, we need to give the levodopa preparations in more frequent dosages. Delayed on. So before going further, in Parkinson, we always call on and off period. So what is on? On is when the person is responding to drugs, the symptoms are dramatically controlled with levodopa preparations, and off phase is when the person is not responding to drugs or the medications, and if we are giving the medication also, the patient is still not responding to medication. So if because of delayed gastric emptying, decreased intestinal absorption, the effect of the symptomatic improvement with levodopa is not seen, that is known as delayed on. And finally, a dose failure. We are giving levodopa, but the symptoms are not getting improved because of abnormalities in gastric emptying, blood-brain barrier transport deficits. So this is the protocol, or this is the chart which we are daily following in our treatment guidelines. Initially, we used to treat with levodopa, dopamine agonists, and MyoB inhibitors. And when tremor predominant disease, we sometimes use with pacitane or trihexyphenidyl and propranolol. However, what's the need of the hour? The need of the hour is to have a drug that have a better absorption, a better bioavailability, and should be a longer acting and with better modes of delivery system, and should be cost effective in our scenarios. So these are the latest newer formulations which has come into our market. Few are available and few are not. They are in the various phases of development. So I will be discussing those in subsequent slides which are being available in our in India or which are not. So first of all, coming to Rytary. So Rytary is levodopa carbidopa microbead preparation, which is oral, longer acting and immediate extended release. It helps in giving fewer dosages and increases the interval gap between the treatment. And the adverse effects are similar to the conventional levodopa carbidopa preparation, and the side effects are almost similar. So the trials have shown that these Rytary preparation or microbead preparation reduces the off period by additional 1 to 2 hours, and it increases the mean on time by around 1 to 1.2 hours. Next is transcutaneous levodopa. It's not available in our market. It is available in US and has been FDA approved. This, as our skin has a poor penetration to polar drugs like levodopa, with the use of ethanol and methanol, we can deliver levodopa from our skin to our blood. So this is in this diagram you can see that it's type of patch device which we can apply on our skin and helps in delivering levodopa and carbidopa to our blood. And this helps in maintaining a continuous dose or having a steady effect on our symptomatic on our symptoms. Studies have also shown that it also increases the on time and decreases the off time. Next is inhalational levodopa, also known as Inbriza. It was approved by FDA in 2018. It is an oral inhalation powder consisting of large porous particles, and it is approved for the treatment of off periods in conjunction with levodopa and carbidopa preparation. It comes in a small pocket-sized breath-actuated inhaler and helps in rapid attainment of plasma concentrations and can be self-administered by patients. Next is apomorphine. This has come to our country around 4 to 5 years back. It's a potent dopamine receptor agonist, has a high affinity for D2, D3, and D4 receptors, and good activity on D1 receptors. You can see in this figure, it comes in a pump which can be placed in the patient's pocket, and it delivers the drug through skin to the blood. So it helps in increasing the on time, decreasing the motor fluctuations, and decreasing the fascination gait and the gait abnormalities which the Parkinson disease patients suffer in mid to late stages. The only issue is cost. In our country, the patient used to get these pumps on rental basis, which cost around 1 to 2 lakh per month on rental. The drug is the drug which these pump deliver is cheaper. Next is safenamide. It has been approved by FDA in 2017, oral reversible MAO-B inhibitor. This I use in mid to late stage Parkinson disease, come in 50 or 100 milligram tablets. The main side effect is in patients with hepatic dysfunction, we cannot use it, and most common adverse effect is mild to moderate dyskinesias. However, once the person lands up in late stages, he is not that much worried about his dyskinesias. He just want to get relief of his bradykinesia. So in those late stages, this drug is being used in our practice for last 3 to 4 years. We all know about COMT inhibitors, classical COMT inhibitors like anticapone and tolcapone. Recently into market, opicapone, a new drug has come. It has the major advantage of opicapone over anticapone and tolcapone. It has a longer half-life because of its longer duration, high binding affinity, and it helps in the side effects of anticapone are comparatively less as compared to opicapone. The major side effects are impulse control disorders with these COMT inhibitors, which are comparatively less in opicapone patients as compared to anticapone and tolcapone. The trials have also shown that it has caused a significant reduction in off time and has an increase in on time, and also has shown that it helps in decreasing the dyskinesias, which are the major side effects with levodopa carbidopa per patients. Next is istradifylline. It was approved by FDA in 2019, as selective adenosine A2 receptor antagonist, and it helps in decreasing the excessive activation of indirect pathway. One should know that this nigrostriatal pathway has 3 pathways. One is direct, one is indirect, one is hyperdirect. So these all pathways contributes to the pathophysiology of Parkinson disease. So this istradifylline drug, which is an adenosine A2 receptor antagonist, it decreases the excessive activation of indirect pathway and ultimately decreases the bradykinesia part of Parkinson disease. This drug has also shown to be effective in overactive bladder and daytime sleepiness. We all know that ultimately all Parkinson patients experience psychotic manifestations like visual hallucinations, paranoid delusions. We always use atypical antipsychotics or other drugs along with anti-Parkinson drugs. However, recently pimavanserin has come into our market. I think within 1 to 2 months it will be available with us. It is a selective inverse agonist at 5-HT2A receptor and has a 40-fold higher affinity for 5-HT2A receptors. And it comes in a dosage of 34 milligram. Now moving on to invasive symptomatic therapies. In all these invasive therapies, almost all of them are available in our country. First is levodopa intestinal gel. It was approved by FDA in 2015. It comes in an aqueous carboxymethyl cellulose gel suspension, and it is administered with a programmable infusion pump. The tube or the delivery system is attached to the jejunum through percutaneous transgastric endoscopic gastrojejunostomy, which we also known as PEG. And it can be used for as long as 10 to 12 years. It is indicated for patients who are experiencing significant off periods despite giving maximum tolerable doses of levodopa, and symptoms are mainly still when the symptoms are mainly still levodopa responsive. So the studies have shown that it has reduced significant off periods and increased significant on periods in Parkinson's disease. The Gloria registry has also demonstrated the same, that it is far more effective than levodopa, carbidopa conventional preparation. Moving on to MRI guided focus ultrasound. So in this, with the help of ultrasound, we give a dithermy to the nucleuses of basal ganglia, which contributes to the symptoms of Parkinson's disease. It has 3 stages: sonication, temporary effect, and ablation stage. I will not go into the details of these. So the targets of this MRI guided ultrasound therapy is we ablate or we give a dithermy to these nucleuses and decreases their activation. For example, ventro-intermediate nucleus of thalamus, if it is ablated through this technique, it will help in reducing the tremor predominant stage of tremors in Parkinson's disease. Subthalamic nucleus, if it is ablated, it can help in reducing rigidity, akinesia, and tremors. And GPI, if it is ablated, it can result in decreasing rigidity, akinesia, tremors. However, what are the limitations of this? Because the targets are different, we sometimes might be confused that which target is to be utilized for symptomatic relief, because one target will help in giving a relief of particular symptom, not all the symptoms. And sometimes we have to give high temperatures and repeated ablations to a particular nucleus once the symptoms wean off. Moving on to deep brain stimulation, the talk of the town. The deep brain stimulation is an effective therapeutic tool for Parkinson's disease with troublesome motor fluctuations and dyskinesias reflected to best medical therapy. It is approved for PD tremors in 1997. For last 30 years, it is with us. However, only in last 3 to 4 years, it is being used for early PD. Previously, we were using it for only patients who are having advanced or mid-stage PD. Now this is being utilized for early PD. The only issues were that if we use it for early Parkinson's disease patients, we might miss the patients who are not suffering from PD. For example, if a person is suspected to having PD, in next 1 to 2 years, he might turn out to be having a Parkinson plus-like syndrome, for example, PSP, which is a close mimicker of IPD. So in that scenarios, we have to be vigilant that which person is to be chosen for DBS and which is to be not. In this, stimulating electrodes are inserted into the brain with the help of a stereotactic frame and MRI, and various nucleus which I've already mentioned, for example, ventro-intermediate nucleus of thalamus, GPI, subthalamic nucleus, pedunculopontine nucleus can be the locus for insertion of these leads, directional leads, and ultimately this is connected to a stimulator electrode like a pacemaker in cardiology. This giving a particular stimulations to these nucleus and helping relieving the symptoms. What are the inclusion criteria for a person to be taken for DBS? So one should be particularly convinced that person is having IPD and he should be levodopa responsive. The exclusion criteria is, I have already mentioned, atypical Parkinson like PSA, MSA, CVGD, and those having Parkinson's disease, dementia, and severe depression or psychosis. In our clinical practice, all the patients who has a significant improvement in UPDRS score or in simple language motor complications of Parkinson's disease, more than 40% with levodopa, we always think of giving the patient advantage or giving an option of DBS to these patients. DBS can be done both in sleep and awake stages. However, the advantages of sleep is more as compared to awake. The DBS is of two types, closed loop and open loop. Closed loop is when the closed loop is when the patient can stimulate, or when the patient himself can stimulate his in various nucleuses according to the symptom profile. Open loop is like after 3 to 5 months, the doctor has to modify the stimulation or the pacemaker according to the patient's symptom progression or his response to the DBS. Now moving on to disease modifying therapies. I have already told you that this is all is symptomatic therapy. So have we got any drugs which can retard the progression of disease or which can eliminate the disease? So we know that this disease is because of accumulation of alpha-synuclein protein. So if we can decrease the production of alpha-synuclein protein, we can retard the progression of disease. So this can be done with various trials are underwent. For example, if we can, at the genetic level, we can introduce RNA molecules to trigger the synthetic post-transcription silencing of alpha-synuclein gene, we can decrease the production of alpha-synuclein protein and ultimately the formation of Lewy bodies. Vaccines have already also been also in various trials of development, and also various smartphone apps have also allowed the neurologist to go beyond clinical assessments for Parkinson disease for consultation and deciding upon which dose is effective. Little bit about genes. Various genes are available. Genetic genes are involved in Parkinson disease pathogenesis. So this is today is the time of precision medicine and precision neurology. So various trials are being underwent that decides that are being utilizing these gene targets and the products of these genes for developing drugs which can retard the progression or halt the progression of this disease. Thank you.
Thank you very much, Dr. Vikas, for giving us a real insight. What are the newer therapies in Parkinson disease? Because when we were students, only alpha-methyl-dopa and you can say the other drugs were there just to control the symptoms. Thank you very much for apprising us what is new, and we may be able to modify the disease process rather than treating it symptomatically. Thank you very much. Now I'll invite Dr. Jagjit Singh Bhaiya, the versatile. Okay, then we will take the liberty to distribute the certificates for our poster presentation. Sare hasan lag gaye vi 30 minute ਹੋਰ ਬੈਠਣਾ ਨਹੀਂ ਪਊਗਾ ਹੈ ਨਾ. So that is the tragedy. So I'll request Dr. Rakesh Kakkad to please come on stage. आप भी आइए डॉक्टर साहब. And invite Dr. Thapar to please come and distribute the certificates to the poster presenters.
Now I request Bharat GR to please come on the stage.
I request Dr. Jagjit Singh Bhaiya, Professor and Head, to join and bless the paper presenters. ਪਹਿਲਾਂ ਆ ਜਾਂਦਾ ਇਹਨਾਂ ਨੂੰ 20 ਮਿੰਟ ਲੇਟ ਹੋ ਜਾਂਦੇ.
Garima.
Please line up here. ਤੁਹਾਡਾ ਹੀ ਟਾਈਮ ਬਚਣਾ ਹੈ ਕਿ ਤੁਸੀਂ ਬੈਠਣਾ ਤਾਂ ਹੈ ਨਹੀਂ, ਉਸ ਤੋਂ ਬਾਅਦ ਦੌੜ ਜਾਣਾ. इकट्ठे बोल दो बेटा सारे.
हरगुन कौर खैरा, हिमांशु अट्री, कंकल लुटिया, कृतिका रानी, पायल,
So thank you very much for coming to MAPICON, and we invite you next year also. Please be our brand ambassadors to motivate your juniors to present papers. Okay? We will not able to sensitize much of the AIIMS PGs to present papers, so we depend upon you. Maybe next year we will be organizing this conference out of AIIMS. And you know why.
Raju Chauhan. Ravi Pratap Singh. Sakshi Sharma.
Doctor Saab, please. Dr. Ji, na ji na, thode bina ta hona hi nahi, ruk jo bhai. Sir. So all photographs will be uploaded on the website, so you can get it from there because these are memorable
Dr. Shiva
events.
R.
वैसे तो आपके दोस्तां ਨੂੰ ਤੁਸੀਂ ਦਿੱਤਾ ਹੋਊਗਾ
Dr.
mobile
Yashpreet
kitchen
Singh
ਵਾਸਤੇ.
Sandhu. And then Dr. Kriti Kalra.
Thank you very much again. You are the young generation keeping alive the academics. Okay? So best of luck for your future endeavor and academics. Thank you very much. With this we complete, and we are grateful to Dr. Rakesh Kakkad and his team for conducting this paper session, as well as before that the quiz. Excellent quiz. Thank you very much. And now I invite Dr. Jagjit Singh Bhaiya, all in one. He is Professor of Medicine. He is an actor who has made 3-4 films, as well as a great singer. ਹੁਣ ਆਪਾਂ ਇਹਨਾਂ ਨੂੰ ਕਵਾਂਗੇ ਨਹੀਂ ਵੀ ਗਾਣਾ ਸੁਣਾ ਦਿਓ, ਨਹੀਂ ਤਾਂ ਇਹਨਾਂ ਨੇ ਚੁੱਪ ਹੀ ਨਹੀਂ ਕਰਨਾ. So, great to have you. He is an integral part of MAPICON. He is a good friend and a great human being. Thank you very much.
Dr. Bitul Gupta. I think my dear brother and beloved colleague, Dr. Bitul Gupta. Thanks for inviting me on this auspicious occasion of MAPICON. So, we will discuss the dengue. Dengue is a sort of a pressure cooker situation. The layman treats dengue with the platelets counts. आज इतने बढ़ गए मार्केट की, स्टॉक मार्केट की तरह आज एक लैब से आ गया 15,000 आ गया, 20,000 आ गया, 40,000 हो गया, 50,000 हो गया. But they only treat platelet counts. They don't treat a dengue shock. Dengue shock syndrome is the killer one. Dengue hemorrhagic fever is the killer one. My topic is to overall review of a dengue shock syndrome. For medical graduates, you must know, sometimes we are unable to document the dengue, but we label it a dengue-like illness. So asymptomatic dengue viral infection may occur, and undifferentiated dengue fever, then dengue hemorrhagic fever, which may lead to dengue shock syndrome. Dengue shock syndrome. That is the dengue hemorrhagic fever and dengue shock syndrome is the key point in today's lecture. So basically what happens in dengue shock syndrome? Dengue shock syndrome, endothelial dysfunction, endothelial suction, which increases the vascular permeability and plasma leak. And that lead to shock. Plasma leak is lead to shock. And that system is not well understood, but may be considered that is the immune-mediated trigger of plasma leak, endothelial dysfunction. So, when dengue comes, and there is always hue and cry in the media, and the leading paper like Hindus write about the cost of treatment of dengue. It cost a bomb. कहते बहुत ज़्यादा महंगा है. 10 से 15,000 का एक प्लेटलेट काउंट मिलता है, 4 प्लेटलेट चढ़ाने होता है, 40,000 इंक्लूडिंग हॉस्पिटल स्टे चार्जेस, एंड पेशेंट अपने खाने का बिल भी बीच जोड़ देता. 1.5 लाख लग गया मेरा डेंगू पे. हमारे RMP ने और केमिस्ट ने 20 रुपए में ठीक कर दिया डेंगू. Yes, it's true. You can treat a dengue fever with a 20 rupees and it may cost up to 20 lakhs. How comes? If complicated dengue is there, dengue hemorrhagic fever or dengue shock syndrome, and definitely survival rate is very less, very less. So that's the scenario. New York Times, all over the globe. ऐसा नहीं है कि डेंगू अब ट्रॉपिकल डिजीज है, ट्रॉपिकल मेडिसिन में ही पढ़ना, ऑल ओवर द नॉर्थ अमेरिकन साउथ अमेरिकन कंट्री, Mexico and Brazil and other countries are lot of incidences of dengue too, and African countries and Asia and even Australia. So the report is there, the war on dengue fever. और ऐसे रिपोर्ट करता, war, there is a tiff, there is a fight, there is a war. You all well understood about the term war. So it's also giving an overall view of the burden of dengue illness and its economic cost in Americas. Same New York Times. क्या कहता है? Mexico में 1 day की cost है, you can see, about $1,800 per day. About 1,800, and followed by Brazil, about $1,100. Then Colombia, then Republic of Dominica. You see the cost of treatment, very much costly in South America. So, Indian media भी बोलता, BBC बोलता, कहता है, India will probe a dengue fever death of Yash Chopra. If a famous celebrity died because of dengue fever, a lot of debate in the media. Global burden, you can see the global burden everywhere, dengue from Australia to America. Everywhere. Australia, Asia, Africa, and America, South America. Everywhere. It's the global pandemic. But you see the burden from 1955 to 2007, you can see exponential rise of dengue. According to WHO current data, you see 5.2 million, 50 lakh हो गया, million mean 50 lakh हो गया. Then 2023, about 6 million, 6.5 million, 65 lakh. So, and though a dengue में death rate is very less, but dengue hemorrhagic fever and dengue shock syndrome death rate is very high. Very, very high. So, current scenario, अभी April 2024 तक current scenario about 7.6 million dengue के patients आ चुके हैं. अभी साल पूरा पड़ा है, हो सकता है 10 millions हो जाएं. Okay, and till date 300 deaths. It may be because of dengue hemorrhagic fever or dengue shock syndrome. Simple dengue is not going to kill. So for medical graduates, it's a vector-borne disease, okay, spread by Aegypti and Albopictus, we do call tiger mosquito. So about the virus, it's a RNA virus having 4 subtypes, dengue 1, dengue 2, dengue 3. So you can see the structure of this virus. This is the inside the viral genome, nucleocapsid, and the membrane E and M protein is there, and embedded in the viral infra. So RNA, it's like a COVID, it's a RNA virus. So infection from one type of, suppose कर लो type dengue type 1 से infection हुआ, it may cause lifelong immunity, and but short immunity for other types. So and subsequently infection from the different types of subtypes, okay, lead to severe complication, dengue hemorrhagic fever or dengue shock syndrome. So this is the if someone is having dengue, and these are the clinical features of high grade fever, headache, vomiting, bone break fever. Basically, the first day 1, the patient may have severe myalgia and the pain, joint pain. That's why it's called bone break fever. यही प्रेजेंट करता, फीवर 2 दिन बाद आएगा, 3 दिन बाद आएगा, after 2 and 3 days. So rashes may appear, rashes like this. So we divide this dengue fever or dengue febrile phase, critical phase, and recovery phase. How? This is the febrile phase, sudden onset of fever, headache, mouth and nose bleeding, muscle pain, joint pain, vomiting, rash and diarrhea, simply diarrhea, dengue virus can cause diarrhea. Critical phase, critical ho gaya. Hemorrhagic fever and dengue shock syndrome, we include this, the hypotension, pleural effusion, ascites, gastrointestinal bleed. Recovery phase mein altered sensorium, seizures, itching and slow heart rate may be there. So dengue, clinically, dengue fever, sometimes we call undifferentiated fever, sometimes dengue hemorrhagic fever, which can result to a bleeding and low platelet count and plasma leak. And eventually, this can cause dengue shock syndrome, right? And dangerously low, blood pressure is dangerously low. You have to treat as a clinician, as a doctor. मैं कह रहा हूँ ना, डेंगू RMP भी ठीक कर देगा, केमिस्ट भी ठीक कर देगा, घर पे भी ठीक हो जाएगा. But crux of the story is that you must manage properly dengue hemorrhagic fever and dengue shock syndrome. So, how to diagnose dengue? कि डेंगी है. Sometime notice आ जाएगा भाई आपने डेंगी लिख दिया, टेस्ट में तो डेंगी आया नहीं. Some tests are approved by government labs or government कि हम तो डेंगू तभी बोलेंगे NS antibodies positive आए, not antigens. So till then you can mention, okay, dengue-like illness with thrombocytopenia, with rashes, right? So you can go for antigen test, you can antibody, viral isolation and sportive investigation. Sportive investigation are very much important in dengue shock syndrome. कैसे? हेमाटोक्रिट का बहुत बड़ा रोल है. डिस्कस करेंगे हेमाटोक्रिट. This is the illness. A day of illness 1 to 10. You see, सारी गेम डेंगू की 10 से 14 दिन की है. 2 weeks, 1 week to 2 weeks है डेंगू total. Temperature, first 1 to 2 days, temperature is high. You can see 101, 102 or 40 degree. Okay. Then you can see the critical, the potential clinical issues. Clinical issues क्या हो सकता है? जब आपको फीवर है तो डिहाइड्रेशन का ध्यान रखना. पेशेंट में हैव डिहाइड्रेशन. डिहाइड्रेशन के बाद शॉक हो सकता है. शॉक एंड ऑर्गन डिस्फंक्शन एंड reabsorption of fluid in the recovery phase. Then followed by laboratory investigation. कुछ laboratory आप लैब बताएगा क्या क्या हो सकता है. You see a dotted line. A dotted line is the hematocrit, very much important hematocrit to monitor the dengue shock syndrome, hematocrit and the viremia. 1 to 3 day viremia is high. The viral load is high. 3 दिन तक. तभी आप NS1 एंटीजन पॉजिटिव होगा. NS1 एंटीजन पॉजिटिव होगा फर्स्ट 3 डे. बाद में भी रहेगा पॉजिटिव, लेकिन अर्ली. देन you can see the hematocrit is initially normal or low. Then hematocrit in the critical phase start rising. Hematocrit के और भी 3-4 नाम है, बताऊंगा मैं. Let you know. This is, then see the platelet count initially high. In the critical phase, patient's platelet count drops very fast. Very fast. Then you can see initial stage में virology and serum. Serology में antibodies comes after 3 to 7 days. IgM and IgG. First IgM आएगा antibodies. Then you can see the viremia is already there from day 1 to day 3. Okay, here you can detect the NS1 antigen. So basically antigen test, जो antigen test सबसे पहले बोला, I spoke about the day 1 से positive होगा, day 1 से. So you can capture in the ELISA based NS1 antigen test in acute dengue infection. Acute में NS1 antigen, simple test, more specific and more sensitive, but not recommended by the government. What क्या? Government, this is the NS1 क्या है? Non-structural protein 1. Okay. This test, NS1 antigen, is well before the antibody formation is positive. So, other proteins like M proteins and E proteins are also present. But this non-structural protein is very much significant to diagnose the dengue fever. So there are other 7 type non-specific proteins, but their function and their role is not well understood. You can only go for non-structural protein. कौन सी test करते हो? It still don't know, right? So दूसरा है serology, antibody testing. Okay, IgM can be detected by MAC ELISA test. This is simple antibody. It comes positive after 4 to 7 days. Viral isolation, viral culture, viral PCR and RNA detection, reverse transcriptase. Because this is RNA virus, it would having the enzyme reverse transcriptase like a COVID virus or dengue virus. So, leave it. Capillary leak. What is the mechanism of capillary leak? In that the autoantibodies are present in the blood, okay, or cross-react with the platelet can cause thrombocytopenia. Platelet count is drastically low, very low, and non-infected, and this may infect the endothelial cell, which lead to the thrombocytopenia and capillary leak, eventually lead to dengue hemorrhagic fever and dengue shock syndrome. Right? Dengue shock syndrome. So causes of thrombocytopenia in cases of dengue, you can destruction of platelet by autoantibodies and DIC, and the bone marrow suppression because of viral illness. Patient intake is very poor and directly can cause bone marrow suppression. So these are the 3 reasons behind the low platelet count in a dengue patient. So IgM antibodies come positive after 4 to 5 days of test, can be persist for 90 days and can be weaned off at 60 days. So you can see all the serology, viremia, NS1 antigen, IgM, IgG, IgG2. How it comes positive in the total spectrum of dengue syndrome or dengue fever or dengue undifferentiated dengue. So can an M antibody जो करते हो आप other disease में भी positive हो सकता है. Those are same family viral illness like Japanese encephalitis, St. Louis encephalitis, West Nile 5, yellow fever, Zika virus. इसमें भी positive हो सकता है IgM antibody. So in that situation, you must take a detailed history. Patient travel to that country where Zika virus, yellow fever, West Nile and St. encephalitis and Japanese encephalitis is common. So hematocrit की बात. What is hematocrit? Is very much important for management of dengue shock syndrome or dengue hemorrhagic fever. The दूसरा नाम है इसका packed cell volume. And volume packed red cell, BPRC, and erythrocyte volume fraction. So it derived from a so-called Greek word known as hemocrates, means judge, total separate blood. And it's the volume percentage, you see, the volume percentage of RBCs, 100 ml blood लिया, कितने RBCs हैं, और कितना leukocytes हैं, कितना plasma, that's all. This is hematocrit, right? So hematocrit is normal. Male में कितना, female में कितना, ladies और gents में कितना, okay? It's 40 to 50%. And 36 to 44 in women. Low in anemia, blood loss, low हो जाएगा. High in dengue shock syndrome or polycythemia vera. Polycythemia, maybe polycythemia because of unknown etiology, maybe because of high altitude, maybe because of smoker. उसमें भी hematocrit high होगा और packed cell volume high होगा, right? This is the total. How you will say it's a another test. आप अगर आपके पास सीरोलॉजी नहीं है, एंटीबॉडी टेस्ट नहीं कर सकते, आप मोहल्ला क्लिनिक के पोस्टेड हो तो टॉर्निकेट टेस्ट कर लो, राइट? मोहल्ला क्लिनिक पे नहीं होगा आपको, हो सकता है कि NS1 एंटीजन ना हो सकता है एंटीबॉडी टेस्ट ना हो, तो ये कर लो. CVC भी नहीं कर पा रहे, सपोज कर लो, प्लेटलेट काउंट. सो ओके, इन्फ्लेट द कफ, the blood pressure, cough between diastolic and systolic for 5 minutes, inflate कर दो. And count the capillary, compound the bleeding spot, petechial hemorrhage, कितने bleeding आए. So this is the, Supportive, this is the treatment of acute dengue fever. अगर फीवर है आपने वॉच रखनी है पेशेंट को, डिहाइड्रेशन होने नहीं देना. आपके पास डेंगू वायरस को किल नहीं कर सकते. यू आर हैविंग सपोर्टिव ट्रीटमेंट और सिम्टोमेटिक ट्रीटमेंट. ओनली सिम्टोमेटिक ट्रीटमेंट है, तो सपोर्टिव ट्रीटमेंट इज द की. तो पैरासीटामोल देना, हाइड्रेशन अच्छा रखना. सिंपली अगर सिंपल डेंगू फीवर है 7 दिन में ठीक हो जाएगा, 7 days 1 week में. ओनली पैरासीटामोल 20 रुपए हो गया ना. बट if you must avoid the NSAIDs, brufen, other brufen like other drugs, aspirin must be avoided. Bleeding हो जाएगी, low platelet हो जाए, that's why avoided. And but important is maintaining the fluid, hydration अच्छा रखना पेशेंट का. उसको वो कल्ला पानी नहीं पी जाए, कल्ला कीवी नहीं खाई जाए, कल्ला वो नहीं पी जाए, सो कॉल्ड पपीते के पत्ते, पपीते के बीज, ऐसा कुछ नहीं देना. नॉर्मल डाइट, हाई लिक्विड डाइट. हाई लिक्विड डाइट का मतलब दूध ले ले, कॉफ़ी ले ले, जूस ले ले, सूप ले ले, राइट, नींबू पानी ले ले, करेक्ट. तो मेंटेन द एडिक्वेट फ्लूइड बैलेंस. बट पानी पिया, यूरिन को देखना है. इफ यू डोंट हैव एडवांस फीचर्स ऑफ मॉनिटरिंग ऑफ डेंगू, तो चेक कितना पानी पिया, यूरिन कितना आया, दैट्स ऑल. एंड चेक द ब्लड प्रेशर. Okay, look for warning sign. If no warning sign, patient can be managed at home. But if severe dehydration is there, okay, along with the warning sign, patient must be managed in the hospital. Blood pressure low, urine output is less, patient is having bleeding sign. Bleed हो रहा, upper GI bleed होगा, nose से bleed हो रहा, lower GI bleed हो रहा, lot of cases are there. Immediately ask the patient to keep in the hospital. Admit, okay, stay in the hospital, don't discharge. So these are the warning sign. These are the warning sign. Lot of warning sign is there. Okay, may have severe abdominal pain है, persistent vomiting हो रही है, पैरासीटामोल कैसे दोगे, फ्लूइड कैसे दोगे, must be admitted in the hospital. Mucosal bleeding है, lethargy हो रही है, right, lethargy हो रही है, LFT enlarged, hematocrit in rising trend में आ रहा, high, hematocrit is high in rising trend. And that situation you must be careful, and that may lead to the shock and the fluid accumulation in the lungs may called respiratory distress. Okay, in that situation you must be careful about the warning signs. Okay, dengue shock syndrome must be admitted in ICU or emergency department. Maintain the IV line. अब देखना IV line, सर इसका प्लेटलेट काउंट तो 15,000 है, कैसे IV line डालूं? If peripheral access is there, no need of central line. Right? No need of central line. But patient is not taking orally. Okay, peripheral access though. No need of central line. Strictly monitor the intake output charting and blood pressure. Strict monitoring. The fluid must be started. Patient orally नहीं ले रहा. तो fluid. Here is the role of fluid. Fluid and fluid bus. That's all. This is the best supportive treatment in dengue. क्या fluid है? This is a central line. Various ways to put up patient cannulation by the central line. Okay, you can go for jugular, you can go for subclavian, you can go through the femoral route. Right? You can go through the femoral route. क्या बताएगा? आप फ्लूइड कितना देना ये भी असेस कर सकते हो सेंट्रल लाइन में. यू कैन मॉनिटर द राइट आर्टेरियल प्रेशर एंड राइट वेंट्रिकुलर फंक्शन. CVP monitor must be, okay, 2 to 8 millimeter of mercury and 4 to 12 centimeter of water. जो आपको दिया जाएगा ना वाटर कॉलम से मांग, you can measure with the water column. कितना है? 4 to 12 centimeter वाटर कॉलम से. So various level central venous pressure can be monitored at the sternal level or axillary level. Right? The water column is there and you can monitor. Normal, okay, very low CVP, less than 2 or 4 के नीचे आ गई, less than 2 millimeter of mercury or 4 millimeter of water. Rush the fluid. Rush the fluid. And more than 8 or 12 water का तो पेशेंट फ्लूइड ओवरलोड में है. You need a different way to save the patient. You must find out a different way to save the patient. Patient तो pulmonary edema चला गया, pulmonary edema made to right or fluid overload, more right RV or RA pressure, more. In that situation, you can diagnose whether patient is having heart failure or simply hypovolemia with the help of CVP. Monitor the CVP. Important consideration, interpretation of CVP. CVP कल्ला नहीं बचाएगा, उसके साथ other चीज must be correlated properly. CVP may give you a fallacious reading or you don't know how to measure the CVP. Correct? Heart rate देखो, blood pressure, urine output and respiratory distress. Correct? Must be watched. Safe central line. Central line पानी कब है और कैसे डालनी है? Central line. Correct timing of central line. Okay. If coagulation defect is there, transfuse that platelet and platelet count should be more than 50,000 डाल सकते हो. Okay. And always put a central line through a ultrasound. Okay, with the help of ultrasound guided central line placement. Correct? And careful site selection. You avoid a subclavian. Okay? Go through the jugular. Site selection is key. Right? Close monitoring post exhaustion. कहीं patient को bleeding तो नहीं हो रही, patient को sometime may have pneumothorax. Right? If peripheral, so you can start other supportive treatment is paracetamol you can give and fluid crystallide देना, जहाँ colloid देना. So this is the study of New York Journal of Medicine. Okay, basically crystalloid, ringer lactate and normal saline is the best one. You can start with the ringer lactate. इसने comparison करा ringer lactate and start other so-called hypertonic saline, hydroxygelatine or gelatins. You can start and volume expanders like albumin and other blood and gelatins can be started volume expanders, but some special set of patient generally preferred fluid is crystalline. Crystalline is normal saline or ringer lactate. So this is another study, fluid restriction. Okay, New England Journal of Medicine में एक और study छपी है 2022 में. तो fluid restriction वो कहता है कम दो ज़्यादा दो, does not matter at all, but must be given judiciously. According to the blood pressure, according to the finish कर दे. So conclusion. So warning sign done. How much is the fluid? कितना fluid देना? 5. Okay. 10 to 20 ml per kg per hour. एक घंटे में 20 ml per kg per hour के हिसाब से देना. So this is the, if systolic BP is more than 90. If less than 90, then 20. This is the algorithm. First hour में, okay, 10 ml per kg per hour के check करो फिर hematocrit and blood pressure. If normal, reduce the fluid. Reduce the fluid. Right? So same algorithm is there. If not normal, hematocrit and blood pressure is not normal, repeat the bolus dose with 20 nal, double nal, 20 ml per kg per hour. And follow this algorithm again. Hematocrit, blood pressure, urine output and discharge. Right? So role of platelet transfusion. Platelet transfusion unnecessarily नहीं करना. 20,000 से नीचे platelet है और sometime right now recent study saying 10,000 से नीचे है और पेशेंट को ब्लीडिंग हो रही है तब देना ब्लीडिंग और 20,000 से नीचे है राइट. अदरवाइज वेट एंड वॉच राइट. लो रिस्क में ट्रांसफ्यूट करना है अगर पेशेंट को लो रिस्क नहीं करना. सो स्टीरॉयड, देयर इज नो रोल ऑफ स्टीरॉयड इन डेंगू फीवर और डेंगू शॉक सिंड्रोम. ये स्टडी है. सो Platelet can be randomly donor platelets or Waficot or maybe single donor apheresis. Single donor apheresis से 50,000 एक बार में बढ़ जाता. How come? You can see. इसमें जो पहले वाला randomly donor है only 5 to 7,000 platelet. Okay, and this okay, single donor okay 50,000 platelets. एक रोल है इक्मो आई है अभी एक अभी रिसेंट बच्ची को लगा था 20 लाख लग गए मेदांता में और वो कहता उसको इक्मो भी दिया 20 लाख बचाने के लिए. इक्मो क्या है? एक्स्ट्रा कार्पोलियर मेम्ब्रेनस ऑक्सीजनेशन लाइक दिस डायलिसिस मशीन की तरह होता, प्लाज्मा एफरेसिस मशीन की न्यू यूनिटी. एंड दिस इज द इक्मो की ये सीरीज छापी है 4 पेशेंटों में, चारों में 2 डेंगू शॉक सिंड्रोम वाले आर सर्वाइव्ड. इक्मो okay, ECMO, right? ECMO can cause thrombocytopenia, can cause bleeding disorder, but timing and intervention is must, and it is very costly and time consuming too, right? And DD of dengue, lot of DDs of dengue. When to discharge a patient from the hospital? No fever for 24 hours, normal blood pressure, adequate urine output, no respiratory distress, and platelet count is more than 50,000. You can discharge the patient, right? These are discharge. Prevention, vaccine, dengue ka bahut zyada effective nahi hai, not effective at all, but can be used. Okay, WHO position on dengue. So prevention is always okay, keep sanitation proper and maintain the proper hygiene and destroy the mosquito breeding spaces. Take home message, okay, there is no need of unnecessarily transfusion of a platelet or plasma, and there is a highly need to monitor the supportive therapy like paracetamol and fluid. The best fluid is ringer lactate or normal saline. Or there is a role of recent advances like ECMO in the management of dengue shock syndrome. Thank you very much.
Thank you very much, Dr. Bhaiya, for an overview of really dangerous condition of dengue shock syndrome. Thank you very much.
Thank you for your informative presentation, sir. Now I'd call upon Dr. Prashant Chhabra, Assistant Professor, Department of Pediatrics, AIIMS Bathinda, for his presentation, The Thrombocytopenia Conundrum. Sorry.
Very good afternoon to everyone. So first of all, I would like to thank the organizing team for giving me opportunity to talk on this platform. And for the next 15 minutes or so, I'll be talking on this topic of core hematology, that is the thrombocytopenia. And the word conundrum literally means a puzzle, so it is not less than a puzzle to solve the cases of thrombocytopenia. And in the next 15 minutes or so, I'll be trying to simplify the approach to thrombocytopenia with the help of history, proper history, physical examination, and the laboratory approach. So as we can see, it's a conundrum. Across all the age groups, we have a numerous number of causes of thrombocytopenia. Some of them are overlapping in all the age groups, adults, children, and some of them are exclusive to one category. For example, gestational thrombocytopenia happens in pregnancy. Neonatal alloimmune and autoimmune thrombocytopenia happens only in neonates. And in the children, there may be some congenital disorders of platelet number as well as platelet function. And so with this, how do we classify thrombocytopenia? The normal platelet count is 1.5 to 4.5 lakhs, as we know, but again, this has to be taken with a pinch of salt, but that we know that there is a Gaussian distribution to everything. So less than 3rd centile and more than 97th centile, that is some of the normal population will be having a platelet count less than 1.5 lakhs, which will be normal for them, and some of the normal population will be having a platelet count more than 4.5 lakhs, which will be normal for them. So as per the classification based upon number, it can be classified into mild, moderate, and severe category, with mild being 1 lakh to 1.5 lakhs, moderate being 50,000 to 1 lakhs, and severe being less than 50,000 per microliter. Having said that, one should bear in mind that there is not a strict linear correlation between the drop in the platelet count and the risk of bleeding. The risk of bleed is highly unpredictable, and it depends on upon the lot of factors, including the underlying condition. and hence the cutoff should be read in the context of the underlying disease. So we'll try to understand this with the help of examples. Suppose we have a 12-year-old kid with chronic ITP, has never bled in the past and has a platelet count 20,000, which has remained stable over a period of time. Then we have another case who is again a 12-year-old. He has dengue fever with a platelet count of 20,000 and has an immature platelet fraction of 15%. What is this IPF? I'll come to that later. And we have same 12-year-old boy who has leukemia, underlying pathology, and platelet count of 20,000. So what do we think out of these three cases, which one has the highest propensity to bleed and which one has the lowest propensity? So the case one has a chronic condition, has remained stable, has never bled, so he has a low risk of bleeding. With the same platelet count, a child with dengue, but with high IPF, which is a recovering marrow, will again have a low risk of bleeding, but higher than that of the first case one. And whereas the case 3 will have a highest risk of bleeding. So then if at the same platelet number, the different individuals have different risk of bleeding, then what actually determines the risk of bleeding? So when to worry about bleed? So as we discussed, apart from platelet number is 1, severity can be predicted, but apart from platelet number, the platelet dysfunction. A lot of disorders are there where apart from thrombocytopenia, there is platelet dysfunction as well. One has just been discussed, the dengue fever, and there are some inherited platelet number disorders like Bernard-Solier syndrome, which also has inherent platelet dysfunction. So those patients have a higher risk of bleeding. If the patient has associated coagulation abnormalities, for example, the patient is in DIC with consumptive coagulopathy, then he has a higher risk of bleed. And if your marrow is not responding or not producing platelets well, that can be read through a surrogate marker of immature platelet fraction in the peripheral blood. So if marrow's production is robust, even despite having a low platelet count, the propensity to bleed will be low. For example, if we see in majority of our immune thrombocytopenia cases, they have a very low platelet number, but despite that low platelet number, their marrow is robust, it is producing at a higher rate. Hence, most of these patients have a low risk of bleed. Apart from these physiological factors, there are some host factors, like if there is past history of clinically significant bleed in the host. If a host or patient has bled in the past, then there are higher risk that he will bleed again with the same low platelet number. Or if a patient is having bleeding in form of wet purpura in the oral cavity or hematuria. So these are the sites, if they are involved, then higher risk of bleed is there in the future as well. So coming to surgical procedure, is there any safe cutoff to say that this is the safe cutoff for a platelet count to go for a surgical procedure? Unfortunately, in the evidence-based studies, the cutoffs have been arbitrary, and it is not an evidence-based. One particular cutoff can be suggested, but in general, platelet count more than 50,000 is suggested a safe platelet count generally, whereas in some high-risk procedures such as neurosurgical procedures or major cardiac or orthopedic surgery, one has to maintain a platelet count more than 1 lakh. Whereas some other procedures like cataract surgery, dermatological procedures, or bone marrow aspiration and biopsy, they can even be performed at a lower platelet count. Here I would like to emphasize that many of the colleagues, they are afraid of doing bone marrow procedure with a platelet count of 5,000, say 6,000, but actually it's not a contraindication. One can do a bone marrow procedure at any number of platelet count. The only thing one has to bear in mind is that a proper hemostatic plug has to be formed, or proper hemostasis has to be maintained at the skin level so as to avoid the skin hematoma. So again, having said all this, the decision to proceed with the procedure also depends. It's not only the numbers, it's also the chronicity of the thrombocytopenia and the urgency of the procedure. For example, if a patient is having a low platelet count for 1.5 years, and now he is in need of a surgery and has never bled in the past, then and the procedure is urgent. So keeping the urgency in mind, one should take the risk and go for the procedure rather than just avoid in view of the low platelet number. Can the patients with thrombocytopenia have thrombosis as well? So yes, these are the conditions in which the patient can present with thrombosis. So heparin-induced thrombocytopenia, in which there is antibody formation against the platelets, which causes the platelet activation and thus the thrombosis formation. Similar pathogenesis has been postulated in vaccine-induced immune thrombocytopenic purpura, which is a newer entity which we came to know during the COVID vaccination period. Then apart from this, antiphospholipid syndrome, which may happen in conjunction with SLE or in alone. Then DIC is another consumptive coagulopathy, which can present with thrombosis, with or without bleed. Then there are microangiopathic, thrombotic microangiopathics like TTP-HUS spectrum, paroxysmal nocturnal hemoglobinuria, and if ITP has happened in a patient who otherwise had a thrombotic condition like DVT. So in these patients, the low platelet count is not a thing which can prevent the thrombosis formation, and one has to be expeditious regarding the diagnosis as well as treatment in these patients. So coming to the causes of thrombocytopenia, broadly we can categorize them into the categories of either the marrow is not producing them well, or the bone marrow is producing them at a normal or even at a higher rate, but they are getting destroyed somewhere in the circulation or in the periphery. So coming to the causes with decreased production from the marrow, inherited platelet disorders are not very common, but they are also not uncommon, I would say. They may present with isolated thrombocytopenia, examples being congenital amegakaryocytic thrombocytopenia, the Bernard-Soulier syndrome, thrombocytopenia with absent radius, and there is another condition called atrus, which is also a congenital condition. So the common things in these is they are lifelong disorders. They may or may not get diagnosed in childhood. Although the thrombocytopenia is long-standing, it is since childhood, but many of these children do not get diagnosed during their childhood, and they become adults, and sometimes they are diagnosed during their adulthood. And many of them are misdiagnosed as ITP for a long time before getting a correct label of their diagnosis, and some of them may have associated phenotypic abnormalities. For example, I told absent radius, and CAMT can also have phenotypic abnormalities. So this is a rare subset. They are uncommon, but one has to keep in mind that not all isolated thrombocytopenias are ITP. Some of the patients will be having this subset of condition. So this is a data from a ITP registry where they have found that there were many patients who were actually mislabeled or misdiagnosed as ITP, but later on, with the advent of all the diagnostics, they could be labeled with the proper diagnosis, and 1 in 7 patients suspected of having primary ITP was actually misdiagnosed at some point during their disease course. The second cause of decreased production is the general hit to the marrow. If the bone marrow milieu has been hit by some infiltrative disorder, or bone marrow as a whole is not producing all the lineages well, which can happen in conditions of B12 deficiency or folate deficiency, which can happen in case of myelodysplastic syndromes, the infiltrative disorders like leukemias, lymphomas, as well as the solid malignancies like sarcomas and neuroblastomas. It can happen in bone marrow failure like aplastic anemia or PNH. And it can happen with some infections like parvovirus. So these are the disorders in which platelet as a lineage are hit, but the other two lineages are also hit. Hence, one can find either a bicytopenia or a pancytopenia in these patients. And how one can see whether the bone marrow is not producing well, the mean platelet volume and again immature platelet fraction plays a role here. These patients will have a normal mean platelet volume and a decreased immature platelet fraction. The third category of decreased production is a liver disease, because we know that liver produces thrombopoietin, which is essential for the production of platelets with the thrombopoietin receptors, and hence decreased TPO production may lead to thrombocytopenia, and which may or may not be accompanied with compensatory splenomegaly. So, and now coming to the second major category is increased destruction or consumption, the prototype disease being immune thrombocytopenia. And the paradox in immune thrombocytopenia is that it is a very common cause of thrombocytopenia in children as well as in the adults. However, it is a diagnosis of exclusion. So although it is very common, but one has to exclude, one has to be very sure that he is not dealing with any other alternative etiology, and then only we can label the patient as having ITP. The newer classification classifies the ITP into 3 categories based upon the duration, the newly diagnosed ones being less than 3 months, the persistent ones being 3 months to 12 months duration, and the chronic ones more than 12 months duration. So the classical presentation of ITP or acute or newly diagnosed ITP will be, it will be abrupt in onset, otherwise the patient will be clinically well, will have a severe thrombocytopenia, but the bleeds will most of the times they will be minor, and if a bleed is happening, the anemia will be in proportion to the bleed that has happened. Suppose an epistaxis has happened or hematuria has happened, so the drop in hemoglobin will be in proportion to the bleeds, as compared to the etiologies like leukemias, where the anemia is out of proportion to the bleeds. And there will be no other oddity or atypical signs and symptoms. So what are the oddities or atypical signs and symptoms? I will come to that. So with this classical presentation, if one is sure that he is not dealing with any other thing, one can label the patient as having ITP and then start the treatment. So ITP or immune thrombocytopenia can be primary without any underlying cause or idiopathic, and it may be secondary, which is associated with underlying associated etiology, and the causes of secondary ITP increases as the age advances. So if we talk about the childhood, that is 2 to 10 years of age, most of our kids will be having primary or idiopathic immune thrombocytopenia without any underlying cause. Whereas if we talk about adolescents and adults, many of them, roughly 50% of them, will be having some underlying associated etiology. So what are the associated conditions? There may be autoimmune conditions like SLE, APLA, and if autoimmunity has hit at least two of the lineages, then it is labeled as Evans syndrome. That is, if immune thrombocytopenia is happening along with autoimmune hemolytic anemia or immune neutropenia, so then that condition will be labeled as Evans syndrome. There may be underlying inflammatory bowel disease, there may be underlying rheumatoid arthritis. Then there is a subset of diseases like immunodeficiency syndromes with HIV, common variable immune deficiency, and selective IgA deficiency. And then there are infections which can cause secondary ITP like cytomegalo, EBV, hepatitis C, H. pylori, HIV, varicella, Zika, and then there may be malignancies. So as I was talking, one has to be very sure on labeling an ITP when to reconsider a diagnosis of ITP if the age is very low, very less, that is less than 2 years or more than 10 years. No previously documented normal platelet counts. If there is history of thrombocytopenia in the family, likely you are dealing with a case of familial low platelets. If the anemia is out of proportion to the bleeds. If the differential counts in the CBC is showing a lymphocytic predominance. Normally we have neutrophils more than lymphocytes, but if the lymphocytes are more than neutrophils, then it is prudent to do a bone marrow before labeling ITP. And then if there is hepatosplenomegaly or lymphadenopathy, so in the presence of any of these, one should consider either there is an alternate diagnosis, it's not an ITP, it's some other thing like leukemias, etc. Or if it is ITP, then you are dealing with a case of secondary ITP. So another pathophysiology of increased destruction being drug induced. The common ones that is used in the clinical scenarios being antibiotics, the anti-epileptic agents, and heparin. So in these cases, typically the thrombocytopenia develops within hours of drug exposure if the patient has been previously exposed because of an amnestic response, or if the patient is de novo exposed to the drug, then it takes 1 to 2 weeks of daily exposure before development of thrombocytopenia. And typically, if one withdraws the drug, the thrombocytopenia resolves within 5 to 7 days, and specific treatment is rarely required. The other conditions with increased destruction include DIC and thrombotic microangiopathies, cardiopulmonary bypass, postoperative thrombocytopenias, and large thrombosis. Then there is a category of dilutional thrombocytopenia, a prototype example being gestational thrombocytopenia because of the expansion of the plasma volume. The absolute platelet count remains normal, but it is reflected as low platelet counts. And apart from that, fluid resuscitation, massive transfusion, or post-operative cases can also have dilutional thrombocytopenia. And the fourth category of mechanism is redistribution, which typically happens in cases of hypersplenism because spleen is the largest reservoir of the platelets. And thrombocytopenia from splenic pooling of patients. These patients typically will have a mild to moderate thrombocytopenia. They will not have a severe thrombocytopenia. And if one is having a severe thrombocytopenia, one should consider alternative diagnosis rather than hypersplenism as the cause. Then infections can have multiple mechanisms. They may be immune mediated, bone marrow suppression, or platelet consumption. The common examples being viral infections, MMR, parvo, hepatitis C, EBV, COVID-19, HIV, and dengue. Hepatitis C is the one which can lead to chronic ITP. So if one is having chronic ITP, it is prudent to test for hepatitis C as well as HIV. These are two viral infections that should be checked. And bacterial sepsis, we know it can induce DIC, and H. pylori is one bacterial infection which can induce ITP in adults. So what should be the differential diagnosis if one is finding incidentally mild thrombocytopenia? So it may be pseudothrombocytopenia because of an EDTA effect. That report has to be checked again with manual platelet count. It may be normal variation, as I talked earlier in the presentation, or it may be because of B12 folate deficiency, ITP, occult liver disease, HIV infection, or a myelodysplastic syndrome. Then in the next 4 to 5 slides, I will just say how to approach laboratory-wise. So initial questions should be emphasizing on whether the thrombocytopenia is real or it is a pseudo thrombocytopenia, if it is new onset or it's a chronic one, or is there any associated other hematological abnormalities, or are there any potentially serious consequences of not starting disease-specific treatment quickly, for example, in thrombotic microangiopathies where plasma exchange is immediately required. So the history of prior platelet count is extremely important, because if one is having very long onset or long-standing low platelets, then might be having some congenital low platelets, then family history, bleeding history, then recent history of medication exposure in the last 2 weeks, infectious exposure in form of vaccination or infections, dietary practices, for example, veganism or other underlying medical conditions should be sought in the history, and in examination, what are the sites which are involved in the bleed, and whether there is a presence or absence of hepatosplenomegaly lymphadenopathy and presence of thrombosis is the main thing that one has to see. So this is the tier 1 investigations, the basic ones which one has to begin with, that is CBC with differential counts, which may show bi or pancytopenia. The renal function tests may show deranged urea creatinine in cases of TTP-HO spectrum. The LFTs may be deranged in cases of DIC and HLH, and the coagulation parameters may be deranged in cases of DIC, and HIV and HCV testing. These are 2 basic viruses that needs to be tested. So this is the first tier 1 investigations, and peripheral blood film is the central point that is the converging point for all these investigations. A good peripheral blood film examination is a must in all cases of thrombocytopenia. So one should talk to the pathologist and specifically ask what is the manual platelet count in this patient, what is the morphology of the platelets, what is the mean platelet size, is there any presence or absence of neutrophilic inclusions, abnormal cells, or any signs of hemolysis. So some of the diagnosis can be just clinched through the peripheral blood film, like Bernard-Solier syndrome, which will have giant platelets, MYH9 related disorders, which will also have neutrophilic inclusions, and the gray platelet, which have a hypogranular platelets. What is the role of mean platelet volume? The normal MPV is 7 to 11 femtoliters, and there are some causes of microthrombocytopenia, that is MPV is less than 7, or macrothrombocytopenia. So visco-Talbot syndrome and aplastic anemias should be thought of in cases of microthrombocytopenia, whereas if one is finding giant platelets or large platelets with a high MPV, then potentially you are dealing with ITP or Bernard-Solier syndrome or May-Hagelin anomaly. So that is the reason many of the Bernard-Solier syndromes, they are mislabeled as ITPs long before they are actually diagnosed as Bernard-Solier syndrome. So once this tier 1 investigation is complete, what is the basic secondary workup that one should do to rule out to look for other causes? For immunity, immune constitution, one has to do immunoglobulin profile to look for common variable immune deficiency, and T cell, B cell, and NK cell subsets for other underlying immune deficiency syndromes. For the autoimmunity workup, one should do ANA, double negative T cells for autoimmune lymphoproliferative syndrome, and DCT to look for associated autoimmune hemolytic anemia. For the infections, one has to test for HIV, HCV, and HBV, and in adults, H. pylori as well. And finally, bone marrow also plays a role. So last slide only. So the bone marrow evaluation also plays a role in cases who are undiagnosed or where the diagnosis is unsure and where the cytopenias are unexplained. So the take-home message is not all isolated thrombocytopenias are ITP. There are a lot of other disorders contributing to it. And then the structured algorithmic approach is to be emphasized for the evaluation. And again, the common clinical conditioners are common than the rarer ones. And peripheral smear along with mean platelet volume and immature platelet fraction is a good starting point for the evaluation. So thank you, and I'm open for any questions if there are any. Thank you.
Thank you very much, Dr. Chavda. Excellent thing, because platelet count in the season of dengue, as Dr. Bhaiya has told, this is most important, to create awareness, because we have seen SDPs being given on 70,000, 1 lakh, and surgeons are sending the patients if the platelet count is more than 50,000, still they are sending the patient for platelet infusion, etc. So really great thing, emphasizing on peripheral blood smear. Good peripheral blood smear can diagnose 50% of the cases of thrombocytopenia. Excellent talk. I must congratulate you on a beautiful overview, making people aware when to do, what to do if there is thrombocytopenia. Thank you very much.
Thank you, sir, for this amazing presentation. Now it's time to turn our attention to Dr. Nitika, consultant geriatrics and sleep medicine from New Delhi, for a presentation on topic sleep issues in the elderly population.
So I must thank Dr. Nikita Dang for coming all the way from Delhi to Bathinda to deliver an informative talk on sleep issues. I think we should have an overview of sleep issues in all population, not only geriatric, because this is also an important area for non-communicable disease. Sleep is coming up as a risk factor for non-communicable diseases also. So thank you very much, Dr. Nikita, for coming all the way from Delhi to deliver this important talk. Thank you very much.
Very good afternoon to the esteemed audience, and thank you very much, sir, for this extremely, I'm humbled by your introduction, actually. And as you've mentioned, I'm just going to take a minute until I have support to put everything in place here.
लेफ्ट साइड तो ऊपर टॉप तो के दसी मेरा कर्सर कितने मेरे स्क्रीन इधर ऑफ हो गई लेफ्ट साइड देख पॉप खुले होना है दसी मैंने राइट साइड देख ही आ रहेगा हाँ हाँ डुप्लीकेट तो करवाओ बस ठीक है यही करना चाहिए presenter view
Thank you. So I'll start the talk by highlighting the agenda for the talk today. I'm going to go through the population and statistics, talking about aging and sleep, and sleep history, which is a bigger challenge for all the clinicians here in their OPTs with their busy schedules. Going through each patient's sleep history can be a mammoth task. Then I'll be browsing through normal sleep, challenges in sleep as we age, insomnia, and other challenges that we face. As we know that the speed of population in India is at a rat race. Now this rat race against populations that are growing across the globe warrant that India reaches a 25% of the population is going to be over 65 years of age by 2050. Japan, on the other hand, has actually already crossed these statistics way back in 2012. And as the populations are getting older, so is the burden of sleep issues increasing. This is how we're going to look like and feel like if we don't do anything about it today. Memory loss, confusion, solving problems will be a difficulty. Trouble with familiar names, tasks is going to be a hassle tomorrow, so we better take care today. Coming to the overview of sleep, sleep is actually on the basis of physiological and electroencephalographic parameters divided in non-REM, which is non-rapid eye movement sleep, and rapid eye movement sleep. The non-REM sleep is in stages 1, 2, and 3. Earlier, we had a classification of non-REM 4, which has now been taken out of the latest guidelines and classification. The muscle tone, EOG, EMG, and EEG are a part of the polysomnography studies when we do a sleep study at night. And highlighted here are the parameters and how they change with sleep and age. The National Sleep Foundation recommends that an elderly person sleep for about 7 to 8 hours per night. With our busy schedules and erratic clouding in our brains, we know how much we have work to cope up with and challenges to deal with, which compromise on this basic need of all humans. Running through a hypnogram in the young, followed by the elderly, we are able, the first two hypnograms elicit sleep latency in the younger adults. So in the younger adults, there is more consolidated sleep. The sleep onset time is minimal. We see consolidated REM sleep. Each sleep cycle is a cycle of 90 minutes, which is periodic and phasic. As compared to the second graph, the second hypnogram that we see, where sleep is fragmented, time wake after sleep onset is much more. Total sleep time is decreased, number of arousals are higher, and slow wave sleep is decreased. Now, these are the factors that influence our sleep day in and day out. Multiple comorbidities, lifestyle issues, dincharya or routine issues, our dietary habits, everything contributes to a good night's sleep. Going through the aging process, the reasons for the increase of sleep disorders in the elderly are not only physiological, pathological, but may also be related to the drugs that one may be consuming as one ages with comorbidities. The peripheral sensory systems that are going down, altered tissue morphology, mental states, and central sensitizations all contribute to this. Factors that influence sleep in the elderly patients, again, as I mentioned, medical illnesses, psychiatric illnesses, environmental changes are a major contributory factor. Sleep problems that arise with age are significantly higher in people with pre-existing medical comorbidities, as shown in this current graphic. Anxiety and depression, arthritis, chronic pain, neurodegenerative diseases, diminishing senses, endocrine metabolic disorders, cardiovascular disorders, balance, gait, and movement restriction, anemias are all very important contributory factors to our night sleep. In the earlier classification, common sleep complaints were classified as primary or secondary. The newer classification, however, classifies them in a different way with these 4 primary heads that we see on the board. Insomnia contributing to a vast 30 to 50% of people having difficulty in sleep initiation and sleep maintenance with multiple nocturnal awakenings, obstructive sleep apneas, which are breathing interruptions during sleep, circadian rhythm disorders, restless leg syndromes to be the most common ones. The secondary causes include the socio-emotional factors, mobility, balance and gait, lifestyle changes, polypharmacy, and in this graph, we see the difference in the gender of slow wave sleep as one ages. We see that there is a significant decrease in the male slow wave sleep with age. The prefrontal cortex and the hippocampus, as they degenerate with age, show corroborative changes, which is elicited on the right side in the colorful diagram, on how slow wave sleep, which is the hallmark of stage 3 sleep, and the spindle activity, which is a hallmark of stage 2 sleep, decrease with age. The impact of poor sleep cannot be questioned, as multiple studies now are coming to highlight not only muscle strength, Alzheimer's, frailty, sarcopenia, and many systemic disorders to be a much contributory factor towards the sleeping conditions of the elderly and the young today. The important lifestyle and socio-emotional psychological factors that contribute towards sleep also contribute towards poor cognitive performance and function are muscle repair, perceived exertion, immune function goes down, muscle glycogen repletion is decreased, altered endocrine function, increased exercise-related injuries, increase in pain sensitivity, increased chronic health issues are all because of poor sleep. The global statistics and perspectives on sleep in the elderly. The global burden of sleep disturbance is about 30 to 50% across the globe. However, the urban Indian population of seniors reports about 25 to 40% disturbance. We are not far away from the global numbers if we don't take care now. Seniors affected by insomnia globally are 30 to 40%, whereas Indians report a 17 to 30% influence of insomnia. This number may be skewed, these percentages may be skewed because of lower reporting. Increase in rates of obesity and metabolic disorders contribute to a high 20 to 30% of obstructive sleep apnea, whereas in India, 30 to 28% of the elderly population contributes to this burden. Elderly with restless leg syndrome account for 15%, which is slightly lower due to genetic and environmental and dietary factors in India. The highest contributory factor or sleep challenge in the elderly today is insomnia. The DSM-5 diagnostic criteria highlights dissatisfaction with quality or quantity of sleep for at least 3 nights in a week for at least 3 months associated with 1 or 2 of the following to be a diagnostic criteria for insomnia. Causes clinically significant distress or impairment in routine functioning, occurs even when there is enough time to sleep, does not occur exclusively during narcolepsy, breathing-related sleeping disorders, circadian rhythm disorders, or any other coexisting sleep disorders, does not occur exclusively during the course of another mental disorder, not due to the direct physiological effects of a substance. Now, these criteria, there is difficulty falling asleep, staying asleep, or early morning awakenings, which further classify insomnia. Again, this is the same slide. This further classifies insomnia as sleep maintenance or sleep initiation in insomnia. The causes of insomnia may be medical or psychiatric, iatrogenic, or psychosocial. Anxiety disorders, asthma, CHF, COPD, dementia, something as simple as reflux is a major contributory factor to decreased sleep. Iatrogenic factors include medication, alcohol, steroids, sympathomimetics, caffeine, our teas and coffees that we love are all iatrogenic factors that hamper our sleep. Psychosocial, bereavement of a dear one, financial stress, travel, marital difficulties, poor sleep hygiene, children bothering us, or parents being a burden that we so-called think is absolutely a misnomer and cause us stress, which contribute to the insomnia that we have. For screening, the most important is the patient history. A patient health questionnaire is a mandate for all clinicians to follow, even if it takes a long time in the OPDs. The geriatric depression scale, the general anxiety disorder questionnaire, the PSQI, ISI, the sleep diary are all mandatory screening tools. However, we also have optional tools like actigraphy and the ring, which is a latest invention of modern day, wherein just slipping a ring in your ring finger will help you diagnose something so easily. A sleep diary is what we all abide by, the sleep physicians. This typically highlights, this is a subjective understanding of the patient's sleep, where the patient is supposed to put in work, schedule, M for medication, C for caffeine, A for alcohol. The first row on top highlights an E, which is an exercise, A, which is an alcohol. The darker highlighted portions are when a person takes a nap or sleeps, goes to bed. The I or the bar at 10 p.m. is actually when you hit the bed. At 11 p.m., this individual is still unable to fall asleep and is tossing and turning in bed, which may be the case for a lot of us here. And in the morning, at 7 a.m., when this person wakes up, after a brief hour, which may be a very hard hour at night, while tossing and turning because this person cannot get back to sleep, he has a shot of caffeine with his medication. Now, this 2 weeks synopsis of a person's sleep schedule helps us understand the subjective emotions and the subjective pattern of the person who's sleeping. The instructions that we give to a patient while filling this is that this is not supposed to be filled in the middle of the night when you're actually looking at the clock and unable to sleep. It is ideal to wake up in the morning and do a retrospective filling of this. Diagnosis of insomnia highlights at least one symptom that I've previously mentioned to be occurring at least 3 times in a week for a period of 3 months, and daytime impairment. Funneling down, insomnia diagnosis is only about 6% in the OPDs, shows a latest research study. The first line treatment for insomnia and sleep disorders is clearly non-pharmacological, as highlighted by the American Academy of Sleep Medicine Clinical Practice Guidelines. Cognitive behavior therapy, or CBTI, forms the mainstay of insomnia. The other non-pharmacological therapies for insomnia include stimulus control, sleep restriction, paradoxical intention, relaxation techniques, cognitive behavior therapy, multi-component therapy, temporal control therapy, details of which I'm happy to share, but I'll be skipping through these as we are running behind time. Again, for choosing the ideal pharmacological treatment, this chart highlights the pathways for choosing the right treatment for an individual based on the kind of insomnia a person may be having, which is sleep maintenance insomnia or sleep onset insomnia. We have drugs like Ramiltion, Suvorexant, the Z-class category drugs, amongst others. Use of sleep medication amongst the elderly from 65 to 80 is shooting at a peak of 31%. Obstructive sleep apnea. We all know the etiopathogenesis of obstructive sleep apnea, which ultimately leads to inflammation, oxidative stress, disturbed circadian rhythms, and endothelial dysfunction, causing irregularities in sleep at night. Hypoxemia or reoxygenation, the autonomic dysfunction, the arousal sleep disruption, intrathoracic pressure changes, and hypercapnia contribute to the pathophysiology that lead to the disease mechanisms. Inflammation, atherosclerosis, endothelial dysfunction, etc. contribute to the associated CVDs. The long-term consequences of obstructive sleep apnea are metabolic disorders, mortality and with high mortality and morbidity, cardiovascular consequences, and neurocognitive dysfunction. Again, I will not get into the details looking at the paucity of time. Skipping through this as well. The trait-based precision medicine is the latest concept in the treatment of obstructive sleep apnea, where we establish the role of traits in pathogenesis of obstructive sleep apnea, initiate therapy with gold standard measures, use the traits to predict response to current treatments, followed by clinical surrogates, apply the surrogates in multimodal therapies, point of care validating traits with measurements, and target obstructive sleep apnea traits to initiate therapy for each individual. And these studies are currently being done by the Harvard Group in Boston. Again, the challenging aspects of sleep in the elderly are contributed by lifestyle, polypharmacy, CPAP, compliance, which is a big issue. Surgical options are there, but harder and more difficult. Alternative devices, again, difficult to maneuver and initiate by the elderly alone. Nerve stimulation, drug therapy, and oxygen supplementation also add to multimodal therapies. Modifiable risk factors, diagnostic polysomnography, change in systolic blood pressure, excessive daytime sleepiness, causing sleep fragmentation and arousals at night, and oxygen desaturation all contribute towards cognitive decline that are directly tangible, and we are able to elicit this in verbal, visual, long and short-term memories, executive functioning, and motor functioning. The chart to the left actually highlights sleep-disordered breathing before and after CPAP therapy and the changes that we are able to see. Future directions for physicians may be systematic studies that may be needed in a stepwise approach to help the elderly function better, have a great scope for learning in the OPDs. Circadian rhythm, diet, psychology, and gut microbiome are also related to the sleep-wake rhythm that contribute to the sleep-related disorders in the elderly, which are not limited to neurological diseases, endocrine diseases, adding to the mental health burden of what they already have. Again, health outcomes and correlates with diabetes, type 2 diabetes. Recommendations for the Indian healthcare providers. Assessment of medication and assessment of the patient are of utmost importance. Assessing drug-to-drug interactions, identifying non-beneficial therapy and simplifying therapy, identifying high-risk therapy and reconsidering whether it is actually needed or not, identifying goals for care and adjustment of medication that are consistent with the needs of the patient, identifying functional status deficits and readdressing medication, eliminating and clearing toxicity in patient systems, and adhering to the barriers that come in place of a compliant patient are something we all need to see. Integrating sleep health in the OPDs from a general practitioner to a super specialist is the need of today. Highlighting in the next few slides the relationship between pain and sleep problems, feed-forward and feedback mechanisms contributing to sleep disturbance and pain. Likewise for polypharmacy, as I've previously mentioned. The highest risk being of beta blockers, antidepressants, and diuretics. Hormones like melatonin, which are secreted and cause dysregulation of the sleep-wake cycles. Nocturia, polypharmacy, movement disorders, dementia, reflux disease, pain, heart failures, depression, and respiratory disease all cause impaired sleep. Sleep is not a unidirectional or a unimodal entity, and it needs to be catered by each one of us in our clinics. Identifying medication risk and deprescribing should be the goal. Socio-emotional challenges that affect the elderly in complying to the treatments may be not limited to loneliness, loss of loved ones, social anxiety, retirement, and loss of purpose, fear of falls, nighttime anxiety, chronic stress, for which we need to reinforce positive relationships and support. The importance of dincharya that has been emphasized by our elderly at each one of our homes comes into play here. Alternative medicine has not fallen shy from supporting mainstream to support each one of us sleep in peace. Alas, we do not consider them important. Holistic sleep solutions are important and backed by evidence. Ashwagandha, Brahmi, Shankhapushpi play an important role in sleep disorders and have enough evidence that we can support patients with adjunctive therapies. To summarize, insomnia disorders and chronic insomnia disorders, treatment of choice being cognitive behavior therapy. Sleep-related breathing disorders, the treatment of choice is PAP therapy. Circadian rhythm disorders, light and rescheduling. Sleep-related movement disorders with dopamine agonists and alpha-2 delta ligands. Parasomnias need reinforcement of sleep hygiene. Central disorders of hypersomnolence need wake-promoting medications and, again, sleep hygiene to be in place. I can't emphasize less on the importance of sleep routine and sleep hygiene. Thank you.
Thank you very much for an excellent talk. And basically, good sleep is an indicator of good health, both physical and mental. So we need to aspire to have good sleep, and you have given the guidelines for abnormality in sleep, diseases affecting the sleep, and how we can overcome and have good sleep. Thank you very much.
Thank you, sir, for having me. Thank you to the audience for being a very patient one.
Thank you for the informative presentation, ma'am. Now let's turn our attention to Dr. Abhijit Kumar, consultant physician and diabetologist from Patna, for his lecture on managing Charcot foot in diabetic patients. Please, sir.
Dr. Abhijit, thank you very much for showing interest in attending MAPICON, and young people like you encourages us to go further, and your presence will promote MAPICON on Indian scene. Thank you very much.
Thank you, sir. A very good afternoon to the esteemed audience collected here. I thank the organizers, especially Vitul K. Gupta, sir, for providing me this opportunity to speak on this stage. Now, my topic is an often ignored one in our routine clinical practice. Charcot foot is an inflammatory disorder which is progressive over time. It was first described in 1868 by Jean-Martin Charcot, who was a French pathologist and neurologist. He described this disease in patients of tabes dorsalis. So coming to the epidemiology, we have eye-opening numbers about epidemiology of Charcot foot. It is prevalent at around 0.1 to 7.5% in patients of diabetes. But surprisingly, the prevalence rate goes up 5 times to 35% in patients of diabetic neuropathy. We have bilateral involvement of the feet between 9 and 75%, which is a very huge number. This disease mostly presents in the 6th and 7th decade of life, and most of the patients are having a long-standing history of diabetes for a minimum of 10 years. We have an estimated 63% of the patients with Charcot neuropathic osteoarthropathy who in future are going to develop a foot ulceration, and we all know the complications and the difficulties of managing a foot ulcer in itself. So what are the risk factors for developing Charcot? Well, the numero uno factor still remains diabetic neuropathy. Along with that, we can have poor blood circulation, previous trauma or injury to the foot. We can have foot deformities or foot ulcers. Another important factor is increased BMI, which is associated with increased incidence of Charcot arthropathy. And worryingly, the BMI is increasing not just in the 30s and 40s. Now we have students of school-going age who are overweight or obese. So some diseases which are linked with Charcots are Parkinson's, HIV, sarcoidosis, rheumatoid arthritis, and psoriasis. So we have two distinct pathophysiologic mechanisms for the development of Charcot foot. One is the neurotraumatic, the other one is the neurovascular. In the neurotraumatic theory, we have repeated trauma which leads to joint destruction. In the neurovascular theory, we have increased blood flow, and this leads to sympathetic failure and AV shunting, causing osteolysis, osteopenia, and bone atrophy. Well, Charcots mostly develops in the foot, but it can also develop in the shoulder and elbows. And we have this pictorial representation of the pathophysiology, both the neurovascular and the neurotraumatic theory. So we can see that the inflammatory response which is triggered, it disrupts the bony architecture of the foot, and this creates abnormal plantar pressures. And when we have abnormal plantar pressures in the foot, such a foot is at an increased risk of ulceration, osteomyelitis, that is infection, along with amputation. So what are the stages of Charcot foot? We have two different classifications. One is the Eichenholz classification, which is based on the clinical and the radiographic findings. The other, Sanders and Freiberg classification, is based on the anatomical locations. So coming to stage 0 or pre-Charcot prodromal stage of Eichenholz classification, clinically the patient will have red hot and swollen foot without any deformity, and we will have a completely normal radiograph. In the stage 1, that is the development or destruction stage, the patient will have an erythematous foot with elevated temperatures but without any pain. On the radiograph, we will have bony debris at joints, fragmentation of the subchondral bone, joint subluxation with or without fractures. In the stage 2, that is the coalescence stage, we have decreased signs of inflammation. The inflammation starts to subside. But on the radiograph, there is worsening of the stage 1 features. Now, there is absorption of the bony debris along with new bone formation. We have coalescence of large fragments with sclerosis of bone ends. Now, in the last stage, we have complete resolution of the inflammation with changes in the overall foot architecture. On the radiograph, there is remodeling of the affected bones and joints. Now, coming to the Sanders and Freiberg classification, this is based on the anatomical location and the various percentage is given. Here we see a classic Charcot foot in the acute active stage where the foot is swollen, red and hot. Now you can see a healthy foot over here compared to a Charcot foot where you have fused joints, the twisted first metatarsal bone, bony fragmentation, and the last stage of the Charcot foot in the Eichenholz classification, that is the rocker bottom deformity. This is the radiograph of the rocker bottom deformity. Now coming to the symptoms of Charcot foot, see, our patients of diabetic neuropathy, they are oblivious of pain sensations and they repeatedly suffer trauma of which they don't take note of. Now, this might be noticed in the form of swollen red or warm foot, or the patient might have difficulty fitting into a shoe. So that is when they present to a doctor. These patients can have loss of sensation and obviously over time they will have foot deformity. Now, why is Charcot so important? It not only hinders the quality of life of the patient, but it also carries its own set of complications. The patient can suffer from foot deformities like flat foot, rocker bottom foot, hammer toes, ankle equinus contracture. The bony prominences, they can lead to ulceration, infection, and not just loss of limb, but also loss of life if not treated properly and in time. We also have recurrence of Charcot joint. Now, can we ever imagine that a disease like Charcot foot would be carrying 13% mortality over a period of 5 years? And this is similar to patients of diabetes who are not having Charcot. This calls for increased awareness about Charcot foot and its diagnosis and management. So how do you diagnose Charcot? Well, the first basic principle is to have a high index of suspicion, because when patients present to us with a red hot and swollen foot, we end up misdiagnosing Charcots as, say, osteomyelitis or gouty arthritis or DVT and other infections. So a clinical exam and a proper history taking is of paramount importance. X-ray is the first investigative modality which we should order in such patients. MRI and bone scans can be reserved for patients where X-ray is negative. Bone scans also help in early detection, like DEXA. So here we have a lateral X-ray of a Charcot foot deformity, which shows dislocation of the tarsometatarsal joint with break in the talo-first metatarsal line, which is shown by the dashed lines, and a reduced calcaneal inclination angle showed by the solid lines. So on radiographic evaluation in a patient of chronic Charcot neuropathy, you see osteophytes, joint consolidation, and arthrosis. Deformity begins with the medial column and it proceeds to the lateral column in the later stages. So how do you manage Charcot foot? The basic goal is to achieve a plantar grade foot which is stable and is able to fit into a shoe. We need to prevent recurrent ulcerations in patients of Charcot neuropathy. So in this stage 0, you don't need to do anything. You just need to monitor the patient. You need to counsel them about the need for monitoring and frequent follow-ups. You need to do serial radiographs to look out for the development of stage 1 Charcot neuropathy. Now here, the importance of foot care in diabetic patients cannot be underemphasized. We need to counsel our patients about foot care, not walking barefoot, wearing the proper fitting shoes and avoiding the tight fitting ones, about the use of moisturizers and emollients so that they do not have a dry skin which is more prone to injury. In stage 1, we have to immobilize the patient. Foot and not weight bearing has to be done in a total contact cast. In stage 2, we do protected weight bearing with a total contact cast or a molded total contact polypropylene ankle foot orthosis. Now in the last stage, if the patient has a plantar foot, then surgery can be avoided and we may use custom inlay shoes. But if there is a non-plantar foot or recurrent history of ulcerations, then we have to go for debridement, exostectomy, correction or fusion with internal fixation. If there is osteomyelitis, debridement has to be carried out with or without staged reconstruction with internal or external fixation or amputation in some cases. Now, in the acute phase, how do we achieve immobilization? We can do it with total contact casts or removable Walker braces. There are some advantages and disadvantages of both these modalities. The removable Walker braces, though they are of low cost and more affordable, but they cannot fit into all the deformities and they have limited compliance. However, total contact casts, despite their high cost, they can fit into the severe deformities and have a better compliance. The thing to watch out for in a total contact cast is that we should not prolong the total contact cast duration unnecessarily, because we have to monitor the patient. If the edema has subsided and there is radiological improvement, we should remove this cast. Otherwise, we will have joint stiffness and disuse atrophy. Are there pharmacological options? Well, there are pharmacological options, but till date, they have not been proven to be of much great benefit. Bisphosphonates can be used, and they help the acute phase of Charcot as they inhibit osteoclastic reabsorption. Calcitonin is an excellent alternative in patients with renal dysfunction. We also have pamidronate and zoledronic acid, which can act on the new hydroxyapatite crystals by blocking osteoclast precursors in the newly formed bone matrix. Now, medical optimization is very important. We have to advise the patients of diabetes and also of Charcot foot to stop smoking cessation. HbA1c targets, as advocated by the American Diabetes Association, has to be individualized. A person in their young 30s, they can have an individualized target of, say, an HbA1c of 6% if they are not suffering hypoglycemia. However, an elderly person in their 70s or 80s can have a relaxed target of 8% if they have already had complications. We need to recognize micro or macrovascular disease, which can lessen the complications post-operatively. Now, when do we go for surgical options? So the main rationale behind Charcot reconstruction is surgical offloading to prevent ulceration and deformity progression. So the modalities available are exhaustectomy and Achilles tendon leathening, plantar osteotomy, osseous debridement, realignment osteotomy, selective or extended arthrodesis, and open reduction with various forms of internal fixation with or without external fixation. Amputation, which is the most dreaded complication which can handicap a patient, well, it is done only after failure of previous surgery. It is performed because there is an unstable arthrodesis or recurrent ulceration or infection. So here we have an example of a Boyd's amputation in a person with Charcot foot. So this algorithm sums up how we should manage Charcot foot. First, we have to do an X-ray, and if it is positive, we go for offloading and redistribute the weight bearing through total contact cast or removable Walker braces. But if this is ineffective, we have to go towards the surgical management. Proper footwear has to be advised to the patient after the total contact cast has been removed. MRI or nuclear imaging should be carried out if the X-ray is negative, and osteomyelitis must be treated. However, if the MRI or nuclear imaging are negative, we have less chances of it being a Charcot foot. Now, coming to the multidisciplinary team approach, it is very important to have a good team to manage patients of Charcot foot. It is not just the physicians or the diabetologists or the orthopedicians domain. Such patients benefit greatly when you have an MDT team in the hospital or your clinic or the medical colleges. And this concept still remains alien in most parts of India, where people are not ready to collaborate with other branches and consider multidisciplinary consultations. We can say that this might increase the cost of treatment, but ultimately this will also increase the quality of the care we provide to the patients of Charcot foot. So I would come to my conclusion. The awareness on Charcot foot still remains low. We need to aware our physicians, our interns, our postgraduates to look out for Charcot foot in their routine clinical practice and have a high index of suspicion. Diabetes remains the #1 cause. The initial treatment has to be offloading. Surgical treatment is reserved for chronic recurrent ulcerations, unbraceable deformity, acute fractures, or dislocation or infection. Thank you.
Thank you very much. So with this, we come to an end of a really important topic, that is Charcot foot and diabetic patient. Now I invite our great researchers from Delhi, Dr. Ashu Grover, to please come on stage. We are really honored to have you, ma'am. You know, you and Dr. Ravinder Singh are really encouraging us to go in for research, and we are really honored. That is a separate thing that we are going live on net, on YouTube. So your lecture will be recorded and will be shared with so many people that they are encouraged as well as motivated to go in for research and academics in future. So please, ma'am.
अच्छा कैमरा वहीं पे है यार ऐसे एक जगह खड़े होकर पढ़ाने का मज़ा नहीं आता मेरे को नहीं कोई बात नहीं फिर मैं वहीं से पढ़ा दूँगी अच्छा
ये उस तरफ हो सकता है बीच में नहीं फिर ये नहीं दिखेगा अच्छा ये तो स्लाइड चेंजर है ना
ठीक है कोई बात नहीं
नहीं मैम ये खोला नहीं सर को पूछते हैं
एक पेन दे जाइए मेरे को तुम जेब में लटका रखा है तो कोई क्वेश्चन आ जाता तो पूछना पड़ता है हाँ हाँ कोई बात नहीं देख तुम ऊपर ये ले जाओ A very good evening, a very warm evening to everybody. First of all, let me thank the organizers for planning this conference, in national level conference in one of the state and one of the prestigious institute, which is All India Institute of Medical Sciences, Bathinda, Punjab. And I'm standing here to tell you all and maybe to motivate you all, since I have been passionate about telling that research, undertaking research work is as important as academics and as the clinical work, besides your other family, personal, social responsibilities. So the day we start thinking that research is also as important as academics and patient care is, probably then we can make ourselves at a little bit higher ranking, national ranking as well as at a global ranking. So I think if we start seeing our country from a lens of measuring that where do we stand today as far as our health research ranking is concerned, or our health indicators ranking is concerned, or how far we have moved in achieving our universal health coverage, the sustainable development goals, the various measurable indicators with which we measure ourselves or we measure most of the countries and we place them in different ranking, first rank, second rank, third rank. And I'm sure that we do, as a country, we have done lot many advancements. And first advancement what really can come to my mind is that we have definitely increased the standard of our medical education in this country by having these premier institutions, which we call as Institute of National Importance, which is All India Institute of Medical Sciences, AIIMS, and that's very great achievement of our country, and I hope that there will be many more such institutions. But still, despite of having this number of institutions, we have to run fast. We don't have to walk, we have to really run if we have to, even if compare and reach at the standards of the All Indian Medical Science Delhi, the ICMR, the Indian Institute of Science Bangalore, our CMC Vellore, our PGI. These are the health institutions, but there are other science institutions also with which we really have to compare ourselves, and we really need to not walk, we really have to run fast, and that running will come if all of you who are attending the session online, offline, at least I say that the 50% of those who are listening to me get motivated to really change the path of their career as making research as their very, very important career. Now, introducing a bit about myself, I am an alumni from Rohtak Medical College, Haryana, MD University. I did my MD in community medicine from PGI, Chandigarh. And thereby, I worked for some time in some of the government medical colleges in Himachal and AIIMS, Delhi for some time, less time. Then I joined ICMR in 2006, January 2006. And since then, I'm here for last 18 years. It's around going to be a 2 decade of my career, my whole life, academic and professional career in ICMR. And everybody now knows what is Indian Council of Medical Research is. So Indian Council of Medical Research is an apex body in the country and the oldest body in the world who has been instrumental in promoting the health research agenda. And in 18 years, I have seen various achievements, various landmark initiatives which have been taken to promote the research and to train, to build the capacity of the country and to carve out the agenda of the research for this country. And we had been working very closely with the sister department, which is Department of Health and Family Welfare. So I have been now heading the division. We have a division at ICMR, which is extramural division, and one division is the implementation science division. So keeping portfolio of mine experience and my qualification and interest, I have been there as a heading the division of implementation science. But before I move to implementation research initiatives and programs at ICMR, I will take around 10 to 12 minutes, pardon me if they are a little longer, but they are important for all of you to know that the quality of the research work, research proposals which are submitted to ICMR for funding is optimally very, 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 very low. When I say very low, it really gives a pain to me. Then what are we doing here? We as an ICMR, what is my role? So this is some of these, when I come to such conferences, and I think I have promised to myself that wherever I go, at least I tell that why research is to be carried out and how it should be carried out, and what are the common pitfalls which all of you should be knowing. And I'm sure all of you, those who are sitting on the forefront, apart from my ICMR colleague, must have definitely tried seeking support from Indian Council of Medical Research, be it would have been a failure, be it would have been a success, or be it would have been in the process. So, the status of research in our India is not that appropriate, that accurate, that optimally quality-wise, which we should be having in a country where we have around 700 or odd number of medical institutions and other allied institutions as well. So the common thing which all of you should note that we do fund the research. We get large volume of research projects in our ICMR, but majority of the projects, majority of the proposals are rejected because of the poor methodology. They're rejected because of the poor methodology. They may have a good optimum idea, novel idea, they want to do it, and most of the experts, they say idea is good, intention is good, but how will he carry out, how will she carry out is not appropriately mentioned into the protocol. So when I say there is a project from your side and I am there to take it before the expert committee and I have to be defending your side, ki sir this is written here. If it is not written, I cannot defend your proposal. So the commonest pitfall we have is the very, very poor methodology section which is not appropriately written in the protocol. When I say methodology, it has to be as detailed as possible. You have to put up the study design, study setting, sample size estimation, and probably you can mention the flow charts of the whole method what you are going to talk about. If it is a house selection, how you are going to enter into the house. If it is a hospital setting, how you are going to select the first patient. If there are 10,000 patients annually coming to your hospital, your sample size is 500, how you are going to select those 500. So all those nitty-gritties are absolutely missing into the proposal. That is one thing. And the secondly, most of the projects, they do not mention the data analysis plan. So whole idea of mentioning the research protocol is various sections which have to be interlinked, interconnected with each other. So in 80% of the proposals, majority, they do not mention what are the data analysis plan. How will they collect the data? How they will quality check control the data, what are the variables, whether independent variable or dependent variables, what will be the analysis plan you will be mentioning, and if you add on the dummy tables into the methodology section, that will be definitely help you out. Another common thing which is not along with the protocol is the patient information sheets. In short-term studentship form, I don't know who are the MBBS students sitting here, and we don't get much STS application from this institution also. We do get from other institutions, and they're really performing well. It's a very small grant which we give to the students to encourage, because experts have advised to encourage students to do the research. So that is how we came up with a scheme of short-term studentship. So when in the STS, there is a whole, you have to put up the sheet, the consent form, the patient information sheet, the confidentiality agreement, all those things have to be mentioned. But in ad hoc or in our extramural grant proposals, we do not get all these information attached to the format. So there are many things which we can talk about it, that there is a lack of the sufficient information, there is no ethics angle which has been to be mentioned, then objectives are not syncing with the title. So lot many things are there, but I think if you all are serious about submitting the research proposal, so you have to take care of your all those missing links when you write a proposal. Now coming to my topic, which is the implementation research program in ICMR. So before I go to implementation real design, so anybody who wants to plan undertaking this implementation research, now what implementation research is, you need to understand the models. Now what this model is, this is one framework, this is one model. Now implementation research is unlikely than the surveys, than the surveillance, than the description, than the epidemiological studies. If any of you have undertaken some course or something about research methodology or a basic epidemiology, you will know that there are various kinds of epidemiology, like we have the cross-sectional and all those designs will come up. But what is different in implementation research is that you have a intervention you already have an intervention. For example, when you say that if I want administer intravenous dextrose or intravenous iron supplementation, it is going to reduce the anemia burden in our country. So what is the intervention? The intervention is IV use of this iron. Okay. Now this is a proven intervention, and this proven intervention has been undertaken in any of the medical school, any of the setting. Researchers have discovered it. But now whether this intervention will be applicable to all the settings, will be applicable to district also, will be applicable to the hospital also, will be applicable to the community also. That science, taking that intervention to a larger setting, apply to that intervention, we call it as an implementation. So there is a difference between implementation of the project and implementation research project. Okay. So implementation research, if you broadly see, there are 5 boxes. So in those 5 boxes, the box with the red boundary is having an outer setting. Now, when we say that, okay, make these anti-tuberculosis drugs available, it is working, DOT strategy is working, but before it starts working, we need to have, these are all the influencers. On the left hand side, all the boxes are those factors which influence the intervention. So we have the political support, whether the local chief minister of the community of the area wants his population to be given the drug, there is a political commitment, there are certain policies, there are various policies. For example, you want to say the neonatal hypothermia screening program, so that policy has to be there. So these are the settings on which we say that any intervention to be implemented into a larger setting is influenced by the outer setting, and this outer setting is very broad. Political commitment, policies have to be in place, and there have to be the adequate resources also. When we say that, okay, you have the NICSHA scheme for the tuberculosis patients, there is a political will. Okay, and we have the nutrition intervention program for the TB patient, there was a political will. So that is how the program was implemented. Now another setting on the blue boundary is we have the inner setting. Now this inner setting is those who will be providing the services, those who would be main implementers of that intervention, they also have to be convinced enough, yes, if it is to be done by ASHA workers, to the medical officers, to the CHOs, to the district program managers, they also need to be understanding, yes, this is the intervention, we are also convinced, we are also ready to get this intervention implemented in my district, in my state, in my subcenter. Another box is characteristics of the individuals. These are again an influencer. If we have to put up a contraception to a family, to a community, to a beneficiary, those characteristics, whether they are ready to take up those interventions or not. So that is called as a characteristic of those interventions. So on the left hand side, these are the 3 outer broad frameworks which affect the implementation research. Now on the right hand side, you have the intervention characteristics with the yellow outline. What does this characteristic means? That intervention has to be cost effective, intervention has to be acceptable, intervention has to make it effective, it has to make a change. And then the last green box, this is where we have that what is the process of implementation. Here it is implementation research. So if there is a research plan to be done for implementation science, you have to have the outer setting, you have to have the inner setting, you have to have the characteristics of the individual, put the intervention in place, and then say that, okay, I am the implementer, I am going to measure it is working or not working. So if it is not working, I have to do the iteration of that intervention so that it works in Bathinda or it doesn't work in another neighboring district, how it will work in neighboring district. That is the role of the implementers or the implementer researchers. Now, when we talk about broadly that I'm speaking about the implementation delivery research. So other three categories of the research with ICMR, we have the three other domains, that's descriptive, discovery, and development. Now this is, I take it kind of, it should not be affecting you. Should I submit the project on descriptive division, discovery division, or development? So whatever is your idea, it is us to see whether it fits into any of the four domains or not. But this is just for your knowledge that we have the 4 Ds, and they may last longer and they may not last longer, but the only idea is that whatever you write as a research project, you should be able to write it as appropriate, as good as possible. This is something I just wanted to tell that as for your knowledge, or those who want to apply to the ICMR funding, these are the four categories. These are the four categories. Starting from left hand to the right hand side, we have the small grant, an intermediate grant, and Center for Advanced Research, and National Health Research priority programs. In that subsequent order, what is difference between the small grant and the Center for Advanced Research is the credentials of the investigator, the credentials of the team. If the team is so strong enough, if the team is good, if they have a past track record of having good research, they are capable to get the Center for Advanced Research. And what does the Center for Advanced Research is? They need to have a holistic view and given to the country. Will they train the country? Will they train the, on any of the, lab parameters, on any of the environmental parameter or the climate factors and all? Whatever topic you think of, they broadly support addressing a major health problems. And we have the Center for Advanced Research on antimicrobial resistance. We have the Center for Advanced Research on neonatal mortality. We have the Center for Advanced Research in taking newer medication for tuberculosis also. And same is intermediate grant. These are all the financial ceilings. For intermediate grant, we have the ceiling of up to 8 crores. And for small grant, we have the ceilings up to 2 crores. But all these 4 categories of the research projects which ICMR plans to give it to investigators depends upon only the scientific merit of the proposal. It's only the merit of the proposal. We review it and we give the grant. Now, so this I have already spoken that we need to have, so if we want to have an implementation research project, we should have addressing what are the systems challenges. These are some of the issues: access to health care, we don't have appropriate implementation of the national health programs, inequity, quality of health care, lack of human resources, and non-participatory intervention. So these are some of the issues which you can take it as a priority topics from health systems angle, and you can fit into any of the condition you want to say, whether it is a CVD control program or a mental health control program or a vector disease control program. In all these programs, we will have these 6 challenges. How you overcome these challenges and barriers could be one of the research topics to talk about. Yeah, so this is, as I have already spoken to you, that intervention has to be effective. But when we say that intervention has to be effective, it hardly matters that with what study design you have been, making these interventions effective. So somebody say that in implementation research project, we need to have a qualitative and quantitative study designs, but it is both. It can be both designs. Even in the implementation research, we take the systematic reviews, meta-analysis as again approach to address that research question. We can take the randomized control trial also. Today only in the meeting there were few projects on randomized control trial, and they were debating upon that why it is an implementation research. I said why not? Because they have taken the community as a broad unit of testing as a control and another community as an experimental or intervention arm. So we can have, if not blinding, but at least we can have the randomized control trial. So study designs have to be appropriately chosen even if for the implementation science. But remember the formula for implementation research, you have to have a proven, effective, workable, upscalable intervention in hand so that you can work upon it. So this is a cycle when you start planning, writing and implementation research project. So you have to start from number one, what is the context? What is my area problem? Go and discuss with your chief medical officer, go and discuss with your district planner. So yesterday some of the experts and one of the researcher had come to me. He wanted to undertake a study in the state of Madhya Pradesh. I said, you go and ask the Secretary Health Services what is his problem. Because if it is an implementation science, any health systems project, you need to talk to the health officials, what is their problem. We as academician, we as a researcher are the facilitators to improve the health conditions. We just advise them how to go about it. We cannot, just take the topics of our interest. So definitely you have to have a stakeholders engagement, you have to have the framework. As I tell, CIFR is one framework, RE-AIM is another framework, and this intervention has to be adapted and with the fidelity. So these are some of the do's and don'ts which I'm very fond of, because I really tell very precisely what you should not be doing and what is the deficiencies in an implementation science research projects. I will not go one by one, and I take the right hand box with the last two bullets. You see that limited or absence of the stakeholder. We get the project from AIIMS Bathinda, but there is no stakeholder engagement. We want to stall the national program for anemia prevention, but the district program officer of anemia is not on board with us. We want to prevent, we want to encourage the mental health services, but the district program manager for mental health is not on board with this. So those are some of the issues, and then lack of very clear strategies. So you must go through all these do's and don'ts. I'll leave the slide with the organizers, but please go through them very carefully, and one by one word has been written with all of my experiences while reviewing the project at ICMR. I'll just take one example, and this is one project which we have initiated as a National Health Research Priority Project. A National Health Research Priority Project is undertaken by ICMR, where we call an expression of interest for them to participate, and we shortlisted. For this project, we received around 100 applications, and based upon their merit, we selected only 4 sites, because we do not want to compromise the quality of the research as well. Now, what is that intervention for this project? We have trying to improve the coverage of the non-communicable disease services, improve the quality of the services, and equity of the ambulatory care services. We all know, and I don't know how much of you have been well oriented toward the health care services of your neighboring district, but this is really an issue. We do not have adequate manpower, we don't have quality services, we don't have, I always give an example sometimes, the person who is dying of diabetic ketoacidosis is being managed at a subcenter level, and the person who needs just simple medication for diabetes comes to AIIMS Bathinda. So that is something which is very, very, not a good situation for us to handle. So we should be having an equity of the ambulatory care services. So this is one project which we have started from ICMR, and these are the 4 sites which have been selected. And last week I was in Agartala, where the Chief Minister of the Tripura, he himself came and inaugurated this project, and he has given all the support that I will make appropriate referrals, I will make the medications for non-communicable diseases, I will establish the referrals and the linkages, and same we are doing it in Chittor, Nagpur and district Faridabad of Haryana. And on left hand side you see the 8 set of interventions, and all these interventions are doable, workable. Our doctors do not have the standard protocols. We will give them the standard protocols, and ICMR has already developed the standard treatment protocols. Dr. Vitul is aware about it, and I will not talk much about these STWs because that's not my topic here today. Of course, these are available on the website. Strengthening of the governance mechanism. We have the secretary, we have the chief minister, we have the program officers, all political will is there. Probably, I think we are able to tackle the NCD, and they have said that after reproductive and child health, NCD is my priority, CM said, so they are going to address patient empowerment. Again, important intervention. If we don't empower the patient, we are going to lose these patients. Strengthening referral, team building, supportive supervision, and effective use of health information technology. We are using the mobile for all nonsense purposes, but not for strengthening our, the patient care. So this is another project which I will not go in much detail. Again, a national health priority project. It really gives a very shameful figure across the global agenda when our neonatal mortality is in double digit. In one of the state, kids, neonates are dying even if born normally, and neonatal mortality is around 21. In some of the states, it is 7. And why should we allow the babies to die when they have been born normally to a normal mother? So there is something which is definitely painful and shameful to us. So we started this project on neonatal mortality again as a national project. And here are the set of interventions which we are planning. And the whole cascade of care from the antenatal services to the postpartum and to the small and newborn babies, we are trying to address. And this is for this project, just to tell all of you that the international agency Bill and Melinda Gates Foundation also has joined hands with the ICMR to address these issues of this. So this is another project of implementation which is ongoing. So I think I'm about to end of my talk here, leaving with the message that whenever you apply to the Indian Council of Medical Research, these are some of the priority topics, and they are dynamic, they are variable, they keep on adding and deleting some of the topics into it. And if you do not find any of the area compatible or included into this list, there is always a scope of adding the others. And my personal experience, we hardly see when we review the project whether it falls into the priority list or not. So we just simply review the project as per their scientific merit. I don't know, I have been forcefully asked to stop. The mic has stopped working. So I will not go in more detail. I really wanted to say all, but yes, in the last slide, of course, start with a very proven intervention, collaborate for success, adapt to the local context, because cancer is a problem in Punjab, so you should have addressing those issues. So this is all about intervention, but one last message I would definitely like to give you, that I have been asked that, you are the person who has been going to various states in the country. You encourage so many researchers. So my, again, message to all of you would be that at least from the audience, the next call is going to be open in the month of December 2024. Must get some projects from Goa. I went to Goa, now I'm in Bathinda. So probably I get some good research projects, and I see from AIIMS Bathinda, probably I like to do justice. So thank you so much for patience hearing, and apologies to organizers for overtaking the time. Thank you so much.
Madam, your mic was not switched off because we dare not do that. ICMR is a premier research organization of the country, and we are really honored that you and Dr. Ravinder are here. So it is a great honor for Bathinda. People think or they don't think as far as the AIIMS is concerned, but we are really honored. And when I met you at Solon, after that I am following ICMR site, and you have beautiful flow charts and guidelines which are really beneficial. And we have sent the message after meeting you to all the, in my group, that you must visit ICMR site, go for the guidelines, take out the printout of any disease, and it is so concise and evidence-based for public health. It is a great thing. So having you here, next time also we will organize it somewhere else with larger audience, and still I must assure you that your lecture will be shared to thousands of people once we get it and put it on YouTube. Thank you very much for honoring us with your presence. Thank you.
Thank you, Dr. Vitul. And just two more messages I want to use this platform.
Please.
Number one, you rightly mentioned the standard treatment workflow. May I request everyone to please open their mobile phones and type into their Google, either the Play Store or the App Store, just type the word standard treatment workflows. You will get 157 standard treatment workflows of 25 specialities. We have made these workflows one pager. Actually, I was supposed to give the talk on one pager document, but topic was this. So you will see that depression has, infertility has, epistaxis has, hypertension has, diabetes has, and this is very useful for all the doctors, and this is the right platform, number one. Number two, that we are conducting the webinars. And we have done 4 webinars, and these webinars are available on the YouTube. There's a whole playlist, and the first induction webinar was done by Dr. Rajiv Bahal, and I did the second one. Subsequently, these 4 webinars have been done. Please download all the webinars. Next webinar will come up on 9th of October. Do listen these webinars very carefully. Of course, there is 1 hour of each duration. You are going to be immensely benefited by all the experts who have spoken about these webinars. So thank you so much for again telling, sir.
Thank you very much. And next time when we call you, you can have your own favorite topic about one thing about the flowchart.
Yes,
but definitely, we will be blessed and honored if you accept our next invitation also. Now you have come here, you have previously also visited AIIMS, so we will increase our hospitality as well as audience when you come next time. So that invitation extends to you also, sir. Thank you.
Me and Dr. Ravinder have done around 200 research methodology workshops in the country.
I was reading in newspaper, a few days back about the bioprofile of Dr. Ravinder, and he was honored for the great research what you two people are doing there. Thank you very much. Yes, please. I invite you for your talk. And again, it is great honor to have people from ICMR. मैं तो आपके साथ हाथ मिला के ये कहता हूँ कि थोड़ी बहुत ही रिसर्च मेथडोलॉजी आ जाएगी हाथ मिलाने से. So, thank you very much.
Namaskar and good afternoon to all of you. It's a great honor to be here in the auditorium, beautiful auditorium of AIIMS Bathinda, and I thank you, Dr. Vitul and the organizers, and also congratulate you for organizing such a huge program. I think that really, is a commendable work which you have done. So, my duty was to tell about the new topic. I think most of the people in the audience, I don't know whether you know. First, I will just a small introduction about myself, that I am graduate from Government Medical College, Patiala, and then I did my PhD from Jawaharlal Nehru University in Public Health, and currently I am working as a scientist with the Indian Council of Medical Research. In the audience, have anybody heard about the term assistive technology? Anybody? Can you raise hands? People, those who know me, doesn't have to raise their hand. Anybody from the student side? Have you heard the term? Anybody using spectacles? Are you using? So, spectacle is one form of assistive technology. Okay. Anybody using hearing aid? Wheelchair? Stick? Walker? Mobile phones? All of you are using. And so, when we talk about assistive technology, we start with the functionality and disability, controversy. In India, I don't know, one part is missing. So, there are two, issues in India. One is disability, other is the functionality. So, I'll not go into detail, but disability is a larger topic and it has more so of a social relevance. And in the disability, the health component goes to the health department, which we have totally neglected till now. So the responsibility of health is to deal with the functionality, morbidity and mortality. So functionality is the ability of human body to perform certain functions, and morbidity we all know that basically what we are learning here and treating the patients, and mortality is the end of the life. So our efforts remain focused on these three areas: how to prevent mortality, how to treat morbidity, and how to restore the functions. But we never think of all these things what we do. So most of the chronic health conditions interfere with functionality and restrict or impair our functions. Whenever somebody falls sick, they either are given bed rest or they are supposed to not to take certain physical activities which we normally do. So it could be physical, physiological or sensory. So the functionality could be affected due to our physical functions or physical structures and physiological functions and sensory functions. So that is what we talk about the assistive technology. Assistive technology is generally a broad term which includes the assistive products or devices or aids or appliances or instruments or softwares which are used for maybe locomotor, visual, hearing, cognition, communication, self-care or sports, recreation, leisure activities. So anybody who has these kind of conditions which are listed here, they are having some difficulty with the functionality. So people with chronic diseases, bone injury trauma, older persons. So why we say that this discussion among competition between functionality and disability is because when we say disability and it affects functions, but on the other side the same kind of function may also be affected in the older person, but we don't say that they are disabled now. So that part is mostly the responsibility of health. So we have to own it, and that is what my role is right now within the overall function of Indian Council of Medical Research. So then children with autism spectrum disorder, neurodevelopment disorders or learning disorders, and then mental illnesses or mental health problems. Post-infection situation like leprosy or polio, there are certain functions which are affected or restricted. Then people with gradual cognitive decline, and also the people with disability as per the RPWD Act. So all these conditions, they can be very well managed with help of the assistive technologies. Now the government gazette, this is 2020 gazette, which says any of such product should be considered as drug. So that means they are medicine now. So that's why we are talking here, because any spectacle, hearing aid, wheelchair, walker, they are now the part of health and are considered to be as a medicine, among the medicines. So here we talk about the healthcare continuum. We deal with prevention, we deal with the promotion, we deal with managing the conditions or rehabilitation and assistive care or assistive technology and palliative care. This was earlier, you might have heard or read about 5 part of the healthcare continuum, but now WHO says that it has to have 6 components. One of them is assistive care and assistive technologies. So assistive technology refers to product and related systems and services developed for people to maintain or improve functioning and thereby promote well-being. It enables people with difficulties in functioning to live healthy, productive, independent and dignified lives and participating in education, labor market and social lives. So now again, this diagram or this flow chart on the right side talks about the health product. Again, this is a new thing which is under consideration now, WHO. All the product or instrument or equipment used in the healthcare settings are now termed as health products, which could be drugs and medicines, which could be diagnostic, assistive technology, medical devices, which could be vaccines, blood cell gene therapies, or digital technology like softwares and apps. So these out of these 7 category, assistive product deal with 7 domains, as I already said: locomotor, visual, hearing, cognition, communication, self-care, sports, recreation, and leisure activity. But somewhere I read there are other classification also as per ISO 9999, which is the basically setting the standards of various products. So ISO 9999 talks about 12 categories, and ICF classification, International Classification of Functioning, Disability and Health, they talk about 12 categories. I think 16 categories. So this is the new classification which will be, adopted by WHO. It's under consideration and under debate, and we are discussing it. And already lot of discussion has happened, and very shortly there will be a document in the public domain for the comments also. So the domains covered as already shared. Now these are the common assistive technologies. This has been like now common is walking sticks, eyeglasses, white cane, torch, wheelchair, anti-bed sore mattresses, auxiliary crutches or elbow crutches, bed protecting mats. So there are n number of assistive products which are available, which we are now trying to position within the healthcare settings. So then there are specific products for children, because among the functions which children are performing or older persons are performing are totally different, because children has to go to school and learn new things. So the cognitive products or communication products are more important for them. Then what are the role of assistive product in the chronic medical conditions? So if we say they help in the prevention, the assistive technology help in preventing the worsening of chronic condition and secondary complications. They are also monitoring devices like wearable and small devices like blood glucose monitors, heart rate trackers, blood pressure monitors. They all help us in preventing the disease progression by alerting users and healthcare provider about irregularities. Now this watch, they have so many functions. You can do ECG, you can monitor your heart rate, you can monitor your blood glucose levels also. So many advancements have come. So wearables are one of the very important assistive products now in our lives. So there are mobility aids like orthotics, shoes, walkers. Now for diabetic, the orthotics or therapeutic footwear is very important, which is another big area which we are developing now. None of the standards are available for therapeutic footwear globally. So we are trying to define those standards for our populations, especially for diabetic, because foot care is very important for them. And then there are other similar requirement for children with footwear, club foot, or maybe cerebral palsy, and so many other conditions like that. Ergonomic solutions also, they also help us in our back pain, like good beds or chairs or tables in our office spaces. Then management of chronic medical conditions also, the assistive product help us in managing. So like adaptive utensils and reachers and bathroom aids, they help us in the management of various chronic medical conditions. Medication managements, the automated pill organizer, dispensers and apps, they send you the reminders. And also the sensory assistive devices for individual with hearing loss or visual impairment or cognitive issues. So there are screen readers also. And then now there are a lot of advancements in the software industry or software area, which help us immensely, and we can also, take help for our patients, because so many patients, they forget to take the medicines. So reminder and alarms and wearables are very helpful devices. And then rehabilitation, exoskeleton and robotics, there are advanced level of devices available now which help our patient during the rehabilitation phase. The prosthetic and orthotics, custom designed limbs, braces or splints, and cognitive rehabilitation tools like devices and apps that improve cognitive function, such as memory aids or brain training apps, or like brain computer interfaces. There are now, artificial limbs which works with which can be controlled with my brain, with the patient's brain. So also the assistive care help us in maintaining the quality of life through telehealth and remote monitoring. Lot of telehealth systems are there, beautiful telehealth systems are there, which can, you plug in the different things, you can do the blood test, you can do ECG, EEG, so many things you can do through those kind of, machines. Then communication aids. So those people which are not able to communicate with others, there are certain, sensors which detect their emotions, and convert it into text or audio or videos. And then environmental control, again, one of the very important area now which we are working on is the home automation, because our elderly, they are alone at the homes and nobody there to take care of them. So there are certain home automation systems which can be used to give them a good dignified lives. So this is the exercise which we did in ICMR on the pattern of WHO. This is called National List of Essential Assistive Products. WHO had in 2016 proposed a list of 50 products called APL list, Priority Assistive Product List, which they wanted, because we are the part of WHO and UN. So whatever is, proposed by WHO, it is almost mandatory on the countries to adopt it. So we did that exercise. It was a huge exercise, and we have come out with these 21 products which are now in the public domain. You can download this PDF file from ICMR website, National List of Essential Assistive Product, and this list includes hearing aids, and then aids for the visual impairment, walkers, wheelchairs, then braces, artificial limbs, therapeutic footwear, ramps, and then various type of mobility aids, mobile phone. Mobile phone are again two types. One is those which can be used by the older persons, where the font size or the only buttons are there, and very few commands can be done through that kind of mobile, or advanced level smart mobile phones. And also the incontinence products, which are used by mostly the patient who are bedridden in the hospital environment or at home care or the home settings. Then there are certain, fall detectors. So this list is basically indicative list, and it is like that now it's in essential list. So you might have seen during the COVID time, bread and milk used to be the essential item. Similarly, this list also has become mandatory for the governments to take it up, and slowly we are building around the systems for the availability of this product even in the remote and rural areas. So I'll stop it here because there are many other slides which I had made, but they are mostly related to the cognition and communication area. So any questions, you are most welcome. Thank you very much.
Thank you, sir, for a very informative talk, especially in assisted device, what ICMR is doing. I think most of the people are unaware. So until and unless they visit the site of ICMR, only then we will be aware that what ICMR is doing for control, prevention, as well as in the area of assisted devices. Thank you very much, and we are really honored to have you here.
So I would request the audience to, if they can visit the National Center for Assistive Health Technology, NCAT, download this list, and you can visit the NCAT Center at AIIMS and IIT Delhi and IIT Madras and NISH Trivandrum. So you will have the actually, real feeling what we are doing as far as innovation is concerned. Thank you.
Thank you, sir. Thank you very much. Before we start our next lecture, I want to acknowledge the presence of Dr. Prashant Joshi. Please, sir. So he is Director, AIIMS, Nagpur. It is real an honor to be here to host Dr. Joshi as well as Dr. Sajid Ansari, who has just come from Lucknow to deliver a talk here. So we are really honored to have you here, sir. So I am sorry that audience from AIIMS is not here. So thank you. Proceed with the next lecture.
Now I'd like to call upon Dr. Arun Thapar, Consultant Physician, Gomti House, Mall Road at Ludhiana, to present his thoughts on sleep disorders, subtypes, causes and management.
This is the one which is one. Next slide. Good afternoon, everyone. Thank you, Dr. Vitul and the organizing committee for inviting me. It's a beautifully organized conference, extremely professional. I'll not take much time. I'll proceed with my presentation and then we'll see. So sleep disorders, types, subtypes, cause and management. I've tried to show here a beautiful painting by a Russian painter, Victor. It's a world-class painting. It's an old proverb, a good laugh and a long sleep are the best cures in doctor's book. How to define a sleep? Sleep is a state of reversible behavior in which there's a perceptual disengagement and unresponsiveness to one's environment. It is also defined as a period of rest for the body and mind during which volition and consciousness are in partial or complete abeyance and the body functions are partially paralyzed. Sleep is important to a number of brain functions, including how nerve cells communicate with each other. Humans normally sleep in supine position with eyes closed. Now, unusual phenomena could be sleepwalking or sleep talking. A very burning question comes up, is sleep an active or a passive process? Normally, everybody thinks it's a passive, but the surprising part is that it is not a passive process, but an active one. In fact, the brain and the body stay remarkably active while sleeping. It is supported by PET scan and functional MRI. The red areas denote state of higher activity, which we can see in the REM sleep, which is the rapid eye movement sleep, a deep sleep. Why do we sleep? What is the need for sleeping? Normally, 1/3 of the human life is spent in sleep. There are different theories which are put forward. The first one is protective behavior adaptation. Energy conservation is the second one. Hormone regulation. Fourth one is memory consolidation, creativity, and brain restoration. Fifth one, immune function regulation with the role of natural killer cells. And the last is emotional balance and mood. I'll take briefly one by one. I'll not take much time for this. The protective behavior adaptation, it was thought that during 24 hours, the species and the animals need to protect themselves, hence they sleep, but didn't hold true for all species. Energy conservation, it was postulated that in order to survive, body needs rest to conserve energy, but this theory has its own limitations. Various hormones have been associated with the sleep, namely melatonin, cortisol, growth hormone, and thyrotropin. They play a big role. Other associated hormones are acetylcholine, 5-hydroxytryptamine, norepinephrine, gamma-aminobutyric acid, orexin, and serotonin. Hormone regulation during sleep. I'll highlight few hormones. That melatonin production will starts before the sleep and peaks at midnight. The cortisol levels are pretty low at night, but they peak early in the morning. Thyrotropin and growth hormone, both of them peak at night, and the cerebral blood flow is at a height, its peak during the midnight. Now, memory consolidation and creativity, whenever we receive some information, it is stored in the brain in a specific formulation. There's an encoding, followed by storing, leading to imprinting, and then for last is recall. Sleep plays a housekeeping role. It removes toxins and metabolic waste, just like immunoglobulins, proteins like beta amyloid and protein fragments from the interstitium, while lymphatic system in the brain, which build up during awake state and settles memory. It is the beta amyloid non-clearance and its deposition which is a risk factor for Alzheimer's. Number of studies are being carried out on this beta amyloid non-clearance. Immune function regulation, it gets activated during night, especially there's increased production of natural killer cells, which are WBCs, which destroy infected and diseased cells, thereby destroy the cancer cells. Last is emotional balance and mood. Amygdala, which is next to hippocampus. The main function of amygdala are emotional responses like happiness, fear, anger, or anxiety. It is a sleep deprivation which leads to excitation of amygdala and which further leads to phases of irritability, anger, and mood fluctuations. Amygdala excitation is one of the precursors for the substance abuse, and in contrast, frontal precortex exerts suppressant effect on amygdala. Sleep plays an important role in maintaining a normal homeostasis of the body. Another painting by a Spanish painter, Antonio de Preda in 1655, the Night's Dream, quite a famous painting. I'll just touch a few lines with the anatomy part. It is a suprachiasmatic nucleus which is situated in the anterior part of the hypothalamus. It is the central pacemaker of the circadian rhythm. The efferent tract is the retinohypothalamic tract, and the efferent tract starts from the pineal gland, which further secretes melatonin. Try to show over here the retinal ganglion cells with the light, how it affects the system. We have the retinohypothalamic tract is there, the pineal gland secreting melatonin, which play a role during the night, during the sleep part. The physiology of the sleep is, when there is a dark room, which stimulates the suprachiasmatic nucleus. There is a release of norepinephrine, which irritates the pineal gland. There is a release of melatonin. That initiates the circadian rhythm, which further leads to release of prolactin, ACTH, norepinephrine, melatonin further secreted, and this cycle is repeated. Just like what starts the circadian is the melatonin, and what starts the sleep cycle is the dark room. Normal awake sleep cycle, we have two factors basically, homeostatic factor and the circadian factor. Homeostatic factor stands for, or also known as factor S. It is dependent on the number of awake hours prior to sleep, and whenever we remain awake, there is accumulation of adenosine. And circadian factor or biological factor or factor C, it is maintained by the suprachiasmatic nucleus. Now there is a balance between factor S and factor C, which I've tried to show over here. Another slide is there showing the process C and the process S, how we remain awake and how we start sleeping. Polysomnography, EEG, electrooculography, electromyography help in collecting different waves from the brain like alpha, beta, theta, gamma, delta, leading to differentiation of the sleep stages. Sleep is divided into two phases, non-REM and REM. Non-REM stands for non-rapid eye movement, and REM is rapid eye movement. Non-REM is stage 1, 2, 3, 4, but lately stage 3 and 4 are collectively known as slow wave sleeps, and we have tried to combine them also. And REM sleeps for rapid eye movement. Now try to show over here that the normal sleep, the NREM constitutes 75 to 80% of the sleep, and the REM or the deep sleep is the dreaming sleep constitutes only for the 20 to 25%. To start with, there is a stage 1 when the body starts relaxing. Stage 2, the brain slows down further. That is the maximum part of the sleep a person is 45 to 55%. Stage 3 and 4 collectively known as where body and tissue restoration takes place. It's a deep restorative sleep. And the last is rapid eye movement, where the learning and memory consolidation takes place. We call it also a dreaming sleep. Now, waves during sleep. During the awake state, I've tried to formulate a small graph over here. You can see that in the awake, when the eyes are open, there are beta waves. I've written B to start with. And when in the awake state, when the eyes are closed, is the alpha waves come up. And NREM, in the N1 stage, the first stage, the theta waves are there, which are so-called positive sharp transients. N2 spindles, in the N2 stage, there are sleep spindles or K complexes. Often we have teeth grinding or bruxism seen in children. Now N3 sleep stage has got delta waves basically, which are low frequency, high amplitude, sleepwalking, night terrors, and bedwetting. Another thing, for the bedwetting, we often use imipramine in children, and the basis behind it that it decreases the stage 3, thereby leads to improvement in the bedwetting. Regarding the rapid eye movement sleep, there are beta waves. Dreaming and memory processing takes place. One remembers dream. The waves are sawtooth appearance. Muscles are paralyzed except extraocular and breathing muscles. Now, word about latency. What is latency? It means that how long. Now, sleep latency is the time taken to fall asleep, and there's a word which I'll use in diseases further, the REM latency. It's the time taken to get to REM sleep. Now, I've taken to start with just one disease, like a depression, in which the sleep latency is increased, the REM latency is decreased, the N3 or the delta waves are there, which are decreased, and the REM density is increased. It is the first REM phase which is increased. And when we use SSRIs or antidepressants, we try to suppress the REM sleep. Conditions with increased REM latency are restless leg syndrome, older adults, and conditions with decreased REM latency are depression and narcolepsy. Slow wave sleep, considered as most restorative sleep, occurs in first half of the sleep, and 20% of the sleep time is spent in this stage. There's an increased vagal tone with decreased sympathetic activity, leads to decreased heart rate, blood pressure, and cardiac workload. Now, one sleep cycle is consisting of one NREM and one REM. And average time taken with one sleep cycle is 90 minutes. For a normal individual, we have 4 to 5 such sleep cycles in a night. In the initial part of the sleep, you can see that there is a slow wave preponderance. One often lands to stage 3 and stage 4. And as the night progresses, in the later part, the REM sleep preponderance becomes much more. Again, I've tried to show a hypnogram over here. The initial part of the night, slow wave preponderance is there, shown in the red color. And the later part of the night, REM sleep preponderance is there, which is shown in the blue color. Slide of a polysomnogram. Stage 1 showing slowing of the activities of the brain waves. In the stage 2, we have K complexes. REM sleep, a typical pattern is shown over here. I'll not go into details about all the physiological changes which take place in the awake state, the REM and NREM. For the heart rate, blood pressure, cardiac output, respirate, it will take a lot of time because we are short of time at the moment. Now, a few words about the wake control mechanism and how it works. The accessory pathway is in the form of reticle formation, which goes to thalamus and cortex. The neurotransmitters involved are norepinephrine, 5-hydroxytryptamine, dopamine, orexin, And hypocretin, which is a neuropeptide secreted by the hypothalamus, plays a big role. It helps in regulating arousal and wakefulness. Orexin also helps, has a big role in the appetite part also. And lack of orexin leads to narcolepsy and obesity. I'll just a brief word about what is NREM sleep. It originates at the ventrolateral preoptic area, surpasses the activity of the wake-promoting substances, thereby initiates NREM sleep. And for REM sleep, it originates at the lateral and post-pontine neurons, cholinergic in nature, exert inhibitory neurons to spinal motor neurons to produce REM atonia. Now I've tried to show over here the wake-promoting substances and the sleep-promoting substances. On one side, we have adenosine, GABA, ghrelin, and melatonin, and on the other side, we have norepinephrine, histamine, serotonin, and hypocretin. It all depends which way. If the wake-promoting substances are on a higher side, one gets awake. If the sleep-promoting hormones are on a higher side, one tends to go to sleep. Same way, it's a sleep-wake switch. Acetylcholine, histamine, 5-hydroxytryptamine, orexin, norepinephrine on one side, and I've tried to show the other part on the other side. Decreased REM is associated with synucleins, a protein associated with synapses in the brain, and often seen with patients with Lewy bodies. Sleep duration, 14 to 15 hours for an infant, and well, it keeps on decreasing, and the elderly go by only 6 to 7 hours. Now, criteria of a normal sleep is dependent on quality, quantity, and timing of the sleep. The International Classification, or ICSD 2014, is based on pathophysiology and the symptoms. We tried to classify into the following one. First is insomnia, second is sleep-related breathing disorders, hypersomnias, circadian sleep disorders, parasomnias, sleep-related movement disorders, isolate symptoms. Just few points about it. Insomnia, which is a lack of sleep, leads to exhaustion, drowsiness, anxiety, depression, cardiac and metabolic problems. It has two types, chronic and short-term. Chronic is more than 3 months, 3 times a week, and short-term is less than 3 months. Clinical features are inability to initiate sleep with good congenial environment. Most common disorder seen in 10% of the population, which gets up early, the patient gets up early, associated with headaches, body aches, and mood changes, leads to anger, irritability. One should follow a heart-healthy style. Make your bedroom sleep-friendly. Avoid caffeine, nicotine, and alcohol. Avoid afternoon naps. Go to sleep and wake up around the same time. Have a good physical activity like yoga. Eat meals on regular schedule and try to learn meditation. They all help in insomnia. Medications for insomnia should be used at the last when other factors are not working. We have benzodiazepines, benzodiazepine receptor agonists, melatonin receptor agonists, orexin receptor agonists, and tricyclic antidepressants. It all depends on the clinical condition of the patient. Sleep-related breathing disorders, and during sleep, the gravity and muscle relaxation allow the tongue and the surrounding soft tissue to fall back into the throat, obstructing the airflow. I've tried to show over here obstructive sleep apnea, which is of two types, adult and pediatric. Then there's another entity called central sleep apnea syndrome. Third is sleep-related hypoventilation disorders and sleep-related hypoxemia disorders. Just a wave pattern, which we observe in the polysomnography. What is the obstructive apnea, mixed, and central apnea, how we differentiate them. Now, criteria for obstructive sleep apnea is one has normally it's an obese, large-sized neck, complains of sleepiness during the daytime, and non-restorative sleep, fatigue, and insomnia symptoms are there. Patient wakes up with a breath holding or gasping or choking. Bed partner reports there's a loud snoring, interruptions in the breathing, or both. Patient is often diagnosed with hypertension, cognitive dysfunction, mood disorders, coronary artery disease, CVAs, CHF, diabetes, and atrial fibrillation. Treatment lies with basically lifestyle changes. One should advocate loss of weight with exercise, quit smoking, alcohol. Nasal decongestants should be used, and avoid anti-anxiety or sleeping pills. Therapies like cognitive behavior therapy and biofeedback, CPAP and BiPAP play a big role over here. Hypersomnia is excessive sleep. We call it as narcolepsy. Ability to regulate or sleep-wake cycle is impaired. I'll be short, just don't. Frequent lapses into sleep and the elements of the sleep while awake. Hypersomnia is narcolepsy type 1, type 2, idiopathic, Klein-Levin syndrome, hypersomnia due to medical and psychiatric disorders, hypersomnia due to medication of substance abuse, lack of wake-promoting substances, and inefficient sleep syndrome. Now, narcolepsy is daytime sleepiness, catalepsy, hypnagogic hallucinations, and sleep paralysis. A few words about catalepsy is a loss of muscle tone. The treatment is gamma hydroxybutyrate, also known as a date rape drug. Salt is sodium oxidate. Person taking this drug when mixed with alcohol goes to sleep. And the mechanism of action is it works through GABA B, whereas benzodiazepines work through GABA A. Modafinil is used to keep the person awake, and narcolepsy is associated with hypocretin system, and orexin is deficient. Circadian rhythm, there's a delayed sleep-wake disorder. One sleeps at 4 a.m. and gets up after a normal sleep, with a normal sleep of 7 to 8 hours. Advanced sleep-wake disorder seen in elderly patients, they sleep early and get up at the midnight. Irregular sleep-wake disorder, rhythm disorders, shift worker disorders seen in shift worker disorders, and jet lag disorders. Chronotherapy aims to restore proper circadian rhythm of sleep-wake cycle through adequate hygiene, timed light exposure, and use of chronobiotic medications like melatonin. Parasomnias, which is abnormal behavior during sleep, sleepwalking, or sleep talking. Types NREM and REM related parasomnias. Few differentiations between NREM and REM related parasomnias. Now, the sleep last is sleep related movement disorders, where we have restless leg syndrome, periodic limb movement disorders, sleep related leg cramps or bruxism, benign sleep myoclonus, propriospinal myoclonus, and sleep related movement disorders. I'll take restless syndrome only. An urge to move legs accompanied by or thought caused by uncomfortable and unpleasantness sensation in the legs. They begin or worsen during the periods of rest, such as lying down or sitting, relieved by walking or stretching the limbs, or as long as the physical activity continues. Must check the serum iron levels, which are extremely low in patients with restless leg syndrome. Treatments, medical treatment lies with gabapentin, pregabalin, ropinirole, and few other mentioned drugs over here. Few sleep facts. The longest someone has gone to sleep is 11 days, 25 minutes. Of 2 lines about Kumbhakaran, that the man who used to sleep for 300 days, brother of king of Lanka, Ravan, a devotee of Lord Brahma, he suffered from hypothalamic syndrome, Klein-Levin syndrome. There's a bilateral ventromedial nucleus involvement and characterized by periodic episodic somnolence. There's hyperphagia, along with other behavioral and cognitive difficulties. I'll not touch these different species. Dolphins sleep in the upright position with one hemisphere. It is just a few lines about what is somnophobia. It's a fear of falling asleep. Onirophobia is fear of nightmares or dreams. Clinomania is irresistible urge to stay cozy in the bed, while dysania is feeling when woken, don't want to get out of the bed. Sleep hygiene is bright screens like TV, video games, phones, and laptops should be avoided. Avoid alcohol intake 4 to 6 hours before going to bed. Avoid caffeine, nicotine. Avoid excessive exercise before going to bed. Thank you so much. Any questions from the audience? Thank you.
Thank you, sir, for this informative presentation. Now, I'd like to call upon Dr. Sajid Ansari, Director, SS Heart Care Center at Lucknow, to present his thoughts on ARNI in hypertension, myths and realities.
Thank you, Dr. Vitul sir, not looking here, ma'am is here, for inviting me here. All of you speakers are still here, waiting for their cue. Friends, topic allotted to me is ARNI in hypertension. And this is a little bit controversial topic, In our guideline, we are not using this drug as antihypertensive medicine. Then why to discuss? Yes, this is time to discuss. Because once we make the thought process that blood pressure is not a disease of magic arithmetic number. Yesterday it was 160/90, today it is 130/80, okay, wow, balle balle. In all conferences, everywhere, we are giving advocacy of calculation of risk score. But when we are getting the patient of hypertension, most of time we stuck on ABCD, different group of medicine, ACE, ARB, beta blocker, diuretics. Okay, that is a mandatory part to reduce the blood pressure. But if you see the incidence of HFpEF, 40 to 45%, 5% causes of this HFpEF is hypertension, rest diabetes and some other obstructive sleep apnea and so and so. So, while giving the advocacy of ARNI, we should have from the day one make one plan in hypertensive patient, what is condition of our patient vasculatory, what is condition of their different marker of inflammation, and what he is going to behave in the futures. So that's why there is a need of time to discuss something about this ARNI. Because you know these are magic drugs. When paradigm HF trial was introduced, we all using in HFrEF patient and magic pill, a recurrent hospitalization reduced by this medicine, and we have thousands of patients in my follow-up and wonderful molecules. Then subsequently came era of HFpEF. It was failed in HFpEF, but there was some point that should be noted with the ARNI. And that's why this was the reason that Asian country, they started their trial in hypertensive patients. Anyway, this is some usual graphs. When you are going to control blood pressure well, you are increasing the longevity. Otherwise, we are going in early part of life. So daily adjusted life years, daily, what is this? If you see different risk factors, we know that from the third year MBBS we are reading this modifiable, non-modifiable risk factors. So, but if you see the percentage of contribution in development of cardiovascular problems, hypertension is under driving seats. So, from the day one, we should make the plan and a plan how to make, you calculate the risk factor, that is more important. So, hypertension is a leading cause of cardiovascular disease and all-cause mortality. This is data not, we are, not lagging very much behind than the Western data. If you see the Western data also, the issue is how much patient is diagnosed hypertension, how many of them well controlled, and how many of them going to reduce the complications. So you see this magic number, around 30-40% diagnosed, out of them around 30% treated, and around 15% is well controlled. And this is true with the Western data also. So, hypertension is a disease awareness, treatment and control program. Tomorrow is the World Hypertension Day. So, World Third Day. So, we should have something for our patients to explain him that don't rely on the one blood pressure measurement and don't think just a disease of magic number. Coming to part of treatment, we know when we are not going to, control the blood pressure, what are the end consequences? In our clinical practice. What is hypertensive heart disease? I think a PG is also here. There is a characteristic finding of hypertensive heart disease, concentric hypertrophy of left ventricle, LA enlarged, high end filling pressure, LA index volume is high. So what does it mean? Same patient coming with a characteristic history of shortness of breath and chest pain, when you are getting the angiogram of the same patient, might their epicardial count is normal. Now patient is telling, doctor, then why you are giving medicine in vascular medicine, this metabolic modulator, my angio is normal. The question arises here, you don't have to see this microvasculature in the hypertensive patient. So this is a mandatory that from the day one, you should be think of their vascular tree. That is a very mandatory. While investigating the patient of the hypertension, ECG is the very basic tools, and that is not sufficient. So you should be go ahead beyond the ECG. Different level of classification, our audience no need to discuss CS. Important is to control well different sometimes while we becoming the puppet of different guidelines, I am using terms puppet, we doctor confuse, leave for the patients. So you make one clear cut crisp idea in your mind. If my patient is having risk factor, have risk enhancer, the BP should be around 130/80. If patient is a frail, okay, it is 140/90. Less than the 130/80 around it is up to different risk factor and the risk enhancer. So if you see right now, if you see the different guideline, Indian guideline, Indian Society of Hypertension, I was also the part of that guideline, European Society of Hypertension, ACC, RSSDI. So there is a fighting in between. So no need to fight. Just guideline guide us that ultimately we need to treat the patient and minimize their complications. So if you see this guideline, whatever kind of patient, class of recommendation and level of evidence, almost 1A, 1B. So you control the blood pressure well. And that is not sufficient. Sufficient is from the day one, you reduce the severe risk. So you go for the primordial prevention, you go to screen the patient and who should be screened. You go at the individual level, family level, school level, at religious place, if you have a general population, in the same way, and how to screen to patient, primordial prevention is important. Coming to our talk today, why ARNI, when ARNI, and what is the benefit to ARNI? You remember the mechanism of action of ARNI. Suppose what we are expecting from any hypertensive drug. Suppose I am prescribing A once a day. So what we are expecting? That drug should have effect on the preload. That should have effect on the afterload. That drug should have reduced the cardiac output. That drug should have effect on the heart rate. Blood pressure is the arithmetics of cardiac output, and cardiac output depend on stroke volume and heart rate, and then afterload. So you should be work on three axes. You reduce stroke volume, you reduce heart rate, and reduce afterload. And where we are standing with this ARNI, if you see the mechanism of action in the HFrEF patient, what this causing? This reduced preload. This causes mechanistic benefit in the LV myocardium. This reduces so long this pressure on this cardiomyocytes and reducing NT-proBNP level. This reduces afterload. And if you see the different marker of inflammation, this significant cause reduction is different marker of inflammation. And above all, what came in Paradigm HF trial? Paradigm HF trial was failed in the higher range of ejection fraction. But if you see the mid-range of ejection fraction around 50%, this causes reduction in the LV mass, especially in the female subset of population. Mind my word, female subset of population, and this significantly causes a reduction in the LA index volume and filling pressures. So if we are discussing for the hypertensive heart disease, what we are expecting from that medicine? This drug has some significant effect on the vascular endothelium. This reduce preload, this reduce afterload, having favorable outcome on the heart rate. This causes reduction in the different inflammatory marker, reduction in the filling pressure, reduction in index volume, and reduction in the relative wall thickness, LV mass. So this is drug going to fulfill all these conditions. So this is proved by a different authority, but the issue is when we are discussing somewhere, we are usually quoting European society and American society. Might be we are more fan of that society. This is true, but this drug have done with the trial with these Asian countries and this with the Japanese and China population, and they have started to use in their guidelines in the high risk patients. One thing, if you see this meta-analysis, almost in all the patient, in the meta-analysis, there was using olmesartan, and if you see there was ease with the acute valsartan as compared to valsartan. If there are different type of blood pressure, different position of mean arterial systolic blood pressure, sitting diastolic blood pressure, ambulatory blood pressure, office blood pressure. So in all this variety, there was a little bit ease with acute valsartan as compared to olmesartan alone. So coming in the mind, why not to use? But one thing, I think that those audience here sitting, I think no one using ARNI in 200 and 400 milligram. Usually you are using 50 to 100 milligram in divided doses. But in all this trial, if you remember, the minimum dose of ARNI as an antihypertensive agent was quite high. It was 200 milligram, optimal was 400 milligram. Then they was able to get a desirable effect for the blood pressures. Mechanism of action, we know this is neprilysin inhibitor, and ultimately this has favorable effect, and when this is active while giving this fragment of this acute valsartan, ultimately you are able to get decreased renin secretion, decreased blood pressure, improve endothelial permeability, decrease hypertrophy, decrease fibrosis, and decrease sympathetic outflow. So, I mean, we know how to reduce this heart rate by these medicines. So, on the same time, this causes two things. Not only sympathetic outflow is responsible for the heart rate. Diuretic is responsible for reducing the heart rate. Whenever you are going to reduce the filling pressure, LA index volume, and you are reducing the pressure of this pulmonary veins, you know that is a very important cause of low atrial fibrillation in hypertensive heart disease, 18 to 20%. Then again heart rate is reducing. So by reducing sympathetic tone and reducing the preload, there is a wonderful reduction in the heart rate also with these medicines. So this causes reduction in ambulatory blood pressure as compared to placebo, significant decrease in the pulse pressure, and in the same way there is significant reduction in the sitting diastolic and systolic blood pressures. So there are different trials with these molecules. So one was important with the parameter trials, and this shows that, and what the key secondary endpoint, the significant reduction in the observed in the clinic systolic blood pressure, and that was statistically significant as compared to placebo. So but here next data I will see you as comparison to olmesartan. This is a parameter study. That was an important landmark study, and this was the reason behind that we can use as antihypertensive medication. With olmesartan 40 milligram, usually you are using this once in a day, and added medicine is the second and third line medicine with the calcium channel blocker and this diuretics, and there was head-to-head comparison was done and at a different time interval, and the primary endpoint was at 12 by acute valsartan reduces central aortic pressure better as compared to olmesartan. But usually we are not looking central aortic pressure in our practice. The important is to see the brachial pressures. Now coming to in the elderly patient usually BP is a concern and frailty is a concern. But you know this is medicine not like SGLT2 inhibitor, the frailty. This you can use while optimizing a dose, keeping in the mind their side effects. Coming to some Asian population, because you know some the racial discrimination is there. So in the Asian patient also, if you see the data regarding this different mean arterial systolic blood pressure, sitting blood pressure, then standing blood pressure, and then night time and daytime, in all, and if you see this little bit difference and little bit ease while using this olmesartan and activity as compared to olmesartan alone. Regarding adverse effect, hyperkalemia is very important while we people using the ARNI. So if you compare the different ARB, hyperkalemia is a lesser amount while using together because this has a favorable effect on the kidney also. So, so hyperkalemia incidence is a little bit on the lower side as compared to ARB alone. Coming to resistant hypertension, this is a concern of the HFpEF. You know, HFpEF, if you are dealing HFpEF, there are 3-4 diagnoses, then we are going to see it is HFpEF. There should be some structural changes in the heart, concentric hypertrophy of left ventricle, injection index volume, increase filling pressure, and that is not ultimate. Right now, there is latest guideline that you should be go and see the LA, this spectral tracking strain imaging, and there should be reduction in the LA strain and reduction in the GLS strain. So, when we are not going to optimize our treatment, the resistant hypertension, refractory hypertension, so what is the next? Because our patient is already having a severe risk. LA usually dilated massive hypertrophy. So this is a drug where you incorporate in that kind of patient and you are having desirable effect with the wonderful outcome in terms of, we know there is a reduction in LV mass, reduction in the filling pressure, and we are supporting so many data that this molecule, when you start to use ARNI, their LV dimension was huge like balloon, and it was 7.5, 7.8 like this, and right now after 3 years of the follow-up, this LV is shrinking with a normal dimension, ejection fraction looking the normal. So this is the magic of these molecules. So many trial is there. The issue is while using this, around 30% of people able to control BP by 8 weeks. That is the more important, and you start reducing the complication in terms of reducing. How many of us, while dealing with this hypertensive patient, we are getting and asking their cardiologist, please mention their filling pressure and what is the time of starting and how it is going to behave in the future. So this is important while you are dealing with the patients. So this might be my last slide. What we are getting from ARNI? This causes diuresis and natriuresis. This decrease salt sensitivity, decrease sympathetic outflow, decrease vasoconstriction, decrease renin secretion, decrease arterial stiffness, reduce afterload, and reduce CV fibrosis. Not mention few things here, and the hypertensive, that is, believe me, very important. If you see the data that how LA, this hypertensive, LA index volume is a very important, and this is a molecule in 12 to 24 week. If you are using and optimizing your blood pressure, this causes reduction in LA index volume around 20%. That's the one criteria for this diagnosis of the HFpEF. And there is a reduction in LV mass also. So this molecule is supposed to be a wonderful molecule for using patient with the blood pressure, not alone those who is having the high risk patient, and that is not going to control while in the refractory or resistant hypertension while using the 3 drug with optimal dose of diuretics. Keeping in the mind there should be no genuine contraindication of the ARNI, genuine contraindication, you know it. I think so. This is all from my presentation. I try to make it simplified. Thank you for any comments and questions.
Thank you very much, Dr. Ansari. Great masterly talk as usual. I have been listening to you for last 10 years. Excellent talk. Definitely, ARNI in hypertension is upcoming indication. And in few years, I think next year, the data will be available, the research will be available to use ARNI in hypertension. ARNI has become a pillar point in treatment of heart failure in any form. So thank you very much for apprising us the use of ARNI in hypertension. Thank you.
Thank you, sir. Thank you.
Thank you for the insightful presentation, sir. Now, I'd like to call upon Dr. Kavaljeet Singh, Associate Professor and Head, Department of Urology and Renal Transplantation, AIIMS Bathinda, for his lecture on renal transplantation, what doctors should know.
Thank you so much. I would like to thank Dr. Vitul for providing this opportunity to present a talk. I still remember the day we got a transplant license. I received a call from Dr. Vitul. Okay, we should have a talk regarding the transplantation. What is the basics? So I will just try to keep it as basic as possible and a concise one. We all know the CKD stages.
and CKD5 when GFR is less than 15 ml per minute. And that is where we label the patient as ESRD, end-stage renal disease. And that is where the renal replacement therapy in the form of hemodialysis versus the kidney transplantation, it actually intervene. Most common cause of ESRD, we all know diabetes. India is a diabetes capital of the world. Punjab is leading in India. Second most common cause, hypertension. And other causes include glomerulonephritis, pyelonephritis, obstructive uropathies, polycystic kidney disease, and other vascular diseases. Causes of death in ESRD, most common, heart disease, sepsis, and stroke. Renal replacement therapy, just a quick one. We know it is of two types, dialysis versus kidney transplantation. Dialysis can be peritoneal dialysis, hemodialysis. This is just a pictorial picture. What is hemodialysis? What is peritoneal dialysis? We all know. I will not go into details of these slides. Indications of dialysis, just a quick review. Refractory hyperkalemia more than 6.5, when urea more than 50 millimole per liter, refractory metabolic acidosis, and other end organ damage like pericarditis, encephalopathy, neuropathy, and refractory volume overload, etc. Again, peritoneal dialysis, we all are aware. I will not go into details. It was just for the documentation purpose. This is the slide I want to focus more on. Why transplant? Why not dialysis? So the advantage is the transplant, especially when done as a preemptive transplant without any dialysis in between, it improves the life expectancy. It improves the quality of life. Transplanted kidneys, they produce erythropoietin and hence reverse the anemia associated with the chronic kidney disease. Better exercise capacity develops for the patient. It frees, of course, from the patient of burden of the dialysis and the complications which are associated with the dialysis. And of course, if we see a long-term data, it is more cost-effective compared to the dialysis. Rationale, no fluid or dietary restrictions. Of course, pregnancy is possible after a successful kidney transplant. And life expectancy is better in transplant population. 5-year survival is more than 85% compared to less than 50% of the patient who are on dialysis. The longest kidney transplant survival patient is from PGI Chandigarh, who is more than 38 years now after kidney transplant. Just a glimpse of the legal authority. This is the act which controls the kidney transplantation. This is the Transplantation of Human Organs and Tissue Act, that's called THOTA. It was in 1994 that act was passed, but there have been many modifications that has happened. 2011 was the recent modification that was done. This act defines various terms such as brainstem, death, donor, hospital, etc., providing clarity in the legal proceedings related to organ transplantation. Of course, it regulates the removal, storage, and transplantation of human organs and tissues, and it prohibits the commercial dealings and mandates authorization for the transplantation. There is a committee that is called Authorization Committee that is constituted or recommended under this act, which mandates the establishment at the state and the national level, and these committees, they oversee and regulate the organ transplantation procedures, ensuring the compliance and the ethical standards they are followed. And of course, the penalties are very strict. You must be, listening these days on and off that the penalties that are the consultants or the doctors they face who doesn't follow the legalities of this act. Just to name, this act comprises 3 main regulatory bodies. One at the national level, it is the NOTO. Then at the regional level, this is the SOTO, State Organ and Tissue Transplant Organization. And then it is ROTO at the regional level, ROTO, and it is State Organ and Tissue Transplant Organization, that is SOTO at the state level. NOTO is the apex body that is located in the New Delhi, in the capital. And it regulates, it mandates the legalities or the framework that is there to be followed for the kidney transplantation. And ROTO, Regional Organ Tissue and Transplant Organization, that is for us, it is in Chandigarh, it is in the PGI. And the state, SOTO, in our state is in GMC, Patiala. Selection of patient's recipient is very important when we talk about the kidney transplantation. And it is age as per se is not a contraindication. Previously, there were the criteria in which age more than 60 was contraindicated, but these days, more than 60 extended criteria donors, they are eligible for kidney transplantation. And uncontrolled infection and malignancies, they are still the contraindications, and malignant disease should be deferred for a disease-free period of minimum 2 years before proceeding for the kidney transplant recipient. Absolute contraindications: active IV drug abuser, active systemic sepsis or transmissible disease, unreconstructible vascular disease, significant psychological barriers, malignancy, of course, within 2 years, minimum 2 years we take it. And exceptions for the malignancies are when they do not metastasize, that is primary brain tumors, non-melanotic skin cancer, and in situ CF cervix. When we select the patient, of course, we do the color Doppler for the vasculature, because there are the one where we have to anastomose the transplanted kidney. Urodynamics, to be sure that the bladder of the patient is working properly so that the transplanted kidney doesn't face any issues related to the bladder. And patients should be listed in transplantation preemptively. That is, it has been seen in the long-term data that preemptive kidney transplant has more success compared to the transplant which happens after the hemodialysis. And in the polycystic kidney disease, I will have another slide on this. When the size of the kidney is large enough that we cannot place the transplanted kidney into the iliac fossa, then we do pre-transplant nephrectomy and PCKD. This is the slide which depicts what are the indications of removing the native kidneys in the transplant recipient before we transplant a donor kidney. The proteinuria, which is not controlled by the medical management, anti-GBM antibodies when they remain persistently elevated, recurrent pyelonephritis resulted in the recurrent sepsis and hospital admissions, ADPKD, of course, when they extend, the kidneys are large enough to extend up to the iliac fossa and we need a space to place the transplanted kidney. Stones, symptomatic stones, which cannot be cleared in the PCNL, we have to remove the kidney. Tumors, of course, high grade with or without autosomal recessive factor, and bilateral VUR grade 4 or 5, which is actively resulting in the UTI, we need to remove those kidneys. There are a risk of recurrence in the allograft when it is transplanted in the primary in the patient, and the recurrence includes the primary diseases, that is hemolytic uremic syndrome, MPGN, membranoproliferative glomerulonephritis, primary oxalosis, primary focal segmental glomerulosclerosis, Fabry's disease, myelofibrosis, IgA nephropathy, to name a few. They have a high chance of recurrence. But ADPKD, cystinosis, renal dysplasia, and Alport syndrome, without anti-GBM, they have less chances of recurrence. Now the donor selection. Donor selection, more than 60 age donors. Earlier, they were not recommended as per the law, but now they are part of extended or expanded criteria donors. So, depending upon whether comorbidities are there or not present, age more than 60 can be accepted as a donor. Age 50 to 59 with 2 or more risk factors, that is hypertension, elevated creatinine just before the recovery of the organ, that is 1.5, and death from a stroke. Standard criteria, of course, less than 60, that is 18 to 60. The mean waiting time for kidney transplantation is on an average in India around 3 years. And there are shortages of other organs like heart, lung, liver, and pancreas. Disease donors, of course, the donors are of 2 types, live donor and disease donors. And the disease donors are usually the brainstem dead donors that we accept as the donors. And live, of course, they are related or first degree relatives and, of course, the wife. Some of these stats. Disease donor kidney transplant, it is clearly showing that in India, in 2022, 1,541 disease donor kidney transplants has happened. It is increasing day by day as more and more institutes, they are starting doing the cadaver transplant. And compared to the live, they are 10,164. Majority of disease donors, they are being done in South India. In PGI, it's a very good program in disease donor. And live organ transplantation, majority is successful, or majority people are doing in North India side. Now, what is the advantage of live donor over a cadaver donor? It is definitely a healthy individual, which is without comorbidities. rigorous assessment process is there, and there are, organ functions immediately after transplant. Of course, the kidney starts because it's a functioning kidney that we have taken compared to the cadaver in which, the patient is the brain dead, and we don't know when actually the kidney will start functioning. And long-term outcomes are definitely superior. Already I discussed that preemptive transplant is better when it is done without starting on the hemodialysis. Similar, already I have discussed that what are the advantage of, the live donor over a diseased donor. Components of live donor. Of course, when it comes to the donation of the kidney, there are many components that come to the picture. Of course, the primary, the main, the star, the center of attraction, the main person who start, the thinking about the transplant is a nephrologist, because the patients, they are landing up for the dialysis with the nephrologist. And he then plans about the kidney transplant, which patient actually is suitable, Then, of course, other factors, of course, transplant surgeon is required. Social workers which counsel the patient, financial counselors, we need to see whether the patient can afford it, although these days in many government institutions, there are different funds that are there to support the patient for the kidney transplantation. Psychologically, the patient has to be counseled. This is a very, very important counseling. Psychologically, the patient has to be counseled about, the effects of transplant, what will be the effects immediately. Kidney might not function. There may be a risk for hyperacute rejection. There may be a risk for acute rejection, and patient has to take the immunosuppressants lifelong. Patient has to be prepared psychologically for all these things. So psychological counseling is one of the most important. So it's a multidisciplinary approach, not a single approach. So multiple departments, they involve in this. If ladies are there, gynecology is very important. The counseling is very important. Of course, now the evaluation, how we evaluate, we start with the history. Of course, detailed health questionnaire about the patient, donor education consent, multiple vital signs are taken, definitely evaluation by the mental health or psychologist is done. Psychological evaluation, already I have discussed that it is the most important. Then family pressure or financial incentive to donate should not be there. This is the main crux of the act that I was discussing. So this thing, that family pressure or financial incentive, if this is there, then there is a problem. So these two things has to be ruled out. That is why there are multiple steps, the multiple committees, multiple legal committees are there. They check for the documents of the donor, whether it's a real donor, it's not a faking donor, and there are there shouldn't be any hidden information that should not come up, because these are the problems that are faced later on, and that lands you in a legal trouble. Components, of course, the investigations that we do, we measure the blood pressure for the donor. 24-hour blood pressure monitoring is there. 24-hour urine assessment is there. Recently, we have started, evaluating the patient, the donors, because we are sooner going to start the transplant here. And we got a donor who had recently diagnosed hypertension. Ideally, the recipient is very good, a young age female. The donor is found to have a hypertension which is newly diagnosed, and 24-hour urine protein was more than 3 grams. But this was newly diagnosed. We treated the patient, and after 3 months, almost now the proteinuria is gone, and it is listed as extended criteria donor with us. Diabetes has to be ruled out. Metabolic workup, of course, ABO typing. The general normal profile like ECG, chest X-ray, cross-match, HLA, I will discuss in few slides. So these are European Association of Urology 2024 guidelines on live organ donation, and it recommends that strong guidelines are there regarding determining the ABO blood group and HLA antigens in all candidates of the transplant. Test both the donor and recipient for HLA DQ, and other guidelines also very strong. I'll just quickly skip it and go to the other slides. Matching donor, of course, very important. This is the slide that I want to focus. So this is the HLA typing. We all know there are 2 classes of HLA, 1 and 2. And the loci for 1 are HLA A, B, C, and for 2 are D, P, R, and Q. And most important that we have to work up is A, B, and D, P, Q, and C. So each HLA locus that we have has 2 genes. So this is how we match them. 000 is the mismatch, that is the ideal one, which is we actually want, and 2 to 2, that is we write it as 0/6 mismatch or 6/6 mismatch. So the higher is the number of the mismatch of these three genes, the higher chances of rejection are there. So 0/6 mismatch is the best one that we should get. ABO, of course, these days, the importance of ABO matching, of course it is there, but still these days the immunopathology has improved so much that now ABO incompatible transplants that are being held. And my next slide is depicting this ABO incompatibility. How we are going for ABO incompatible? Basically, we desensitize these antibodies. And rituximab anti-CD20 drug is started day 28 before the transplant, and at the 3-4 days before the transplant, and of course 1 week after the transplant, we go for plasmapheresis. And the tacrolimus and the other immunosuppressants that are commonly used, they are started on day 0. And of course, the IVIG or basiliximab is given at D0. So this is the desensitization protocol which helps us perform the ABO incompatible kidney transplantation. In the live organ donation, continuing, we have to rule out the infectious diseases like HIV, hepatitis B and C, and syphilis, TB, and other diseases as per the region. Of course, malignant diseases we have to rule out as per the age, and PSA for the prostate cancer, and other for the gynecological examination we have to go for pap smear, colonoscopy, mammogram, and 2D echo and PFT CTs to rule out any malignancy. Donor and stones, I told you we have to clear the donor first of the stones before starting with the transplant. It's important. Donor and hypertension, there are different criteria. These days, we have some extended criteria that a patient who is hypertensive on 1 or 2 antihypertensives can be taken up for the as a donor. Donor and albuminuria, I just gave an example that newly diagnosed hypertensive patient with significant albuminuria, it was treated and the patient is now labeled as extended criteria donor. Donor and pregnancy should not donate while the patient is pregnant and should not be excluded from donation solely because they desire to conceive children, may be acceptable if their long-term post-donation risks are acceptable. Malignancy, of course, 2 years malignant-free survival can be acceptable. Marginalized donors, of course, those donors who have diabetes, hypertension, coronary artery disease, they are obese. This family history of kidney diseases, endocrine disorders, respiratory disorder, neuropsychiatric disorders, and skin cancers. They are labeled as medically marginal. This is our checklist practice that we are adopting for the donor details. The basic details are there. All demographic profile is noted. Of course, the comorbidities are noted. And in the lower end, cardio, pulmo, anesthesia, psychiatry, urology, these are very important counseling, and the fitness from these departments is very important. And of course, the basic profile is done. We go for ultrasound, we go for CT, angio for the donor to look at which side kidney we want to take depending upon the vasculature, arteries, number of arteries in the donor kidney, 1 or 2. Majority of times we prefer the left kidney because the left renal vein is longer in length on the left side compared to the right. And we do DTPA to see the absolute GFR and the percentage of function on the both kidneys, and better kidneys left with the patient, with the donor, and relatively less functioning kidneys taken up for the transplant. Of course, the infectious profile and the clearances are very important. This is the medical fitness certificate performer that we are using. It is there on the SOTO site. My next 3-4 slides I'll quickly go through. This is basically for the surgical aspect, how we do. Majority of time I told we take the left side of the kidney and we transplant into the patient's right iliac fossa, where the renal artery is majority of time transplanted end to side with the external iliac artery, and renal vein with the external iliac vein, and ureter with the native bladder. Live donor surgery, majority of time donor surgery these days, everywhere it is done with the laparoscopy, and it is best to retain the best kidneys left with the donor, already I have discussed. This is more of surgical that we prefer, majority of time we prefer the left side because left renal vein is important, but sometimes there are multiple renal arteries on the left side, so we have to take up the right side. In the right side, if we are taking, the vein size is small, so in that case, what we do is after we have mobilized the kidney laparoscopically all around, we open up the patient and we take a patch of the IVC with that to improve the length. Recipient preparation, majority of times it is supine position, and of course Gibson incision is there. Under GA we do, it is Gibson incision, inverted Hocking incision in the right iliac fossa, and kidney is placed in right iliac fossa. In the left side, indication is when already a patient has undergone one transplant, it has failed and there is no space on the right side, and the patient is undergoing second transplant, we place it on the left side. Retroperitoneal surgery, already I have described that the vessels, how majority of time it is anastomosis, arteries are and veins are anastomosis to the external iliac. Internal iliac is used more commonly when there is accessory renal artery alongside. Reperfusion, this is more of a surgical. After we do ureteric, it is anti-reflex Lichgroig operation that we mostly do. This is the surgically, I have explained what I have explained. This is the Gibson incision that we do on the right iliac fossa, and inverted hockey stick incision. And this is how we open the external oblique aponeurosis and rectus sheath. We don't divide the muscle in this, and this is how we reach the retroperitoneum, and we apply the sling around the vessels. And inferior epigastric vessel, this is the yellow line, this is preserved because any accessory renal artery is there, we can anastomose it with the inferior epigastric. And this is how the vessels, these are the vessels shown. We hook these vessels with the slings and we dissect them, and this is clear. This is how we denude the external iliac vein, external iliac artery, divide the tributaries, clear very clearly with the cautery so that later on lymphocyl chances are very less. And this is how, when the multiple arteries or multiple veins are there, how we cut off the patch and how we, this is more of a surgical aspect. And this is how the transplant kidney look like when we have anastomosed. This is here, we have anastomosed the kidney end to end on with the internal iliac artery, but majority of times we prefer it on the end to side. This is more of technicalities how to do. And how long a transplant can be expected to last. I already told you the longest living transplant recipient is more than 38 years of transplant. The patient is in PGI Chandigarh, hale and hearty. Recently I have attended a conference by the Noto in Delhi, and that patient was called there and he's hale and hearty. So this is just right. So I end my talk that kidney transplant is a boon these days to the patients, and it should be taken up as a preemptive manner before the hemodialysis, so that the patient have a good hale and hearty lifestyle, with a quality of life. Again, I thank you so much, Dr. Vitul and MAPICON, for inviting me for the talk. Thank you so much.
Excellent talk. Basically what you have showed is really, really important, as we are also being aware by your talk that what physician should know, beautifully depicted. I learned so much, after reading so much about renal transplant, but your masterpiece is real educative, and we are going to distribute your lecture on YouTube to everyone, every physician, so that he should know the basics, what renal transplant is, how the donor is selected, and how it is being done. Graphic representation was beautiful.
Right.
Thank you very much.
Thank you so
and
much.
I must appreciate your efforts also to bring this region on the map of renal transplantation. Because of your efforts, AIIMS is being recognized as a center for renal transplantation.
Thank you so much.
Thank you
sir.
very much.
Equal credit goes to Dr. Saurabh sitting, nephrologist. I told you nephrologist is the center
So
stone
please.
of any transplant
हो जाओ यार,
program.
acknowledge करेंगे आपको
He is the main person.
Great.
Right. Thank you so much.
Thank you.
Thank you so much, sir. It was incredibly insightful. Now it's time to turn our attention to Dr. Amandeep Kaur, Associate Professor, Department of Medicine at AIIMS Bathinda, for a presentation on topic PUO, Reveal the Unrevealed.
Good evening, everyone. First of all, I would like to thank Vitul sir for providing me this opportunity to present at this prestigious platform of MAPICON. So my topic of talk today is paraxia of unknown origin, also known as fever of unknown origin. First of all, coming to the definition. Now, it is defined as a temperature of 101 degree Fahrenheit or 38.3 degrees centigrade or higher with a minimum duration of 3 weeks without an established diagnosis after an intensive 1-week investigation in the hospital. Now, nowadays, there has been a slight change in the definition. That is, the 1-week inpatient investigation is no longer required. So, we will be describing the workup, we will be outlining the causes, summarizing the treatment, and we will review the importance of improving care coordination among the interprofessional members to improve the outcome for patients. The causes of fever of unknown origin are often the common conditions which are presenting atypically, and the list is extensive, that is around more than 200 causes. Broadly, we will be classifying it into 4 categories, that is the infections, then non-infectious inflammatory conditions, followed by malignancies, and lastly but not least the miscellaneous causes. Now, out of these, the infection is the most common cause comprising around 40%, followed by malignancy, that is 25%, autoimmune diseases constituting 15%, miscellaneous 10%, and there are around 10 to 15% of the cases of FEO which remains undiagnosed. Among the infectious causes, we have the tuberculosis, extrapulmonary tuberculosis, brucellosis, HIV infection, abdominopelvic abscesses, cat-scratch disease. We have viruses like the cytomegalovirus, Epstein-Barr virus, toxoplasmosis, enteric fever. We can further classify it into organ-based infectious causes, tick-borne infections, and regional infections. Now, organ-based, like there can be a subacute bacterial endocarditis, sinusitis, mastoiditis, parotitis, vascular graft infections, Whipple's disease, then tick-borne infections like babesiosis, anaplasmosis, tick-borne relapsing fevers, and in regional infections like we have leptospira, rat bite fever, louse-borne relapsing fever. Coming on to the non-infectious inflammatory causes, mostly these are the autoimmune causes like the giant cell arthritis, SLE, rheumatoid arthritis, gout, pseudogout, Behçet's disease, sarcoidosis, Felty syndrome, Takayasu, Kikuchi disease. These are all the non-infectious inflammatory causes. Third, we have the malignant and the neoplastic causes, which comprises of lymphoma, renal cell carcinoma. We have the myeloproliferative disorders. We have the carcinomas of breast, liver, pancreas, colon. There is an atrial myxoma. There can be a metastasis to the brain or liver. And we have the malignant histiocytosis. Then there are certain miscellaneous causes like the drug fever, thyroiditis, Crohn's disease, pulmonary embolism, hypothalamic syndrome, cyclic neutropenia. Then there is another term, that is the factitious fever. Then there is another classification, that is the Durek and the Streets classification, according to which we classify it into 4 different types, that is the classical, nosocomial, neutropenic, and PU associated with the HIV infection. Among the classical, the frequency of each category varies by both time and location. Endocarditis, complicated UTI, abscesses, and tuberculosis are the most common cause. In patients over the age of 65, the connective tissue diseases, these are to be determined the cause of fever more frequently. And fever in travelers is likely to be secondary to the infections such as malaria, typhoid, and acute HIV. Nosocomial, that is the healthcare associated fevers, which can be due to the drug fevers, due to complications post-operatively, venous thromboembolic diseases, malignancy, post-transfusion reactions, and the Clostridium difficile infections. Then neutropenic fevers are common in this subclass, and they're most frequently due to the infections. HIV-related FPO, the fevers can be present during the acute illness. These are common in the setting of untreated infection, and there is additional infection with the opportunistic organisms. Now coming on to the history and the physical examination. There is no clear-cut diagnostic approach, and the key to pinpoint the origin of FU is the thorough history with a focus on the most probable etiology based on the patient's symptoms. The important aspects of history includes the family history, immunization history, dentition history, occupational history, nutrition and weight history, drug history, that is the use of over-the-counter medications or illicit drug abuse, sexual history, recreational habits, animal contacts, and history of any surgery, trauma, or any of the procedures. Now, the most important clue which can give us is the fever patterns. As per the fever patterns, we have three, that is the intermittent, continuous, and the remittent fever. Intermittent fever means any fever which is characterized by intervals of normal temperature. Continuous fever means temperature remains above normal throughout the day and does not fluctuate more than 1 degree Celsius in 24 hours. Then we have the remittent fever, that is the fever pattern in which the temperature varies during each 24-hour period but never reaches normal. Certain other fever patterns, like there can be a tertian or quartan fever in malaria, undulant fever, brucellosis, tick-borne relapsing fever, borreliosis, palabstin fever, Hodgkin's disease, periodic fevers in case of cyclic neutropenia, and double quotidian fever in adults' disease, malaria, and typhoid. So first of all, coming to the infectious causes, what history and physical examination is important in infectious causes? There is a history of any prior invasive procedures or surgery, history of exposure to the tuberculosis patient, pet contacts, mosquito or tick bites, rodent exposure, history of any blood transfusion, and history of use of immunosuppressive drugs. If there is a history of exposure to unpasteurized dairy products, then it gives us a clue in favor of brucellosis, cow fever, and Yersinia infection. If the patient has a contact to birds, then there is a more likely infection of chlamydia, psittaci. Exposure to cats gives us a clue towards the toxoplasmosis or a cat scratch disease. HIV and disseminated gonorrhea in travelers and sexual encounters without barrier precautions, and acute Epstein-Barr virus infection should be suspected in the daycare centers as it spreads very easily. Now, in cases of malignancy, there can be a history, patient gives us a history of malignancy, history of any unintentional weight loss. As per that, we must go for an age-appropriate cancer screening. There can be a history of family history of malignancy or history of any alcohol use or smoking. Then there are certain physical examination points which can give us a clue towards the malignancy, like if there is a relative bradycardia with a long-standing history, it goes in favor of lymphoma or central nervous system malignancy. If there is a new heart murmur, we can go towards the atrial myxoma. Sternal tenderness gives us a clue towards the myeloproliferative disorders, and even an isolated hepatomegaly with FPO can give an evidence of hepatoma or liver metastasis. Coming on to the non-infectious causes. Now, important point to remember is that rheumatological etiology is less likely if a patient reports symptoms of rigors and chills. It goes more in favor of the infectious causes. So, collagen vascular and autoimmune diseases can manifest as FUO even before the presentation of muscle and joint pain or stiffness or oral ulcers. The fever distribution analysis should be done in these patients, like if there are morning fevers, it goes more in favor of periarteritis nodosa, whereas if there is a double quotidian, it goes more in favor of the adult Still's disease. Now coming on to the investigations, we will be dividing it into the non-invasive and the invasive part. Earlier we used to have 4 stages, stage 1, 2, 3 and 4, but now we will be dividing it to non-invasive and invasive. In non-invasive we have all the routine basic investigations like the complete blood count with differentials, complete metabolic panel, urine analysis with urine culture sensitivity, blood culture sensitivity, preferably 3 sets of blood cultures should be sent, chest X-ray, inflammatory markers such as CRP, ESR, LDH, creatine phosphokinase, then autoimmune markers like ANA, rheumatoid factor. We can go for a cytomegalovirus, IgM or PCR, then tuberculin or Monton test, IGRA, HIV immunoassay, CT scan of the abdomen and chest, and last we can go for a cardiac echocardiography if we are suspecting a atrial myxoma or there is a culture negative endocarditis. Now coming on to the invasive test. Now invasive tests are to be performed as per the differentials, and the most common are the bone marrow biopsies, biopsy from the liver, epididymal nodule or temporal artery, which can give us a clue towards any malignancy, infection, myeloproliferative disorders or the other inflammatory conditions. Then we can go for an upper GI or a lower GI and retrograde cholangiography as per the involvement of the GI tract. And then third, we have the nuclear medicine test. Earlier, the nuclear medicine tests were reserved for those patients in which the diagnosis was not confirmed even after the thorough initial evaluation. But now it has been seen that in certain European studies, they are saying that FDG PET or CT scan should be done at an early if we are not able to find a cause, because these are highly sensitive, it is a non-invasive technique, and it can further guide us about the biopsy or aspiration. Then there are certain other studies like leukocyte labeled studies, gallium and indium labeled leukocyte studies. Now coming on to the treatment. Now no single standard FVO management protocol is present, but we should avoid the empiric antibiotics or the empiric glucocorticoid treatment if not necessary. But there are few exceptions. That is, we can start with the empiric antibiotic treatment or the empiric glucocorticoids if the patient has presented to us with a culture negative endocarditis, cryptic disseminated disease, temporal arteritis with suspected vision loss. Then there are certain specific examples like steroids have been mainstay of treatment in autoimmune diseases like giant cell arthritis, polymyalgia rheumatica. In case of drug fever, it is the best to discontinue the implicated drug, and we will be seeing that the patient is afebrile at least after 2 days of discontinuation of the drug. Then there is a naproxen test. I think nobody of us is very well aware of this. It's used to differentiate, that is, the infectious and the neoplastic etiologies. But this test is not specific enough to be useful for all the individual patients. Coming on to the prognosis, it has been seen that around 15% of the cases remain undiagnosed. Prognosis for patients with FEO is generally good. It will resolve spontaneously within weeks to months. In stable patients, for symptomatic management, we can go for the non-steroidal inflammatory drugs. Poor prognosis has been reported in elderly patients and those who have been diagnosed with a malignancy. And even in children who do not have a particular cause, eventually do better more as compared to the adults. Now, most important is the patient education. That is, patient is all the time very worrisome that why is the fever persistently coming and coming. So, the patients should work together with the providers by providing a thorough history to aid in the directed diagnostic testing. So the take-home message is that it is one of the most challenging diagnoses. It requires a thorough history, repeated physical examinations, and selective diagnostic testing. We must avoid a shotgun approach early in the diagnosis of FEO, and an interdisciplinary approach is important. Thank you.
Thank you, Dr. Amandeep. You have made this very complex problem very simple with beautifully explained flow how we should investigate the fever of unknown origin. Thank you very much. Thank you.
Thank you for the informative presentation, ma'am. Now let's turn our attention to Dr. Saurabh Nayak, Associate Professor, Department of Nephrology, AIIMS Bathinda, to present his lecture, Common Acid-Based Disturbances, Tools and Tips.
This is a real important and very complex topic which has gone several times over my head also. Because I missed this topic in undergraduate level. I went to some conference, so I missed this topic and I will attend to this topic now so that I must learn something about acid-base balance. Thank you for choosing this topic.
So, good evening all. So, my talk of the today is common acid-base disorders. So, I will start with what is the basic meaning of acidosis. So, basically it is believed that H plus is acid and OH minus is a base. Or in another convention, anions are acid and cations are base. Now the nomenology is changed and now we don't call no more alkalosis or acidosis. We use terms like acidemia and alkalemia. So when pH is less than 7.35, it is called acidemia, and when pH is more than 7.45, it's called alkalemia. In other concept, whichever substance donates an H plus becomes an acid, and whoever accepts an H plus becomes a base. So this is the basic structure. So what is the source of acid in the body? So acidosis is just H plus accumulation in the body, which results in the lowering of the pH, and our body assess pH. We cannot able to assess the H plus concentration. So body has a system which assess pH of the body fluids. So protein metabolism generates phosphoric acid, anaerobic glucose metabolism generates lactic acid, fat metabolism generates organic acid and ketones, and carbon dioxide is produced in the tissue level when there is a hypoxia, or in normal condition also CO2 is produced. So this is the source of H plus in the body. How this acid is buffered in the body? It's by bicarbonate buffer. In one answer, it is the bicarbonate buffer which is the most important buffer of the all process. So normal pH is what? 7.35 to 4.5. So if there is a compensatory mechanism going on, then pH lies within this range. If there is acute acidosis or alkalosis, the pH goes beyond this range. So if there is an acute acidosis, there will be pH less than 7.35, and if there is acute alkalosis or alkalemia, then pH would be more than 7.45. So ICF, like intracellular space, always have a acidic media. So the pH is 7 for intracellular compartment. Interstitial space, it is 7.35. In veins it is 7.35. Veins are little acidic than the arteries, and artery pH is normally 7.40. So what are the buffers are present in our body? So we have chemical buffers which acts within minutes, within seconds they act. So these are in the blood available. Then comes the lung and respiratory centers which drive the respiratory efforts, and they works within minutes to hours. And then comes the role of kidney. Kidney has a multiple functions, which is the main function of kidney is to buffer the acids, and it works, and it takes days and 2 weeks to control the acid buffer. So hemoglobin binds the free H plus. Histidine residue present in almost all the proteins as a part of amino acid, which also binds the H plus. Phosphates, they form the phosphaturic acid, and bicarbonate forms the carbonic acids. Now, if you look into the buffer system of our body, there are intracellular buffers. Main intracellular buffer is a phosphate, ATP. So phosphate is intracellular buffer. Then we have proteins in the inside the cells. For example, hemoglobin you have in the RBCs, and you have amino acids. All proteins are can buffer. If they have histidine residue, they can buffer H plus. Then in extracellular fluid, the main buffer is carbonic acid, which is there in intravascular fluid also. And then you have plasma proteins like albumin in the vascular streams. So in summary, what I am going to tell you is there are two sources of acid in the body. One is diet, which comes from fatty acid and amino acid metabolism. Then there are metabolism in our body which produces CO2, lactic acid and ketosis. Ultimately, they lower the pH of our plasma, and then these buffers comes into play, which are chemical buffers like bicarbonate and phosphate and proteins. So then ultimately lungs will do the job, and they exhale the CO2, which is the actual surrogate of H plus. PCO2 is a surrogate of H plus, which is acid, and then kidney handles H plus efficiently. So lungs, they do the job by exhaling CO2 out of the body, which is a surrogate of H plus, and then kidney have to have multiple actions. So one of them is excretion of lactic acids, ketones and organic acid. Kidney can directly excrete those organic acids. These are weaker acids. Then urine buffers, there are bicarbonate and phosphoric buffers. And then kidney also has a tendency to excrete, distally secrete H plus. Then there are excretion of uric acid, which is done by kidney. Reclamation of bicarbonate is very important. It's the same process of acidosis, like loss of bicarbonate is acidosis production, and if you reclaim the bicarbonate, it is actually countering the acidemia. And ammonia generation. The kidney is one of the important organ apart from liver which can able to generate ammonia. Ammonia generation helps in directly excreting H plus molecule out of the body. So role of kidney is explained in this diagram in a schematic presentation. So you can see in proximal tubule ammonia can be produced. Ammonia can able to excrete H plus, and then phosphoric acid is produced. Phosphoric acid can another way to buffer. These are the urine buffers: phosphoric acid as well as bicarbonate causing carbonic acid. So in distal tubule we can able to reclaim the bicarbonate. So bicarbonate reclaiming will be creating a alkalemic media, so countering acidosis. And then you can in collecting ducts you have direct H plus secretion in alpha intercalated cells. So distal secretion of H plus through ammonia generation is happening in the alpha intercalated cells. We have H plus K plus ATPase or H plus ATPase situated, which can throw out the H plus outside the lumen, and this helps by producing ammonia, because you cannot the H plus will not go out itself. It has to bind with ammonium ion, and generate ammonium ion, that is NH4 plus. And ammonia will be created in proximal tubules from metabolism of glutamine. What is the pendrin? It's very important to understand the role of pendrin, because pendrin is situated in the type B cells of intercalated cells of collecting duct, unlike type A cells, like you can see in the diagram. So type B cells mean what will happen once H plus is excreted by type A cells, then there will be bicarbonate will be reclaimed. And not only bicarbonate will be reclaimed, chloride also will be reclaimed by alpha beta intercalated cells, and this is called as pendrin. So we excrete one of the bicarbonate ion. This bicarbonate ion will be again transferred back to the body by reclaiming in the ENAC channels and sodium potassium ATPase. So we are not losing any bicarbonate, we are reclaiming both bicarbonate as well as chloride ion. So this reclaiming of chloride is very important to understand non-anion gap acidosis. Because in non-anion gap acidosis, chloride is elevated because of reclaiming from the kidneys. So what is the anion gap and what is the concept of anion gap acidosis? So there are two kinds of acidosis, or there can be two methods to generate acidemia in the body. One is addition of an acid. Once there is addition of an organic acid, the anion gap will be elevated. And another way is to develop acidosis is losing of bicarbonate. Whenever there is a losing of bicarbonate without addition of any acid, then in this case chloride will be reclaimed from the kidney and anion gap will be maintained by rise in the chloride. So that's how we explain two types of acidemia in the body: normal anion gap as well as anion gap. So in this diagram you can able to understand the anion gap. So if you see in the picture, there is an anion gap which is actually the difference between measured cations and the measured anions. In the second picture you can able to appreciate the anion gap is mainly composed of phosphate and albumin. Now if you see this high anion gap acidosis, there is an increase in the unmeasured anion. This is because of influx of organic acid. Those are weak acids like ketones and lactates and other phosphatidic acids. So these high unmeasured anion actually becomes high anion gap. And see in this case chloride is normal. See in all three pictures chloride is 104. So there is no reclaiming of the chloride has been taken place, but bicarbonate has been reduced from 24 to 12. Now see in this diagram, which is normal anion gap acidosis, there unmeasured anion has been increased, but that has been compensated by, so there is a loss of bicarbonate. There is no addition of any acid going place in this place. So only bicarbonate is lost, that is from 24 it has become 12. Now what happens with the loss of bicarbonate? We have reclaimed chloride from the kidneys, and with the reclaiming of chloride, now chloride has become more than 104, it is now 116, and the anion gap is maintained. So there is no increase in the unmeasured anion level in this point of time. So here comes the role of pendrin to maintain anion gap. How to analyze acid-base disorders in ABG? So we cannot estimate H plus with electronic machines also. Like in our system, we cannot able to assess H plus, we assess pH. Similarly, in ABG machine, blood gas analyzer, we also cannot estimate the H plus. We assess pH, we assess PCO2, we assess PO2, we assess bicarbonate. Bicarbonate directly measured. And we assess oxygen saturation. Based on this, we apply this Henderson-Hasselbalch equation and we derive something called as buffer ratio. Buffer ratio is a ratio of base to acid. And with this, we interpret H plus. How we interpret H plus? So buffer ratio is basically base upon acid. So the bicarbonate divided by PCO2. PCO2 is a surrogate of H plus because it's an acid. So whenever there are changes happening in the bicarbonate as well as in the PCO2, the pH changes. Based on this principle, we calculate estimated H plus and pH. So this is how ABG machine works. So when the bicarbonate is lost, the pH will be reduced. That is acidemia has happened. Or when there is a PCO2 rise, pH will be reduced because it is in the denominator side. So pH will be reduced and acidemia will happen. Usually the buffer ratio is around 20:1. So can you predict H plus concentration based on ABG? Yes. So if you see the pH and if you have to take the 2 decimals of points of the pH. So if it is 7.40, the H plus amount would be 40 nanomoles per liter. If you reduce it by 7.38, that pH is reduced means acidosis has happened. That means H plus has been accumulated. So you have to add the H plus 2. So it will become 42. If you have increased the pH, that means 7.42. So the H plus has to now lost. So 2 H plus will be lost. So now new H plus levels will be 38. So similarly, you can estimate the H plus based on the pH. So now let us now see the traditional approach of acid-base disorder and how we interpret it based on ABG. It's all based on one HH equation. So primary metabolic acidosis. Let's first take this. So in primary metabolic acidosis, what's happening? Bicarbonate is lost, so pH will be reduced. So what will happen? Compensation happens in the same direction. So PCO2 will be lost. So how to lose PCO2? By increasing respiratory rate. So lungs will exhale more PCO2. Then this is the compensated mechanism. Similarly, in metabolic alkalosis, what is happening? Bicarbonate is getting accumulated. So pH is increased. Again, correction will happen at the same direction. So what will happen? PCO2 is increased. Now it's very difficult to increase the PCO2 of the body because for that your respiratory center has to be shut down and you should stop breathing, which is not common or not possible. So this metabolic alkalosis is almost never get compensated, because it is not practically possible. Now see the respiratory acidosis, PCO2 is risen, so pH will drop here. Again again the compensation will happen in the same direction. So what will happen to bicarb? Kidney will reclaim the bicarb because acidosis is happening, so it will reclaim the bicarb. And what happened in respiratory alkalosis? The PCO2 is lost because of hyperapnea. So what will happen? pH will increase and then kidney has to lose bicarb here to enable to increase the acid content of the body. So respiratory alkalosis is the most common acid-base disorder encountered in the hospitalized patient. It's very common, may be seen with psychiatric patients also. Now compensation, how fast does it occur? So respiratory compensation happens earlier. It takes at least 1 to 2 days for the lungs to compensate for a metabolic disorder, but kidney take longer, as I have seen earlier. It takes at least 5 days for kidney to completely compensate a respiratory disorder. Now here are the tips. You have a shortcut, like you cannot always follow the big formulas. So follow the pH and PaCO2. If they are following the same direction, it's a metabolic disorder as a primary event. If they are in opposite direction, pH and PCO2, then it is a respiratory disorder. Now there is another trick. You subtract the after decimal points of the pH and compare it with PCO2. If the difference is less than 15, it's a metabolic disorder. If the difference is more than 15, it's a respiratory disorder. See, for example, its pH is 7.35 and PaCO2 is 40. So the difference between 40 and 35 is 5. So it's a metabolic disorder. As you can see with bicarb, it's low. It's a metabolic acidosis case. So that was the shortcut. Now principle of compensation should be known. Body attempt to compensate to normalize arterial pH because body can able to measure only pH. But compensation never returns pH to normal. This is the principle. And patient never overcompensates. If there is overcompensation happening with the formulas, then there is another disorder coexisting. Body by itself cannot overcompensate, and compensation is almost never complete. And we have seen that metabolic alkalosis is not fully compensable disorder. Now there are compensation formulas like metabolic acidosis. There is a Winter formula which is like 1.5 into bicarb plus 8. It is actually a PaCO2 measurement with respect to the bicarbonate or lost in the metabolic acidosis. In metabolic alkalosis, what happens? Bicarbonate is accumulated, so PaCO2 will be risen. How much it is risen? 40 plus 0.7 bicarb minus 24. But here it is no need to calculate this metabolic alkalosis formula because I have said earlier it is not many times compensated. It's very difficult to compensate a metabolic alkalosis disorder. So never need to calculate the compensation. For respiratory acidosis and alkalosis, I will give you the better shortcuts than these lengthy formulas. Now compensation shortcuts for metabolic disorders. It's very simple. You just have to match the decimal numbers of pH and PCO2. If those are comparable, that means it is compensated. If they are totally different or fall apart, that means it is acute and non-compensated. See, for example, 7.27 and 25. 25 and 27 is not far apart. That means this is a compensated disorder. But the disorder has to be metabolic at least. That is the prerequisite. Now for respiratory disorder, compensation shortcuts are, I call it 14-25, like 1425. You should just remember, like for every 10 rise in CO2 for respiratory acidosis, in acute non-compensated setting, the bicarbonate will increase by 1. For chronic, it will increase by 4. For every 10 millimeter of mercury fall of PCO2 in respiratory alkalosis case, in acute uncompensated setting, the bicarbonate will fall by 2, and for chronic it will fall by 5. So 1425 can be remembered 14-25. Now I will give you some examples to crack. What are the steps to read ABG? So this is example number 1. So suppose the pH is 7.50 and PCO2 is 48. Now you know if it is a metabolic disorder, it is compensated. Okay. Now to know whether it's a metabolic disorder or a respiratory disorder, what you have to see? pH and PCO2 direction. So pH is raised and PCO2 is also raised because PCO2 normal is 40. So it is a metabolic disorder. So compensated disorder because the PCO2 and pH is 2 decimals are normal, are equal. So it's a compensated mechanism for a metabolic alkalosis is led. This is a inference what I have already told you. It's a metabolic alkalosis in this case because bicarbonate has actually risen. Okay. So these are the steps. See the 7.50, 48, it is compensated, and no need to calculate this with step 3. Suppose if we calculate also, let us go to the formula. It is 40 plus 0.7 into bicarb minus 24. Bicarbonate here is 34, so that minus is 10. So 0.7 multiplication is 7, so it's 47. So with formula also you know that it is compensated, and with the trick also you know that it is compensated. Now example second. If the pH is 7.12, what's the direction of the pH? Low, that is acidosis. What is the direction of PCO2? Again low, decrease 8 from the 40, normal. So it is a metabolic disorder. What is the disorder? Acidosis. So it's a metabolic disorder. It's very clear. But if you see the bicarb, you know that it is metabolic disorder. Okay, but by trick also it is metabolic disorder. Now let's calculate the compensation. It was for metabolic. There is no trick is telling that there is no compensation happening. See the minus 12 and 32 is far apart. So with trick there is no compensation happened, right? And now let's the formula. Winter's formula is 1.5 into bicarb plus 8. So that comes to around 22. But the actual PCO2 should be 22, compensated PCO2, but the actual PCO2 here is 32. That means there is another disorder existing which is rising the PCO2 from 22 to 32, and that is a respiratory acidosis. So with trick also we are right that the disorders is not compensated, and with formula also we can able to know that there are mixed disorders, and with a metabolic acidosis, a respiratory acidosis is coexisting. Now example 3. The pH is 7.34 and PCO2 65. So pH is dropped, that is acidosis. It should be 7.35. It is 7.34. So acidosis. And the PCO2 is risen, so it's a respiratory disorder because it has a opposite direction. And with respiratory acidosis, you know that PCO2 is very high. So now let's see the compensation happening or not. So the trick is 14-25, 14-25. So this is a compensated disorder or non-compensated disorder. Since pH is not falling in the range, it is an uncompensated disorder. You got my point? It is not 7.35 to 45. If it is 7.35 to 45, then it is compensated. If it is beyond 7.35 or beyond 7.45, it is not compensated. So this is a not compensated respiratory disorder. In this non-compensated respiratory disorder, if you apply the formula, it will come as respiratory acidosis acute. So 1. So for every 10 rise in PCO2, the bicarb should have risen from 1. So here from 40 it has risen 2.5 times. 25 हो गया, 25 add हो गया from 40, तो 2.5 times बढ़ गया. So if you increase bicarb from 2.5, it would become 24. So 24 plus 2.5 will be 26.5. So bicarbonate should have been 26.5, but it is now 34. That means a metabolic alkalosis disorder is coexisting, which is rising the bicarbonate from 6.5 to 34. So this is how we calculate compensation using tricks and the formulas. And these shortcuts are not just shortcuts, they have been now study proven. So this winter formula and the trick has been now correlated with the study. So it's not no more a trick, these are real tricks. Now there is another approach of acid-base disorders. One is the traditional approach which we have just finished. Another approach of acid-base disorder is a base excess approach, which is also called as Copenhagen approach. So this concept of base excess approach is what Copenhagen has found, that whatever is the disorder, the change in bicarbonate is the central point, because we know that bicarbonate refer is the central to all acid-base disorder, and change in bicarbonate happens whenever there is alkalosis or acidosis. So what he has done is, he has determined by various calculations which has been made by computer, that there must be some amount of strong base. If we add that amount of strong base to the blood, the acidosis is neutralized. And that amount of base excess is called as base excess, and that base excess gives us an idea about whether acidosis is happening or alkalosis is happening. So you can also standardize this base excess. These are the machines variables, like ABG machine actually gives you the actual base excess as well as standard base excess, and the standard base excess where there is a correction for ECF. These are the pictorial diagram, but I'll go you with the examples, real scenario example. So this is first blood gas is a normal blood gas. See the base excess there. I don't know whether it's visible. So the pH is 7.46, which is a normal pH. See the bicarbonate is 21, which is actually less. So there is a loss of bicarbonate, means that there is some acidosis going on. And see the base excess, it is minus 0.2, minus 2.0. So now usually base excess falls between 0 to minus 5. 0 to minus 5. So this base excess here falls between 0 to minus 5, that is minus 2 in this case. So it's a normal VBG. Okay, normal blood gas based on base excess method. If you see a patient of severe acidosis, here the pH is 6.9, very severe acidosis. If you see the VBG in detail, their CO2 is also risen to 80. So and the bicarbonate is also 12. So there is both mixed metabolic as well as respiratory acidosis going on. In this case, the base excess is minus 16.1. That means the base excess is more negative. That means you need 16 millimole per liter of strong base to be added to neutralize that acidosis. You got my point? What is the base excess theory of Copenhagen means? So in this case, base excess theory tells that there is a severe acidosis going on. Now see the third picture. pH is 7.45, which is normal. Bicarbonate here is 32, which is high. Sorry, 25, which is high. And base excess is in positive, 1.8. That means it's not normal. It's not 0 to minus 5. It is in addition. So there is alkalosis going on, and the alkalosis is diagnosed by base excess theory. So this is how this second concept of acid base works. So there are glitches in base excess. It does not work when there are mixed disorders, and once compensation has started, this theory fails, and you cannot able to actually get to the acid base disorder with this approach alone. So you have to always use a traditional approach, which I have already told. So with this, I'll stop the presentation.
Excellent talk, Dr. Saurabh. I must congratulate you. Have made this very complex topic very simple, and I will go listen to your lecture 3-4 times before comprehending all the complex things. But thank you very much. With this, I think we are coming to the end of today's session. We were 1 hour late because of 5 minutes increment with each speaker. So we will be sticking to time tomorrow.